This is day 2 of the October meeting. I'm going to try this today for as long as I can. I'm going to appreciate Dr. Wharton's assistance yesterday and probably today. We'll start off today with roll call of the ACIP members and the ex officios, and then we will move to agency updates. Please say your name, your title, if you have any conflicts again, and if you're here or not. Dr. Asturias.
Edwin Asturias, a professor of infectious disease at the University of Colorado, no conflicts of interest.
Dr. Brewer.
Noel Brewer, Gillings Distinguished Professor at the University of North Carolina and member of the Cancer Center there. I have no conflicts of interest.
Dr. Brooks.
Oliver Brooks, Clinical Professor of Pediatrics, Charles Drew, University of Medicine and Science. No conflicts. Good morning.
Good morning, Dr. Chen. I will. All right, we'll come back to Dr. Chen. Dr. Chu.
Helen Chu, Professor of Medicine and Epidemiology at the University of Washington Schools of Medicine and Public Health. No conflicts.
Dr. Sineas.
Sybil Sineas, Associate Professor of Medicine and Pediatrics at the Warren Albert Medical School of Brown University, and I have no conflicts.
Dr. Jameson.
Denise Jameson, Dean, Carver College of Medicine, University of Iowa. I have no conflicts.
Dr. Kambosh.
Minnie Kamboj, Infectious Disease Physician, Memorial Sloan Kettering Cancer Center. No conflicts.
Dr. Lair.
Jamie Lair, owner of Cougar Family Medicine, private practice in Ithaca, New York, and I have no conflicts of interest.
Dr. Maldonado.
Good morning, Bonnie Maldonado, Professor of Pediatrics, Global Health, and Infectious Diseases, Stanford University School of Medicine. No conflicts.
Dr. Moser.
Charlotte Moser, Co-Director of Vaccine Education Center at Children's Hospital of Philadelphia. No conflicts.
Dr. Schechter.
Rob Schechter, California Department of Public Health Immunization Branch. No conflicts.
Dr. Shaw.
Al Shaw, Professor of Medicine in the Section of Infectious Diseases at Yale School of Medicine. I have no conflicts. Good morning.
Good morning. I'm Dr. Talbot, Professor of Medicine and Health Policy at Vanderbilt University. I have no conflicts, and I'm ready to get started.
I want to see if Dr. Chen's on.
Oh,
She is on, but let's see if she can.
Oh, Dr. Chen. I don't have her on.
She is on Zoom.
Oh.
She may be having trouble.
All right.
And we need to do roll call for the ex officio.
Oh, yeah. Thank you. I'm like all excited to get ahead, and I've forgotten y'all. All right. Ex officios, CMS, HRSA. Do they need mics? Indian Health Service, OIDP, NIH, FDA. And Dr. Chen, I saw that you came back on. Are you able to say good morning now?
Yes, I've been here, and this is, I just heard NIH. That's the start of the voice that I heard. So I am here. Thank you.
Can you
From Harvard Hospital and Harvard Medical School.
Do you have any conflicts of interest?
No conflict of interest.
Okay, thank you, Dr. Chen. Good morning. All right.
Do we need to make sure the audio is working?
We have not heard anything until you said Dr. Chen.
Okay.
Just the members.
Okay. Okay. Technical difficulties this morning. We are now actually broadcasting live and everyone can hear us. We would like to do roll call for the voting members again. So once again, name, position, and if you have any conflicts of interest. Dr. Asturias.
No conflicts of interest.
Name and position.
Edwin Asturias, University of Colorado, no conflicts of interest.
Thank you. Dr. Brewer.
Noel Brewer, Professor of Health Behavior in the Gilling School of Global Public Health at the University of North Carolina, and member of the Lineberger Comprehensive Cancer Center. No conflicts of interest.
Thank you. Dr. Brooks.
Oliver Brooks, Clinical Professor of Pediatrics, Charles L. Drew University of Medicine and Science. I have no conflicts. Good morning.
Dr. Chen.
Good morning, Lynn Chen, Associate Professor of Medicine at Harvard Medical School and Director of Tribal Medicine Center at Mount Auburn Hospital. I have no conflict of interest.
Thank you. Dr. Chu.
Helen Chu, Professor of Medicine and Epidemiology at the University of Washington Schools of Medicine and Public Health. No conflicts.
Dr. Sineas.
Sybil Sineas, Associate Professor of Medicine and Pediatrics at the Warren Albert Medical School of Brown University, and I have no conflicts.
Dr. Jameson.
Denise Jameson, Dean, Carver College of Medicine, University of Iowa, and the Vice President for Medical Affairs. I have no conflicts of interest.
Dr. Kamboj.
Minnie Kamboj, Memorial Sloan Kettering Cancer Center, no conflicts.
Dr. Lair.
Jamie Lair, Cougar Family Medicine, private practice in Ithaca, New York, and I have no conflicts of interest.
Dr. Maldonado.
Bonnie Maldonado, Professor of Global Health, Infectious Disease and Pediatrics, Stanford University School of Medicine.
Ms. Moser.
Charlotte Moser, Co-Director, Vaccine Education Center at Children's Hospital of Philadelphia. No conflicts.
Bonnie needs to make a conflict.
Oh, Dr. Maldonado, can you please talk about your conflicts of interest?
No conflicts of interest. Thank you.
Thank you. All right, Dr. Schechter.
Rob Schechter, California Department of Public Health, no conflicts.
Dr. Shaw.
Hal Shaw, Professor of Medicine in the section of Infectious Diseases at Yale School of Medicine. I have no conflicts. Good morning.
And I'm Dr. Talbot, Professor of Medicine and Health Policy at Vanderbilt.
And some of the ex officios.
And keep, I'm online also.
Oh, good. Oh, good morning, George. Actually, it's probably evening where you are. Dr. Kushel, could you do your title and conflicts of interest?
Hi, good morning, everybody. George Kushel, Professor of Medicine and Geriatrics at University of Connecticut, Director of UConn Center and Aging at UConn Pepper Center, and I have no conflicts of interest.
And we do need to do the ex officios because some of them are online.
Okay. Once again, we'll also work with our ex officios, CMS.
Good morning, Mary Beth Hans, representing CMS.
Thank you. HRSA.
Good morning. This is Commander Paul McClung, representing HRSA.
Indian Health Service.
Good morning. This is Matthew Clark, representing the Indian Health Service.
Thank you. OIDP.
Good morning. This is Chinedu Okeke, representing OIDP.
Fantastic. NIH.
Good morning. John Weigel, representing National Institutes of Health.
And FDA.
Good morning. David Caslow, representing US FDA.
All right. I think we've now gone through introductions. We'll do agency updates. There's been a wide range of vaccination efforts across the federal governments, and we appreciate the updates and continued collaborations across the agencies. CMS.
Good morning. This is Mary Beth Hans again, representing CMS, and I have just a couple of updates. One is building on what you just shared. We have worked very hard to amplify CDC and HHS messaging around the importance of immunizations, both seasonal and routine immunizations, and have talked to state Medicaid agencies and interested parties at many different kind of touch points throughout state connections and community involvement. And we also have really appreciated having representatives from CDC speaking with state Medicaid agencies as well, and have really emphasized the importance of immunization and to continue to return to the higher pediatric immunization rates that we saw in previous years. I also wanted to highlight that on September 12th of this year, my Medicare colleagues issued a Medicare Learning Network bulletin that included COVID codes and pricing for this year's COVID-19 vaccine, codes and pricing for this year's COVID vaccine. And those are the only updates that I have from CMS. Thank you very much.
Thank you. CDC.
Good morning, everyone. I'm Dimitri Daskalakis from the Centers of Disease Control and Prevention, and thank you again for the opportunity to give you a brief update from the agency perspective. So I'll start with fall and winter season. So first I'll say thank you so much to our colleagues at FDA, our colleagues in industry, and our colleagues at ACIP for a very expeditious rollout of COVID-19 vaccines. Again, all three strategies for vaccination, RSV, COVID, and influenza, are now in the field, and we are really seeing some interesting changes by launching early. This time last year, we are actually seeing higher uptake of COVID-19 vaccine at this time of year compared to the same date last year, which is, again, I think really testament to the fact that we work so closely together across the various components of government and industry, so thanks to that. In terms of where we are, the amount of acute respiratory illness happening in the U.S. Continues to be low. COVID-19 activity continues to decline in all areas, and there is some minimal seasonal flu and RSV activity in the southeastern part of the United States. As expected, it's where it starts and tends to then sweep across the country, and so hopefully it will sweep with some immunity based on vaccination that will mitigate some of the effects. I, for the purpose of time, will not share a lot about highly pathogenic avian influenza. I think you got a really thorough update on that. There will be some updates coming today as we release more information, and I'm happy to talk about that later once it become public. I also want to flag some of the foes that we know, measles specifically. I think if you all are likely tracking that we are seeing a year with lots of cases, 267 measles cases reported by 32 jurisdictions. Couple of things about that. So there have been 14 outbreaks reported in 2024, and 70% of those cases are associated with those outbreaks. That compares to 4 outbreaks in 2023 and 49% of cases being there. These outbreaks tend to be in communities with very low vaccination rates, and I think important flag is that we really need to make sure that we maintain our high vaccination rates for flu. For measles. Really looking flu on my mind. Looking at measles in general, we've recently released data showing that there are many states, because of exemptions, that will not be able to even come close to the 95% threshold that we need to maintain community immunity. So we look at some focused populations with low coverage, but our goal is, and thanks to you and all of the work across the immunization programs, is that we have limited communities that have that issue. I also want to flag mycoplasma. I think that that's something that you may have seen in one of our spotlights, one of our mechanisms to sort of transmit information quickly. We are seeing increases in mycoplasma pneumonia, making sure that providers are alert to mycoplasma in kids. Actually, interestingly, we're seeing mycoplasma in younger kids, which is not what we tend to see. Important to remember, because macrolides, which are the first line of treatment for this infection, sometimes aren't first line of treatment for some of the respiratory or pneumonias. So really thinking that if people are not responding to first line antibiotics, to think mycoplasma and potentially think of change in therapeutics. Ending on a high note, happy anniversary VFC. I think you all are also tracking that 30th anniversary of what is likely the most significant equity intervention in public health. Again, many children have experienced great benefit. 508 million illnesses have been prevented, 1.129 million deaths, and that's in kids, which means a lot of potential was maintained in adults, so really important. And 2.7 trillion with the T in societal costs that have been saved by the intervention. Imagine what would happen if we also have a vaccines for adults program. So thank you again for contributing your time to protecting the health of the entire nation and the nation's children. And with that, I will turn it back over to our chair.
Thank you so much. FDA?
Oh, good.
So thank you, Dr. Talbot. David Caslow, Director, Office of Vaccines Research and Review, CBER FDA.
So since the last FDA agency report at the June 2024 ACIP meeting, our Vaccines and Related Biological Products Advisory Committee, or VRPAC, convened twice and plans to meet again before year end. And the Office of Vaccines Research and Review took several noteworthy supplemental regulatory actions, of which I'll briefly highlight only 3. In September, VRPAC met in open session to discuss considerations related to the use of pertussis, controlled human infection models, to demonstrate the efficacy of pertussis vaccine candidates for the purpose of licensure. 2 endpoints were discussed: mild disease such as cough and colonization. Considerations on the use of these models included the relevance to pediatric populations, the limitations of the models with real-world pertussis infection and disease, and the ability of these models to assess long-term effectiveness of pertussis vaccine candidates. A meeting summary is anticipated to be posted shortly. VRPAC also convened an open session in October to make recommendations on influenza vaccine strains for the 2025 influenza season in the Southern Hemisphere, and also to discuss pandemic preparedness for highly pathogenic avian influenza viruses, including considerations for vaccine composition for H5 vaccines. FDA proposed an inter-pandemic period strain change process to take advantage of the inter-pandemic period to accrue additional safety and immunogenicity evidence with updated prototype vaccines, and to potentially save critical pandemic response time to have updated vaccines when needed. Again, a meeting summary is anticipated to post shortly. We also anticipate a VRPAC meeting on December 12th to discuss considerations for respiratory syncytial virus, RSV vaccine safety in pediatric populations. More on that at a future ACIP meeting. As for major regulatory actions taken since June, I will briefly mention 3 likely to be of some interest to ACIP. On 19 August, meningococcal B vaccine, Bexsero, with a dosing schedule in individuals 10 through 25 years of age, of 2 doses administered at a 0 and 1 or greater month under accelerated approval, was revised to 2 doses administered at 0 and 6 months, and to include a 3-dose schedule of Bexsero administered at 0, 1 to 2, and 6 months for that same age group, now under traditional approval. On the 29th of August, smallpox, Mpox, vaccinia vaccine live, or ACAM 2000, was approved to include prevention of Mpox disease in individuals determined to be at high risk for Mpox infection. It was approved with an updated medication guide. And finally, on Tuesday of this week, respiratory syncytial virus vaccine Abrysvo was approved for the prevention of lower respiratory tract disease caused by RSV in individuals 18 through 59 years of age who are at increased risk for lower respiratory tract disease caused by RSV. As in the past, I'd like to take this opportunity to personally thank CBER review team, supervisors, and management who work assiduously to conduct research and review to protect and enhance public health, our VRPAC members who we call upon frequently to opine on complex topics such as the 3 mentioned in this report. And let me end by thanking our colleagues here at CDC, who are really amazing partners, on call 24/7 in a collective regulatory and policy effort to protect and enhance public health through immunization.
Thank you. Y'all been very busy. HRSA.
Good morning. Thank you, Dr. Talbot. This is Commander Paul McClung providing some brief updates from HRSA today for you all. So HRSA's Division of Injury Compensation Programs, or DICP, continues to support the nation's public health through the administration of the National Vaccine Injury Compensation Program, or VICP, and the Countermeasures Injury Compensation Program, or CICP. I'll share a brief update from each program this morning. First, I'd like to highlight that HRSA, in partnership with CDC, sponsored a study from the National Academy of Sciences, Engineering, and Medicine, or NASEM, to review the evidence from 19 potential harms of COVID-19 vaccines and 9 potential shoulder injuries from intramuscular administration of vaccines more broadly. The NASEM committee drew 65 conclusions where it could not find evidence to establish, accept, or reject a causal relationship, and drew 20 conclusions with sufficient evidence, with the final release of their report in August of 2024. And these important conclusions are going to support decision-making for VICP and CICP when adjudicating claims for compensation. In support of VICP, the Advisory Commission on Childhood Vaccines, or ACCV, was briefed on the NASEM report via Zoom on July 11th, 2024, and the following day, ACCV met to discuss their next steps. They made 2 motions, including establishing a work group to amend the vaccine injury table's qualifications and aids to interpretation to address conclusions and information provided by NASEM on shoulder injuries. And they also added an agenda item to the next ACCV meeting with input from HRSA and HHS about potential research areas of interest regarding shoulder injuries. I'd also like to highlight that currently the ACCV has several vacancies and is seeking nominations. And if you have any questions or are interested in submitting a nomination, please check out the ACCV website or send an email to accv@hrsa.gov. So for VICP, I just briefly wanted to recap for everyone. VICP is a no-fault alternative to the traditional legal system for resolving vaccine injury petitions. It was created in the 1980s after lawsuits against vaccine companies and healthcare providers threatened to cause vaccine shortages and reduce U.S. vaccination rates, which could have caused a resurgence of vaccine shortages and reduced U.S. vaccination rates. VICP continues to serve as a keystone program in the nation's ability to stabilize vaccine supply and protect the nation's public health by expeditiously processing claims. And over the past 2 years, VICP has made substantial strides in reducing the backlog of claims that were awaiting review by a HRSA provider. From October 2022 to October 1st, 2024, VICP's reduced the number of claims activated by the U.S. Court of Federal Claims from 1,107 to 166. And over this same period, the wait times for a HRSA medical review has decreased from more than 12 months to 49 days. In fiscal year 2024, VICP received 1,161 petitions, adjudicating 1,374 claims, and awarding over $149 million to petitioners and over $53 million for attorneys' fees and costs. And these data and more are available at the VICP website at hrsa.gov. For CICP, just again to recap, CICP is also a no-fault compensation program. It's a bit different. It adjudicates requests for benefits alleging an injury from covered medical countermeasures deployed in a response to a pandemic, epidemic, or security threat covered under a Public Readiness and Emergency Preparedness Act, or PrEP Act, declared by the Secretary of Health and Human Services. As of October 1st, 2024, 13,468 claims alleging injuries or deaths from COVID-19 countermeasures had been filed with CICP. And CICP continues to make substantial progress in processing those claims and has now rendered decisions on 3,318 COVID-19 claims. And additional information about CICP is also available at the hrsa.gov website. In addition, just in closing, I want to highlight that support for vaccine efforts in this country are also ongoing in other parts of HRSA, including the Bureau of Primary Health Care, or BIPIC, which released its Uniform Data System, or UDS, data in August of 2024. Those UDS data capture immunization rates for children 2 and under based on the CDC 10 series. And BIPIC continues to work with CDC to promote immunization efforts across the spectrum by promoting various tools and resources that CDC has developed through their many communication channels. And finally, just want to highlight that HRSA's HIV/AIDS Bureau continues very important work through the Ryan White HIV/AIDS program, supporting access to Mpox vaccination. Thank you.
Thank you. And one quick, I may have missed. You're looking for nominations for ACCV. Can you tell us what that acronym stands for?
Absolutely. So ACCV is the Advisory Commission on Childhood Vaccines.
Thank you. All right, Indian Health Service.
Hi, good morning, Dr. Talbot. This is Matthew Clark with IHS. The Indian Health Service remains committed to immunization as our leading clinical and public health prevention priority. As part of our ongoing national E3 vaccine strategy, we offer every patient at every encounter every ACIP recommended vaccine when appropriate. To date, we've designated 32 E3 pilot sites in 9 areas, including federal, tribal, and urban Indian organization teams. The IHS E3 vaccine strategy continues to bear fruit as our pilot sites innovate at the local level and share best practices regarding effective immunization strategies in tribal communities to cross-pollinate our system of care. This year, we've designated 5 IHS E3 champions in the Alaska, Bemidji, Great Plains, Nashville, and Oklahoma City areas, each of whom have demonstrated excellence by exceeding established thresholds to improve vaccine coverage rates for American Indian and Alaska Native people. Over the last several months, we've been developing E3 training materials for an academic detailing activity. This week, 6 healthcare professionals representing federal, tribal, and urban Indian organization programs are undertaking intensive training to become E3 ambassadors in their respective areas. Following completion of training, they will undertake outreach to educate and support immunization staff working in tribal communities in the implementation of the IHS E3 vaccine strategy. Following ACIP action in June of this year related to a preferential recommendation for the hexavalent vaccine Vaxelis in American Indian and Alaska Native infants, through a variety of platforms, including written guidance and both in-person and virtual events, IHS has been working diligently to communicate this option to vaccination teams serving tribal communities. We plan to monitor the impact of this recommendation on vaccine coverage rates and potentially disease outcomes. Finally, IHS is actively engaged in our annual seasonal vaccination campaign to reduce the risks of vaccine-preventable respiratory viral diseases in Indian country, including influenza, COVID, and RSV. This includes aggressive efforts to promote access to and uptake of both maternal RSV vaccine and nirsevimab among American Indian and Alaska Native infants and young children. Similar to last year, in addition to collaboration with the Vaccines for Children program, IHS procured and distributed a supplemental supply of nirsevimab to support programs, especially those in remote locations with planned early season vaccination activities. This year, we've also worked closely with our federal partners at the CDC and Administration for Children and Families to develop materials and provide education to support home-based outreach to Indigenous families about the importance of recommended RSV immunizations. Working in collaboration with our federal, tribal, and urban Indian organization partners, the Indian Health Service will continue our efforts to mitigate the risk of vaccine-preventable illness in Indian country. Thank you.
Thank you very much. OIDP.
Thank you, Chair. Good morning, everyone. I'm Chinedu Okeke from the Office of Infectious Disease and HIV/AIDS Policy at the Office of the Assistant Secretary for Health. Thank you for the opportunity to give an update on some of our activities on vaccine safety and vaccine activities overall. I will start with the National Vaccine Advisory Committee update, NVAC. NVAC met on September 12th and 13th this year. At this meeting, the committee showcased work that can help to strengthen the U.S. vaccine and immunization system and inform vaccine policy. The meeting began with a panel presentation on the implementation of the ACIP Universal Vaccine Recommendation for adults aged 19 to 59 and adults aged 60 and older with known risk factors for hepatitis B. The committee also heard presentation on provider payments and RSV immunization across the lifespan. Much of the discussion at this meeting also focused on innovation to provide additional context for the report the committee is currently working on. NVAC hosted speakers on tuberculosis vaccine innovation and some of the challenges associated with advancing the tuberculosis vaccine pipeline. It also hosted a panel on new research to inform future HIV vaccine development. On the first day of the meeting, we learned more about a new HHS campaign called Risk Less, Do More. NVAC also hosted 2 panels focused on immunization equity. The first panel showcased 2 innovative projects, and the second panel explored lessons and evaluation approaches. Now, to fulfill the charge on providing input to advance the development of the vaccine national strategy, the committee participated in 2 working sessions to discuss potential recommendations for new goals, indicators, and objectives. My next update will be on the National Vaccine Strategic Plan 2026 to 2030 update. In the last ACIP meeting, I mentioned that the Office of Infectious Disease and HIV/AIDS Policy, in collaboration with HHS Interagency Vaccine Work Group, has started planning data gathering and engagement efforts for the next iteration of the National Strategic Plan. I also mentioned that we are putting together a request for information that will be released to the public. I'm happy to announce that we have posted the RFI on the Federal Register, and the 60 days countdown, has begun. Everyone is encouraged to provide feedbacks into all the strategies. So in addition to providing your feedbacks for the vaccine national strategies, please take a moment to also provide feedbacks for both the national HIV/AIDS strategy and the viral hepatitis national strategy. OIDP is approaching the updates for all the strategies through a syndemic lens. We encourage ACIP members to actively submit feedbacks and recommendations during this process. I wanted to also highlight, in the spirit of transparency and making sure that we provide several platforms to hear from stakeholders, OIDP is putting together a number of virtual and in-person sessions. First, the syndemic listening session taking place on October 29 from 2 to 3:30 p.m. Eastern Time. The second opportunity is on vaccine strategy, focused on vaccine strategy listening session taking place on October 31st from 1 to 2:30 p.m. Eastern Time. In November, OIDP will also host 2 general sessions for all the national strategic plans, November 13th and November 14th. November 14th is specifically on Spanish language. My final update is on Mpox. OIDP continues to lead the Summer of Pride Mpox Equity Initiative, a nationwide effort to increase access to Mpox vaccines for LGBTQI+ communities most at risk. This initiative leverages Pride festivals and other LGBTQI+ events to effectively reach these communities. On September 4th, OIDP and the HHS Office of Intergovernmental Affairs organized a virtual LGBTQI+ stakeholder call for community partners. This call served as a continuation of OIDP's previous discussions this year with community partners and health department staff involved in Mpox response. The stakeholder call, led by Assistant Secretary for Health, Admiral Rachel Levine, and CDC Director of the National Center for Immunization and Respiratory Disease, Dimitri Deskalakis, provided an update on Clade 1 Mpox virus and U.S. preparedness and response. OIDP is currently in the process of planning another stakeholder call in November. This concludes my update. Thank you.
Thank you. Last but not least, NIH.
Good morning. The National Institutes of Health continues to support vaccine-related research for multiple pathogens. I wanted to highlight just a few of these that we believe might be of interest to the ACIP. For COVID-19, NIAID is sponsoring a phase 1 trial testing the safety of a novel intranasal vaccine for SARS-CoV-2. The vaccine utilizes a new virus vector, murine pneumonia virus, a virus related to the human RSV, and was developed by scientists from Intramural NIAID Laboratory of Infectious Diseases. This is part of the Project NextGen, a program by both BARDA and NIAID that aims to accelerate the development of next-generation COVID-19 vaccines. For Mpox, a NIAID-sponsored clinical trial of MVA-BN, or Jynneos, vaccine in adolescents demonstrated that it is safe and generated an antibody response equivalent to that seen in adults. Adolescents are among the population most affected by Mpox in the current outbreak in the DRC. Bavarian Nordic received EMA approval to extend MVA-BN authorization to include adolescents. As part of the U.S. government response to the current Mpox outbreak, NIAID has released an update to its priorities for Mpox research. The NIAID Mpox research agenda outlines the objectives to respond to the Mpox outbreak, including trials to evaluate ways to stretch the vaccine supply and develop novel vaccines and therapeutics. A link to the report will be in the written comments. For malaria, 2 NIH-supported trials of novel malaria vaccine in healthy adults in Mali found that all regimens were safe and generated a robust immune response. The vaccine candidates conferred a significant degree of protection from parasite infection and clinical malaria that was sustained over a span of 2 years without the need for any booster dosing. For RSV, NIAID is conducting a randomized open-label phase 4 study of maternal RSV vaccination compared to the infant nirsevimab or both products combined. The trial was open to enrollment in September 2024 and is evaluating antibody titers for from the regimens for a period of 1 year. It's not clinical outcomes, but we believe that the immunologic response will inform clinicians using these 2 regimens. In other news, Dr. Hugh Auchincloss, the longtime Deputy Director of NIAID, retired in September 2024. Dr. Marazzo, the Director of NIAID, has named Dr. Sarah Reed as the new Principal Deputy Director for the Institute. Many of you likely know Dr. Reed from her work as Deputy Director for the Division of AIDS. The NIH has established the Research and Development of Vaccines and Monoclonal Antibodies for Pandemic Preparedness Network. It's called REVAMP, to focus on prototype pathogens for the purpose of developing vaccine candidates and monoclonals to better protect against emerging pathogens. By studying specific prototype pathogens, scientists build a knowledge base that can be applied to future emerging viruses. Details and links for all of these, as well as additional updates, will be provided in the written summary, and this concludes the updates from the National Institutes of Health.
Wow, thank you all of our colleagues who have done an immense amount of work and for sharing the progress that's being made. We will be moving on to meningococcal vaccines, and our first speaker will be Dr. Jamie Lair, the work group chair. Thank you.
Thank you very much. On behalf of the meningitis work group, I'd like to introduce the meningitis session for today. Next slide. We're working on 3 major topics at this time. The first one is that GSK has a pentavalent MenABCWY vaccine. The date for regulatory decision is going to be coming up in February of 2025, and we're reviewing that to decide what our recommendations are for using that vaccine. The second major topic is that, as you heard from Dr. Kaslow, the FDA approved Bexsero under an accelerated program for a 0-1-month dosing schedule. And then upon review after that approval, they have reviewed the data and come to a decision with the manufacturer that the dosing schedule would be better served to be 0 and 6 months, with a 3-dose schedule also to be considered. So we're going to be discussing that today. And then a longer-term project, which has been requested from the ACIP to the work group, is to revisit the adolescent schedule in totality to see if we have the best schedule possible for the American public. Next slide, please. So for timing, we're going for voting today on the Bexsero dosing schedule change. So we're going to have a presentation from Dr. Schilly on that topic. But we're also going to be talking and preparing for a vote in February of 2025 on the GSK presentation. And so we're going to have a presentation from Dr. Dong on cost effectiveness. And then we hope to revisit the adolescent schedule somewhere in 2025. Next slide, please. So the presentations today, as I said, will be one from Dr. Dong on cost effectiveness, and the other presentations from Dr. Schilly on both the Bexsero dose change and on the pentavalent GSK vaccine. Next slide. And I already mentioned that today we'll have a vote on this topic. Next slide. The next 4 slides are relevant for both the Bexsero presentation and the GSK pentavalent. And so instead of repeating the slides in both those presentations, they asked me to present them here. This is important information, background for the incidence of meningitis disease over the last many years. And you'll notice that the time frame is different in many of the slides. So this time frame is from 1996 to 2023, and you'll see that the number of cases has dropped by 90%. And so at the current time, we have 0.13 cases per 100,000 people. Just for those of you who like math, like I do, that is literally a 1 in a million case situation. So we have 1 in a million cases. Next slide. Much of that drop has been in the 3 serotypes B, C, and Y, which have come down since 2006 to present. You'll notice a big upspike in Y recently, and that's part of the consideration of the work group. But you'll see that other serotypes and the W serotype have stayed low the entire time. Next slide. This is an incidence by age group and serotype from 2012 to 2021, and you'll notice the large number of cases in less than 1 year and in the elderly, but the area to focus on right now would be the 11 to 15, 16 to 20, and 21 to 25-year-old age groups, with a special attention to the 11 to 15-year-old age group, which is low. And then if we look at the next slide, you'll see that this is just for the last couple of years, 2022 to 23. There's a significant drop even in the last 10 years. Next slide. I'd like to thank everyone on the meningitis work group, the ACIP members, the ex officio members, the liaisons and consultants, the grade support team. I'd also especially like to CDC contributors. A big thank you to Dr. Schilly, Dr. Collins, and Dr. McNamara, who've spent a lot of time working on this and helping with these presentations and getting the work group to work together. And that's my final slide. I think we're ready to move on to the economic analysis, but presentation by Dr. Dong. Thank you.
Good morning. Today, I'm happy to share the results of our economic analysis of GSK pentavalent vaccination among adolescents. I'd like to acknowledge our research team and the Meningococcal ACIP work group for their contributions. Next slide. We have no conflicts to report. Next slide. This slide lists the acronyms used in this report. Next slide. In this presentation, I'll be covering the research question, methods, model inputs, results, sensitivity analysis, comparison between our model to GSK's, limitations, and a summary of results. Next slide. Our overall goal was to evaluate the cost-effectiveness of vaccinating adolescents with the GSK pentavalent vaccine compared to the current recommendation of MenACWY and the MenB vaccines. Next slide. Here is a brief review of the current recommendation. ACIP recommends routine vaccination with a quadrivalent vaccine for adolescents aged 11 or 12 years, with a booster dose at age 16 years. In addition, ACIP recommends 2 doses of MenB vaccine for adolescents and young adults aged 16 to 23 years on the basis of shared clinical decision-making. We use Q to represent the quadrivalent vaccine and the B for the MenB vaccine. And therefore, QQBB represents the current recommendation. With the launch of the pentavalent vaccine, we have 3 policy questions to discuss. Should the pentavalent vaccine be an option for those recommended to receive Q and B together, or just Q or B alone? We use P to represent the pentavalent vaccine, and therefore we use QPB, PP, and QPP to represent these three alternative vaccination strategies. Next slide. Now to cover the methods used in this analysis. Next slide. Our intervention is the use of the pentavalent vaccine in adolescents, and the comparators are either current recommendation or related strategies. In PICO 1, we compare QPB versus QQBB. In PICO 2, we compare PP to QQ. In PICO 3, we compare QPP to QQBB or QPB. Notice that for PICO 3, there are two comparators. QQBB is the current recommendation, and the other one, QPB, could be considered as a recently established option for the standard of care. For reference, we also compare each strategy to non-vaccination. We aimed to calculate the incremental cost-effectiveness ratio. It is the difference in cost between the intervention and the comparator, divided by the difference in their outcomes. Essentially, it tells us how much extra cost is associated with each additional unit of outcome gained by using the intervention compared to the comparator. Next slide. This figure illustrates how we modeled the cost-effectiveness analysis applicable to any type of vaccination, Q or B or P. The red circle indicates the decision on whether someone is vaccinated. And the top section of this diagram shows what happens with vaccination. If vaccinated, people can either be protected or not against the corresponding serogroups, because the vaccine is not 100% effective. If they are protected, there are no additional costs beyond vaccination. If they are not protected, they will either develop invasive meningococcal disease or not. And if having invasive meningococcal disease, they may recover, have sequela, or die. I'll use IMD to refer to invasive meningococcal disease in the following slides. As vaccine effectiveness wanes over time, the proportion of the population protected by the vaccine decreases, leading more individuals to fall into the category not protected by vaccine. Unvaccinated individuals follow the same path as those who fail to gain the protection from vaccination. Next slide, please. These are the basic elements to our economic model. We use a population-based model that includes the entire cohort of current 11-year-olds in the US. We are looking at vaccination strategies over a time period of 19 years, and in each half-year interval, there are changes occurring to the number of people vaccinated, the incidence rate, and the present value of costs, just to name a few factors. In addition, we use a lifetime analytical horizon to look at outcomes that might last beyond 19 years, like the costs and the years of life lost due to sequela. We discount the costs and the outcomes by 3% each year. And we are taking a societal perspective in this analysis. Next slide. Using the most available data on the epidemiology of disease, vaccine effectiveness, the costs, and the quality-adjusted life years for each episode, we calculated the outcomes of IMD cases, deaths, costs, and the quality-adjusted life years associated with each vaccination strategy or without vaccination. In the end, we compared the incremental cost-effectiveness ratio, which is the cost per quality-adjusted life year saved, between the intervention strategy and the comparator for each PICO questions. Next slide. Now to cover the key model inputs. Next slide. One of the key epidemiological parameters is the IMD incidence rate by serogroups ACWY and serogroup B. For serogroup ACWY, we take 2003 to 2005 as the pre-vaccine era, and use the average incidence rate during this period for unvaccinated individuals in this study. For serogroup B, we use the average incidence rate from 2012 to 2014 for unvaccinated individuals. Next slide. The figure on the left shows us the IMD incidence rates for unvaccinated individuals by age. The blue line is for serogroups ACW and Y, which rates range from 0.03 to 0.5 per 100,000 throughout ages 11 to 29 years. The red line is for serogroup B, which ranges from 0.02 to 0.2 per 100,000 between 11 and 29 years. The table on the right shows us the death rates from meningococcal IMD cases by serogroups. It shows on average 9 to 15 out of 100 people with IMD will die. Next slide. Around 20% of people with IMD would have long-term consequences that including hearing loss, scarring, neurological disability, single amputation, or multiple amputation. This slide shows us the sequela used in our model and the percentage of each sequela among IMD cases. Next slide. Now we move to the vaccine inputs. This table shows the estimates of initial vaccine effectiveness by serogroups and doses. The data for the first dose of Q is based on the observed clinical effectiveness, whereas all other values are derived from immunogenicity data. The initial VE is 79% for the first dose of Q and 99% for the subsequent doses. For B, it's 64% for the first dose and 79% for the second. We assume that the protection against IMD from the pentavalent vaccine is the same as protection from each single vaccine. Next slide. These figures present the vaccine effectiveness over time. In each figure, the blue lines are for the first dose and the red lines are for the second dose. From the literature, we found immunogenicity data for specific time points, such as after 2 years, 5 years, and 7 years. In addition, we assumed that the effectiveness of both doses of Q and the second dose of B would last for 10 years, while the effectiveness of the first dose of B would last for 5 years. Using these point estimates, we plotted how vaccine effectiveness declines over time. Next slide. In our model, adolescents will get their first dose of Q at age 12, their second dose of Q and the first dose of B at age 16.5, and their second dose of B at age 17. Currently, among adolescents aged 13 to 17, 88% have received at least 1 dose of Q and 60% have had at least 2 doses. For the MenB vaccine, 32% have received at least 1 dose and 13% have received at least 2. PICO-1 introduces the pentavalent vaccine P as an alternative to simultaneous Q and B. Under this intervention strategy, 88% of 12-year-olds would get their first dose of Q, consistent with the current recommendation. However, at age 16.5, 32% would receive P dose instead, while another 27% would still receive a second dose of Q to maintain the current coverage level. At age 17, 13% will receive their second dose of B, same as the current recommendation. Next slide. In PICO 2, P doses are introduced to replace current Q doses. Therefore, in this intervention strategy, P doses will be given at the same age and have the same coverage rates as the current Q doses. That means 88% of 12-year-olds would receive the first dose of P, and 60% of 16.5-year-olds will receive the second dose of P. Here we compare it with QQ. Next slide. In PICO 3, P doses are introduced to replace the current B doses. Therefore, 12-year-olds would receive the first dose of Q with a coverage of 88%. However, at age 16.5, 32% will receive P as a replacement for B, while another 27% of this age group would receive the second dose of Q to achieve the current 60% coverage level. At age 17, 13% will receive P, matching the coverage level of the second dose of B. Next slide. This table shows us the cost of each type of vaccine based on the 2024 CDC vaccine price list. To be more accurate, the prices for the private sector have been further adjusted by the estimates from the market scan claims database. The percentage of vaccine purchased and the vaccinations administered are assumed to be evenly split between the private sector and the public sector. We also weighted the final price by each vaccine's market share, which are obtained from the market scan claims database and the Vaccine for Children database. Finally, the cost per dose, including administration fee, is $177 for Q, $224 for B, and $245 for P. Next slide. This table shows us the cost inputs for IMD cases, sequela cases, and the related productivity losses. The values presented here and on the next slide are obtained from Dr. Ortega-Sanchez's research and his presentation to the ACIP meeting in June 2023, and the values have been converted to the 2024 US dollars. Next slide. Now we are looking at the estimates of quality-adjusted life years under each episode. The background utility is 0.9 for ages 11 through 29 years. And this has been further applied to individuals with IMD and sequela. We assume that sequela have a lifetime effect, and their qualities were further calculated based on the background utility for each age group. Next slide. Now I'll move to the results. Next slide. This graph displays the number of IMD cases and deaths that will occur over 19 years. Without vaccination, there will be an estimated 233 IMD cases and 33 deaths. The two vaccination strategies in PICO 1 yield identical health outcomes, preventing 91 IMD cases and 14 deaths compared to non-vaccination. Next slide. In PICO 2, the main difference between the two vaccination strategies is the protection that P doses offer against serogroup B, which would prevent an additional 12 IMD cases and 1 death. Next slide. In PICO 3, the difference in health outcomes comes from the last dose in each strategy. Specifically, the final dose of P in the QPP would prevent 1 additional IMD case, compared to using B as the last dose in its comparators. Next slide. This table shows us the cumulative costs for each strategy. The disease costs which include direct medical costs and productivity loss, is $93 million for non-vaccination and around $52 million with vaccination. The vaccination cost ranges between $1 to $1.4 billion. Next slide. Then we calculated the incremental cost effectiveness ratios by dividing the difference in total costs between the intervention strategy and its comparators by the change in quality adjusted life years. The values are displayed in the far right column of the table. We found in PICO 1, QPB is cost saving comparing to QQBB. There is no difference in QALYs, but QPB would save $175 million. In PICO 2, we see that PP would increase the costs by $373 million, and again 33 quality adjusted life years compared to QQ, which leads to an incremental cost effectiveness ratio of $11 million per quality saved. For PICO 3, QPP is cost saving compared to QQBB, since QPP would increase qualities and save money. Furthermore, comparing QPP to QPB, there will be an incremental cost effectiveness ratio of $4.5 million per quality gained. Next slide. The next section is sensitivity analysis. Next slide. First, we see tornado diagrams, where we vary each parameter one at a time. This graph shows how the top 6 parameter assumptions affect the cost effectiveness of PP versus QQ. On the left side, we can see the individual parameter names. The blue portion of the bar represents how the incremental cost effectiveness ratio would change if the parameter were lower. And the orange portion of the bar represents how the incremental cost effectiveness ratio would change if the parameter were higher. If you look at the top bar, you can see how the vaccine cost might change the results. The current vaccine price is around $210. So if the vaccine costs were half of the current price, the incremental cost effectiveness ratio would drop below 0, which means the PP would become cost saving versus QQ. On the other hand, if the vaccine price were 50% higher, then the incremental cost effectiveness ratio would increase to about $29 million per quality gained. We used a wide range on the vaccine cost input here, just try to more fully understand how this input would impact our results. Next slide. This slide shows the same tornado diagram, but for PICO 3. The top parameter here is still the vaccine cost. Similar parameters were shown to be important in this comparison as in the previous comparison. Next slide. The next few slides will show the sensitivity studies with higher incidence. Here, we extend the period of pre-vaccine era. We calculated the average incidence rate for serogroups ACWY from 1996 to 2005, and for serogroup B from 1996 to 2013. In each figure, the red lines represent the values used in this analysis, in contrast to the blue lines, which depict the base case values. Next slide. We saw that in PICO 1 and PICO 3, the QPB and the QPP remain cost-saving compared to the current recommendation. With higher incidence, the PP in PICO 2 and the QPP in PICO 3 will become less costly. Next slide. In this sensitivity analysis, we change the incidence of MinB to be 3.5 times higher than the base case among 18 to 24 years old. Again, we found that in PICO 1, QPB remains cost-saving, and in PICO 3, QPP remains cost-saving compared to QQBB. In PICO 2, PP has become less costly compared to QQ. Next slide. In this figure, we illustrate how changes in the pentavalent vaccine price affected the ICERs in PICO 2 and PICO 3. The dotted lines in each figure indicate the base case input and result. We see that the incremental cost-effectiveness ratio moves in the same direction as the vaccine price, that it drops when the vaccine price decreases. When the vaccine price is below $143, PP will bring cost savings compared to QQ. And when the vaccine price is below $190, QPP will become cost saving compared to QPB. Next slide. Now we'll discuss the differences between our model and the GSK's. Next slide. On the input side, GSK's used the higher incidence rates and the coverage rates than ours. Next slide. In our model, the initial VE for the first dose of MinB is higher, while the VE wanes much faster than GSK's. For example, in our model, the effectiveness of both vaccines declines to 0% within 5 to 10 years. Whereas in GSK's model, they maintain over 20% effectiveness at 10 years. We also calculated the overall years of protection based on the waning speed. And we found that GSK's model predicts a longer period of protection for both vaccines. Also, our model included 5 types of sequela with the aggregate rate of 22%. While GSK's include 16 types of sequela with an aggregate rate of 55%. Next slide. This table shows us the differences in outputs. For PICO 1, both models found that QPB is cost-saving comparing to QQBB. For PICO 2, GSK estimated a higher ICER than ours. For PICO 3, QPP is cost-saving compared with QQBB in both models. But QPP has a higher ICER compared with QPB in our model. Next slide. Our study has several limitations, such as limited vaccine effectiveness data, assumptions on the third dose effectiveness of MinACWY, unknown pre-vaccination incidence rates, and estimated costs for GSK's pentavalent vaccine. Next slide. Also, our study didn't account for additional protection against gonorrhea, potential increase in vaccine uptake, and the benefits for fewer adverse events from reduced injections. Also, we used the vaccine coverage data based on the current shared clinical decision-making practices and didn't model any changes to the routine use of MinB vaccines. Next slide. In sum, we found that in PICO 1, QPB is cost-saving versus the current recommendation. In PICO 2, we found that PP would cost $11.3 million per quality saved versus QQ. In PICO 3, the results ranges from cost saving to costing $4.5 million per quality gained. Next slide. Thank you for your time.
Thank you very much. We have time for a couple of questions for Dr. Dong, Dr. Maldonado, and then Dr. Schechter.
Thank you very much for this. Is a really helpful presentation. I know it's complex modeling. And for those of us who've been following the trajectory of meningococcal disease and how to prevent disease in the highest risk populations in the U.S., I think this is a really helpful discussion. But I'm not a modeler, so I have some probably basic questions for you. I guess fundamentally, what I find surprising, and maybe you can help elucidate this for me, is that it would just seem to me intuitively that if you have a pentavalent vaccine that you can give twice versus 3 different valencies of vaccines that you have to give 3 times in adolescents who are very hard to bring back, that would actually be least cost effective. And so I'm assuming that the cost of the vaccine is driving that, and you may have indicated that, but I just wonder why, taking coverage, potential coverage costs for this disease, retention of this patient population to get the full 3 doses would not impact the overall efficacy of this particular schedule. So my basic question is, why is 2 doses of a broader vaccine least cost savings compared to all of the other options? Thank you.
I think you are talking about the PICO 2 when we compare PP versus QQ. Yes, for this comparison, the travel trips will be the same. There are going to be 2 trips. One is for the first dose and the one is for the second dose. So when we calculate the incremental cost effectiveness ratio, then the advantage of having less trips would be canceled out while calculating this. Another thing is comparing, if you say comparing PP to other, for example, more trips kind of strategies, that's part of our limitation that we didn't include the possible the possible reduced trips in the other comparators, because we're not comparing those at this stage. But for now, yeah, for if we say for PICO 1, for example, we replace 1 dose with P to the 2 doses with QB at their 16.5 stage. So it's going to be the same. This patient and the parents, they are going to visit the doctor and have the vaccine, regardless of it's like a Q plus B or just a P. So it's going to be a same visit. So when we calculate the incremental cost effectiveness ratio, the benefit of this is going to be canceled out as well.
Sorry, I just want to follow one more time. So then, are you saying that if we, it just seems to me if you look on slide 40, I think it's 40, would you be able then to compare PP to QBB and see if would you say that the cost savings would still fall towards QBB?
Well, here we are PP to QQBB, right?
Yeah.
Yes. So we didn't, because this is not one of the PICO questions, so we didn't calculate this. But for sure, if we are comparing PP to QQBB, there will be 1 trip reduced from this.
And what was the reason for not making
So that just wasn't one of the specific PICO questions we were looking at. If that's of interest, and, you know, with the work groups, you know, work group lead approval and whatnot, we can definitely run that simulation or run that comparison at a later time.
Yep. Thank you.
Hi, Rob Schechter. Thank you so much for the presentation. While slide 40 is up, one question would be, can you, to what degree are you prepared to, maybe this is premature, but for the other pentavalent vaccine, where there's already the recommendation, which I believe is PICO 1, can you comment on whether the first part of PICO 3 would also likely to be cost-saving for the other formulation of the pentavalent vaccine? As we're looking ahead to...
Can we go back to...
I'm sorry, for slide 40.
40, yes.
The top half of 3, the comparison between QPP and QBB, would you expect it to be similar for the other pentavalent formulation that's already available?
I'll do this one by one. So for the first one, PICO 1, QPB versus QBB, it is cost saving because the price, recall the equation calculating the incremental cost effectiveness ratio is going to be the net cost divided by the net outcome. So for the PICO 1, the net outcome would health outcome would be the same. So the overall, the why we have cost saving is because the price of Q plus B is less than just P. So in this cases, I would say for the same coverage rate, and we assume that this will be cost saving. The QPB will be cost saving to QBB anyways, because this is pure saving money. And the other one is QPP versus QBB. For now, it is cost saving, and the benefit comes from the last dose of P that it gives protection against serogroup ACWY. And the cost part, the difference is going to be the P minus the QB. The price is much lower. So I'll assume the cost saving as well.
I'll just add that if you're referring to the pentavalent vaccine that's already kind of being used, when this type of analysis was done last June 2023, the result for PICO 1 was very similar. It was cost saving as well.
Thank you. Another question is, you mentioned the limitations, the difficulty of estimating the risk to the unvaccinated. And I'm wondering if the risk is diminished because of decreased colonization or other indirect effects, would that increase the cost per ICER if the baseline risk is lower than it was pre-availability of vaccines? Would that be associated with increased cost estimates per? Is that a reasonable assumption?
Yes.
Yeah, definitely. If the risk is lower, the disease burden will be lower. There'll be less disease to prevent with the use of the vaccine. And so you would expect the cost effectiveness ratios to increase.
One last small question on slide 19 and 20. I guess it's the estimating whether your coverage estimates going from 27 to 59%, 27 versus 32%. I'm just wondering to what degree that's an additive effect from the bivalent vaccine versus you're immunizing some of the same people who've gotten the pentavalent with the, is it additive or is there overlap? Or maybe I'm misguided there, but I'm just wondering if the coverage effect would be lower because you're basically talking about the same teenagers.
So in terms of serotype protection, coverage is exactly equal. What the model did is if a person was using shared clinical decision-making after they got their second Q, they went on to start getting their B series. If you're in that track, you, instead of getting Q and B, you just get P. Everybody else who didn't choose to get the B vaccine, they would still get the Q vaccine to finish their Q series. So coverage for serotype protection purposes is the same in those two strategies.
Maybe I'll reframe it. If the coverage rate is lower than 59%, what effect would that have on the cost estimates?
So if coverage went down, you mean like if a person was going to get QQ and we just modeled a separate QQ strategy with lower coverage? We did not run that analysis, but that's something we can look into.
Okay, thank you. Thank you again.
So I don't see any more questions. Oh, I'm sorry, Dr. Shaw.
Hi, thanks, that was great. I just had a question, still on this slide. So am I correct that the PP intervention would obviate the need for a second B vaccine? Is that correct? So I'm trying to figure out when, would there be a relevant comparison of PP to the QBB? Wouldn't that be a relevant comparison if that's the case? Was that modeled? Like, you know, PP compared to the current recommendation?
Per the current PICO questions, we didn't include that. Per the current PICO questions, we didn't include that into our model. We are comparing PP just versus QQ for the concept that if the Q itself is going to be replaced by P.
Okay, I mean, I think that might be a thing, as Dr. Maldonado was saying, if it's really only two vaccines compared to the current recommendations for QBB. Otherwise, I can't imagine a typical scenario where someone would just get QQ. I mean, the only scenario I could think of would be a young child with complement deficiency or something like this, which is not really what we're talking about here.
Okay. We're going to take that back to the work group and try to get that comparison developed.
Dr. Lear.
So, thank you. As chair, I've been thinking about this and breathing this for many months, and I'd like to sort of summarize some of my thinking. Can we go to slide 27 first? When you look at this and when you look at the incidence rates, just in comparison, we're not talking pneumococcal with 30,000 cases a year. We're talking hundreds at most. And so that's just one important factor that I'm putting into my consideration. If you go to slide 29, these are the cost-benefit analyses. And the reason the PICO 1 is cost savings is because the manufacturer has priced it that Men ACWY might be $180, Men B alone might be $180, but combined they're only $220. So it's not A plus B equals C, it's A plus B equals just a very slightly higher. So the pentavalent is much less expensive than the two vaccines combined. And so when you are choosing to give the two vaccines, it's going to be less expensive. And that's why we have cost savings here. Reminder that at the current time, the ACIP has decided that we are doing shared clinical decision making. So B is not an automatic recommendation. And so there are a number of people who choose to get QQ without getting BB. And that's what they've modeled here, and I appreciate that. So when I look at row 3 here, and I see QPP versus QQBB cost savings, I consider actually, while I appreciate them doing that, I consider that a false choice because we're already probably going to choose PICO 1 And so we're not going to be comparing QPP to the current. We're comparing QPP to QPB, which is one that we're probably going to choose. And then I look at the last column over on the right, and we're talking ICERs in the millions of dollars. And I really want to emphasize that. We were talking yesterday about pneumococcal, $200,000 per ICER, and we were talking about $500,000 per ICER. We're talking millions of dollars per ICERs. In private communication with other ACIP-like organizations, they will not consider ICERs above $100,000 or $150,000 per QALY. I really want us to be aware that we are contemplating spending a lot of money for very few cases. I recognize that this is a dramatic, devastating disease for those who get it, but I also want to think about fiscal prudence. And then I also want to go to slide 36. And this is aimed at the manufacturers. This is all based on price sensitivity. If you looked at the tornado diagrams, which were earlier in this presentation, the cost, if it went down by 50%, it got it into a very simple cost-effective ratio and sometimes even cost savings. And so this is all based on the price of the manufacturer, and I would suggest that the manufacturers should heed these concerns, that these prices are getting too expensive for me as an ACIP member to contemplate. So those are my thoughts. Thank you.
Ms. Moser.
Thank you. So I'm also on the Meningococcal Working Group, and Jamie and I provide a nice span of what the group has been discussing when it comes to these prices. And so what I would add to what Jamie's already said is that cost is but one piece of what we're considering. This is a disease that kills 1 to 2 of every 10 people that it infects, and it permanently disables 1 to 2 people that survive. So we have to take into account the costs that are paid beyond the numbers we're looking at on the paper. The other thing I would add is that these models are great to give us something to look at, but we see with those tornado plots that there are, we can play with those numbers and adjust them, and those costs change dramatically. So we need to take into account that we don't really know what's going to happen when we make the final vote and decide on what we're going to do for a recommendation. So, I think that we've had some really productive work group meetings. We'll continue to have those meetings, but I did want to make the point that there are a variety of points of view on the committee.
So I think we probably need to move on now to Dr. Schilly's presentation on the evidence to recommendations framework for the ABCWY vaccine.
I'm sorry, Dr. Wharton, I've had my hand up for a while. I don't know if you guys can see the liaison's hands.
We can, Dr. Middleman. We're running a little behind time. Can you make a very brief comment, please?
Oh, yes, thank you for recognizing me. I'm sorry to interrupt. I just wanted to add that I would like to also sort of add a call to action for the pharmaceutical companies. Cost is a huge issue, but I think something that people haven't really talked about much is the confusion that this alphabet soup sort of provides. And I don't think anyone aims to have a confusing recommendation. So the more we can make this clear with fewer vaccine options and combinations by making this recommendation simpler and using our evidence-based knowledge that combination vaccines often provide much greater immunization rates across the board, I would be most appreciative. So it's sort of a call to action again for trying to find that price that makes that tornadic sensitivity analysis make sense. Thank you.
Thank you. Dr. Schilly.
Good morning. I will now present the evidence to recommendations framework
including grade, for the GSK pentavalent or MenABCWY vaccine. Next slide. I will first review the meningococcal vaccine recommendations. Starting with the routine schedule, one MenACWY vaccine dose is recommended at 11 through 12 years of age, and a booster dose is recommended at 16 years of age. 2 MenB vaccine doses are recommended at 16 through 23 years of age, with a preferred range of 16 through 18, based on shared clinical decision-making. For persons at increased risk, MenACWY vaccines are recommended for certain medical conditions, some microbiologists, exposure during an outbreak, travel to hyperendemic areas, and first-year college students. And MenB vaccines are recommended for persons with certain medical conditions, some microbiologists, and exposure during an outbreak. While MenACWY vaccine products are interchangeable, MenB vaccine products are not interchangeable. As such, vaccines from the same manufacturer must be used for all doses in the MenB series. Next slide. There are 2 new MenABCWY vaccines, one manufactured by Pfizer and one by GSK. The Pfizer vaccine, Penbrea, is licensed for use, and ACIP voted on recommendations for this vaccine at its October 2023 meeting. The GSK vaccine is not yet licensed for use, and we anticipate an ACIP vote for this vaccine in February 2025. Each vaccine is a combination of an existing MenACWY vaccine and an existing MenB vaccine. The meningococcal vaccines work group has previously assessed the Pfizer vaccine and is assessing the GSK vaccine separately. Note that there are a lack of data directly comparing these 2 vaccines. Next slide. For the Pfizer vaccine, the ACWY component is Nimenrix, and the B component is Trumenba. For the GSK vaccine, the ACWY component is Menveo, and the B component is Bexsero. Both vaccines are intended to be administered as 2 doses separated by 6 months and are indicated or anticipated to be indicated for persons aged 10 through 25 years. Next slide. The 3 policy questions that guided development of recommendations for the Pfizer pentavalent vaccine are being used for the GSK pentavalent vaccine. For PICO-1, should the GSK pentavalent vaccine be included as an option for MenACWY, MenB vaccination in people currently recommended to receive both vaccines at the same visit? For example, 16-year-olds. PICO-2, should the GSK pentavalent vaccine be included as an option for people currently recommended to receive MenACWY vaccine only? For example, 11 through 12-year-olds. And PICO-3, should the GSK pentavalent vaccine be included as an option for people currently recommended to receive MenB only? For example, during a serogroup B outbreak. Next slide. The combined PICO questions are reflected here. Next slide. Among the 6 outcomes, 3 are critical: meningococcal disease caused by serogroups A, B, C, W, and Y, short-term immunity, and serious adverse events. All outcomes will be included in the evidence profile. Next slide. This slide depicts how the PICO questions translate into schedule options for healthy adolescents. PICO-1, or the use of MenABCWY when both MenACWY and MenB are indicated at the same visit, corresponds to a dose of quadrivalent vaccine at age 11 through 12 years, a dose of pentavalent vaccine at 16 years, followed by a dose of MenB vaccine. For PICO-2, or use of MenABCWY vaccine when MenACWY is indicated, corresponds to a dose of pentavalent vaccine at age 11 through 12 years and 16 years, followed by a dose of MenB vaccine. PICO-3, or use of min ABCWY vaccine when min B vaccine is indicated corresponds to a dose of quadrivalent vaccine at age 11 through 12 years and 2 doses of pentavalent vaccine at 16 years. Note that the preferred recommended age for min B vaccine for healthy adolescents is 16 through 18 years of age. Next slide. The evidence to recommendations framework domains are depicted here. Next slide. First, I will discuss the public health problem domain. Next slide. Meningococcal disease most often presents as meningitis or bacteremia and progresses very rapidly. It commonly affects previously healthy young persons. 10 to 15% of cases are fatal, even with antibiotic treatment. Approximately 20% of survivors experience long-term sequelae, such as cognitive deficits, hearing loss, and limb amputations. Next slide. The work group felt that invasive meningococcal disease is a problem of public health importance for all 3 PICOs for the GSK pentavalent vaccine, which mirrored the previous ratings for the Pfizer pentavalent vaccine, shown in gray. Next slide. Now to the benefits and harms domain. Next slide. 10 trials, including 2 unpublished studies, were identified for inclusion in the evidence review. 3 studies lacking a min-B or min-ACWY comparator group were excluded. All included studies were randomized trials, and all except for 1 were observer blind. Next slide. Next slide. 4 studies contributed to the assessment of short-term immunity 1 month after 1 min-ACWY vaccine dose for healthy persons. The seroresponse risk ratio ranges from 0.94 to 1.03 for serogroups A, C, W, and Y. Because HSBA titers are established correlates of protection only for serogroup C disease, the body of evidence was downgraded for indirectness. The certainty was deemed moderate. Next slide. Because the studies included healthy adolescents, the body of evidence was further downgraded to very serious for persons at increased risk for low certainty. Next slide. Next slide. 1 study contributed to the assessment of short-term immunity 1 month after 2 min-B containing vaccine doses for healthy persons. The seroresponse risk ratio ranges from 0.91 to 1.01 for the 4 serogroup B strains depicted here. Again, because HSBA titers are established correlates of protection only for serogroup C disease, the body of evidence was downgraded for indirectness. The certainty was deemed moderate. Next slide. As with the assessment for serogroups ACWY, because the studies included healthy adolescents, the body of evidence was further downgraded to very serious for persons at increased risk for low certainty. Next slide. Next slide. No studies informed long-term immunity for min-ACWY vaccine, and 1 study informed long-term immunity assessed at 2 years for min-B vaccine. Downgrades were made for indirectness, as previously discussed, and for imprecision due to small study sizes. The overall certainty level was low for healthy persons, next slide, and very low for persons at increased risk. Next slide. Next slide. 7 studies informed adverse events. Serious adverse events related to vaccination occurred in 3 subjects among pentavalent vaccine recipients across 2 trials, compared to 1 subject receiving min-ACWY vaccine and 2 subjects across 2 trials receiving min-B vaccine. Next slide. Because the sample sizes are not large enough to detect rare serious adverse events, the evidence was downgraded for imprecision. The certainty was rated moderate for healthy persons, and low for persons at increased risk. Next slide. For non-serious adverse events for healthy persons, a downgrade was made for imprecision for some arms for certainty levels of moderate to high. Next slide. And certainty levels of low to moderate for persons at increased risk. Next slide. In summary, for PICO-1, evidence for meningococcal disease caused by serogroups A, B, C, W, and Y, and interference with other vaccines administered concurrently is lacking. Evidence for short-term immunity for ACWY and B serogroups is moderate and low for healthy persons and persons at increased risk, respectively. Evidence for serious adverse events is moderate and low for healthy persons and persons at increased risk, respectively. Similarly, evidence for non-serious adverse events is moderate and low for healthy persons and persons at increased risk, respectively. Evidence for persistent immunity is only available for MenB serogroups and is low and very low for healthy persons and persons at increased risk, respectively. The summary of evidence for PICO-2 and 3 is similar, except evidence is lacking in forming persistent immunity for MenACWY serogroups affecting PICO-2. Next slide. The work group felt that the desirable anticipated effects are small for all 3 PICOs. Next slide. And that the undesirable anticipated effects are small for PICO-2 and minimal for PICOs 1 and 3. Next slide. When considering if the desirable effects outweigh the undesirable effects, for PICO-1, the work group felt the intervention was favored, but for PICOs 2 and 3, the work group responses varied. Next slide. The overall certainty of evidence for short-term immunity was moderate or low for the 3 PICO questions. Next slide. The overall certainty of evidence for serious adverse events was moderate or low for the 3 PICO questions. Next slide. Now to the values domain. Next slide. Vaccine coverage data from NIST may inform how adolescents and their parents value prevention of meningococcal disease. Approximately 85% of 13-year-olds had received at least one MenACWY vaccine dose, and 60% of 17-year-olds at least 2 doses in 2023. Next slide. Approximately 32% and 13% of 17-year-olds received at least 1 and 2 doses of MenB vaccine, respectively, in 2023. Next slide. Additionally, 89.6% of 16 through 23-year-olds and 69.1% of their parents prefer a simplified meningococcal vaccine schedule with fewer injections and fewer visits. Next slide. The work group felt that the target population would feel that the desirable effects were large relative to the undesirable effects for PICO-1, were probably large relative to the undesirable effects for PICO-2, and were probably large or were large relative to the undesirable effects for PICO-3, although some members were uncertain. This is similar to the work group's previous ratings for the Pfizer pentavalent vaccine. Next slide. The work group felt there was probably not important uncertainty or variability, or no important uncertainty or variability, and how much people value the main outcome for PICO-1. There was more uncertainty for PICOs 2 and 3, similar to the ratings for the Pfizer pentavalent vaccine. Next slide. Now to the acceptability domain. Next slide. CDC's General Best Practice Guidelines for Immunization and the American Academy of Pediatrics Red Book both state a general preference for combination vaccines over separate injections of equivalent component vaccines. Potential advantages include improved vaccine coverage, timely catch-up, reduced shipping and stocking cost, reduced cost for extra healthcare visits necessitated by deferral of vaccination, and facilitation of additional new vaccines into the vaccination program. Potential disadvantages include that adverse events might occur more frequently with combination vaccines than with individual component vaccines, confusion and uncertainty about selection of vaccine combinations and schedules for subsequent doses, and extra doses of certain antigens in the combination product. Next slide. Adolescents prefer fewer injections due to injection site discomfort, and parents and caregivers prefer fewer injections to reduce the number of physician visits as related to parental work loss. Next slide. Work group members felt the intervention is, or probably is, acceptable to key stakeholders, with more confidence and acceptability for PICO 1. Next slide. Now to the resource use domain. Next slide. For PICO 1, QPB was found to be cost-saving relative to the current recommendation of QQBB. For PICO 2, PPN could improve health outcomes, but cost $11.3 million per QALY saved versus QQN. And for PICO 3, QPP is cost-saving compared to QQBB. QPP costs $4.5 million per QALY saved more than QPB. Next slide. The work group felt that PICO 1 would be an efficient allocation of resources, but this varied for PICOs 2 and 3. Next slide. Now to the equity domain. An increase in invasive meningococcal disease has been observed among Black or African American persons, consistent with the demographic characteristics of ST 1466 cases driving the increase in incidence in recent years. Next slide. Among 11 through 20-year-olds, case counts are too small to examine by year, but the average annual incidence across 2015 through 2023 is highest among Black or African American persons. Next slide. This figure shows incidence of meningococcal disease by ethnicity from 2015 through 2023 for all ages. Incidence among Hispanic individuals is higher starting in 2019. Next slide. When we look specifically at incidence by ethnicity among adolescents 11 through 20 years, we can see that the average annual incidence across 2015 through 2023 is higher among cases in 11 through 20 years that are not Hispanic or Latino in this time period. Next slide. Counties with lower socioeconomic status had fewer MinB doses stocked. This equates to 20 doses per 100 adolescents for low SES counties versus 28 doses per 100 adolescents for high SES counties. Next slide. Some healthcare providers may choose to discuss immunizations recommended for shared clinical decision-making with all eligible patients, while others may be more selective. Provider or patient awareness of the recommendation is a prerequisite for shared clinical decision-making discussions with patients. While patients can initiate a shared clinical decision-making discussion with their provider, relying on patients to be aware of the vaccine or relying on a provider's judgment of which patients may benefit from vaccination could lead to health inequities. Pentavalent vaccine could potentially reduce disparities among those who might be interested in MinB vaccination, but who might not receive clinical care that includes discussion of MenB vaccine. Next slide. And the lack of MenB vaccine interchangeability currently restricts existing MenABCWY vaccine use to patients of providers stocking the Pfizer MenB vaccine products. Next slide. The work group felt that health equity would probably be increased with the GSK pentavalent vaccine, which is different than the variable responses noted previously for the Pfizer vaccine. This difference may relate to the lack of interchangeability of the MenB products, as currently only patients at practices which stock the Pfizer product are eligible for pentavalent vaccine. Next slide. Now to the feasibility domain. Next slide. Challenges with insurance or financial burdens related to pentavalent vaccine are not expected. The GSK pentavalent vaccine would provide an additional option and may reduce the number of doses for some people. Lack of MenB vaccine interchangeability complicates stocking considerations. Next slide. Overall, the work group felt the intervention would be feasible to implement. Next slide. A summary of the work group determinations is depicted here. Note that the determinations are generally favorable for PICO 1 and somewhat less favorable for PICOs 2 and 3. Next slide. For PICO 1, the work group felt that the desirable consequences clearly outweigh the undesirable consequences. For PICOs 2 and 3, the work group was divided, as shown here. Next slide. The work group feels there is sufficient information to move forward with a recommendation. Next slide. The work group does recommend the intervention for PICO 1, does not recommend the intervention for PICO 2, and the work group was evenly divided for PICO 3. Next slide. Several work group members noted that it would be important to harmonize recommendations between the GSK and Pfizer pentavalent vaccines unless there is a vaccine-specific reason to have a different recommendation. Next slide. In light of this point, several work group members suggested creating an interim recommendation for the GSK vaccine that mirrors the recommendation made for the Pfizer vaccine last year. In other words, to accept PICO 1 and reject PICOs 2 and 3. Recommendations for use of both pentavalent vaccines could then be revisited as part of future adolescent schedule deliberations, if desired. Next slide. I would like to thank those listed here for their contributions to this presentation, and will now take questions.
Dr. Lair.
Thank you very much for that wonderful presentation. As a member and chair of the work group, could we look at slide 65? So go back one slide. I'd like the ACIP members to comment. The work group seems to have a different perspective on PICO 3, and there is a chance that the work group might want to favor PICO 3, which would create a lack of harmony between the two pentavalent vaccines. And I'm curious if you could give the work group guidance as to how you feel about that, whether that would be acceptable or not acceptable. I personally, taking my chair hat off, do not feel that it is acceptable, and I would be wanting to harmonize. But if the ACIP members would be comfortable with a non-harmonious recommendation between the two pentavalents, we'd like to hear from you. Thank you.
Dr. Chu?
I would agree with you. I think that it's important to harmonize, and I think that probably the most logical thing would be to accept PICO 1, keep the two harmonized, and then to wait for subsequent data to come in on whether a PP strategy is as immunogenic or comparable as a 3-dose strategy. So those are my thoughts.
Dr. Shaw?
Thanks very much. That was a really great presentation. I just want to, not to belabor it, but the specific PPB versus the current recommendation has not been modeled. Is that correct? PPB versus QBB. Only PP versus QQ. Is that correct?
Yes, so that, we are looking at revisions to the adolescent schedule change in the coming months, but we want to first address the use of the GSK pentavalent vaccine, and then can address other changes in the context of larger revisions to the adolescent schedule change. So right now, we're currently only looking at the pentavalent vaccine in the context of different options of existing recommendations.
Okay, thank you.
Dr. Asturias?
Yeah, Edwin Asturias, and I think, thank you, Jamie, for that question. First of all, I think as soon as we include NEP into the schedule, we're going to move from a combination of meningococcal vaccines where we have a sort of recommended schedule and a shared decision-making to now basically include the B as part of the recommended schedule. And I feel like if we're going to, include that as part of the puzzle, then one needs to sort of go all the way with the B recommendation, meaning it doesn't make any sense to leave one piece of the strategy to be shared decision-making when you basically are already moving to one of the vaccines being recommended. So that poses the issue then of, should you do any preference in sort of having 3 doses of the quadrivalent or 2? And again, that's, I think, an economic analysis that needs to be done. But overall, I think it's going to be important that we acknowledge that immediately when we include the pentavalent vaccine as part of the schedule, that's going to include basically moving to a recommended schedule and not a shared decision-making.
So I need to clarify, the QPB schedule, which is PICO 1, that the work group is considering and recommending, is still shared clinical decision-making. The P and the B are only being offered if after shared clinical decision-making, the family or the child decide that they want B. So even though we're saying P as the second dose in that series, that is still shared clinical decision-making. Thank you.
But we haven't been presented with that choice, have we?
That was the thought process of the work group, that it is still shared clinical decision-making under PICO 1. Actually, under
what I'm trying to get at is what we have been presented with is data, on my understanding, that the whole schedule moves to that and not just pieces of it.
The whole schedule will move from QQBB, which is QQ recommended and BB shared clinical decision-making, to QPB, Q recommended, and P and B shared clinical decision-making, and if they decide they don't want B, it would just be a QQ schedule. So we're not changing away from shared clinical decision-making for B.
This is becoming very complicated,
Yes.
but I do think that I'm sort of opposed to sort of move to a schedule that downgrades the second vaccine recommendation, which I think has been so important, and we know that parents value that. So,
okay. Dr. Maldonado.
Thank you for this discussion. And I just want to say, as a pediatrician and as the former chair of the American Academy of Pediatrics Committee on Infectious Diseases, this issue has been even within the Academy. I mean, I'm not speaking for the Academy now, but has been a very difficult one. And I can tell you that in general, the shared clinical decision-making, as you all know, and you heard the slides really, it's very difficult for primary care providers to really deal with that issue, particularly for a disease that is this devastating, but the incidence is so low and unpredictable. So I don't know what to say given all of the constraints that we currently have, except to say, if we can minimize, as Dr. Studios indicated, minimize the complexity for the primary care provider, noting the very low uptake of B because of this shared clinical issue. So I would try to, if possible, if there's such a term as available, mainstream the recommendations and harmonize with the routine schedule, and then as quickly as possible try to transition, as Dr. Chu mentioned, really transition this into being a non-shared clinical decision-making routine opportunity for us, because it's really difficult for clinicians and families to understand how to make these decisions. And again, the impact in communities is very difficult. And as you saw, most of the lack of B is in areas where there are equity concerns already. So I think transitioning as quickly as possible to a routine would be the best choice. And I'm sure we all, think that's what you're essentially indicating here.
Thank you.
Ms. Moser, Dr. Brooks, and then Dr. Chen.
Thank you. So just to clarify, because I think it helps to remember that there's already the Pfizer vaccine that's approved for essentially what we're showing at PICO 1, so that this whole discussion, which in the work group was very complex because of the impending review of the schedule overall, was determined that it was best to just address the GSK vaccine in comparison to the Pfizer vaccine. And again, we came up with some different responses that we will then be revisiting when we get back to looking at the routine schedule, which will be very quickly. The Bexsero issue came up, and now we have the second pentavalent vaccine, so those had to take precedence, but we'll be very quickly in 2025 getting back to those discussions. To Dr. Maldonado's point, that we are looking at the schedule as a whole, because we know that there are issues with shared clinical decision making, and trying to think about what should this schedule look like now that we have these new vaccines that allow us to use fewer vaccines to accomplish more, essentially.
Yes, so Dr. Larry made a couple of relevant points. One I'm going to go back to. We're talking millions of dollars as it relates to ICERs. Also, what Dr. Suri said, if at age 16 the decision is no B, you just give another Q. If at age 16 you want B, you give a P, and then you give another B. So there's no question that if we don't harmonize, there will be issues. So that, I think, almost is an assumption that we have to make. So I would not be in favor of going out of harmony. I would be in favor of PICO 1, and it's not as confusing as it sounds. And if we're looking at, if the family's looking at using B or wanting B, then the option that we're presenting is cost saving. And the only other thing I'll say is for some of this data going forward in terms of the 0.6 hospitalization and all that, it'd be nice to see raw numbers, because we're talking about maybe 4 or 5 deaths or 10 or 12 complications averted per year. So the numbers that we're discussing for this particular illness are, in terms of bad outcomes, are very, very low. So that is my position.
One final comment from Dr. Chen, and then we'll move on to Dr. Shilley's next presentation.
Thank you. I agree with the others, ACIP members, about the need to harmonize. Otherwise, it becomes very complex. And then a point is that the 2 pentavalent vaccines, because they contain the different MenB components, I would assume that they are not interchangeable, right?
That's correct.
Right. And then it would be complex for individual clinics to stock the 3 different meningococcal vaccines. And while it may be clear that you use QPB, it is still confusing for some of the vaccine administrators who may not understand the differences between these vaccines. And then the cost analysis, as shown on some of the earlier slides, that had the QPB in comparison to QBB. I would think that if this were, and that's for PICO 1, if this were standardized, some people who may get Q and then QP may drop off before for the 3rd dose. So I wonder if that was a consideration. And then finally, meningococcal disease is a potential concern for travelers, which will be a subset of these the population getting meningococcal vaccine, and that's more specifically for the those going to sub-Saharan Africa or going to mass gatherings, such as religious pilgrimages. And I wonder if there are data looking at the cost. I assume that they would still get the Q vaccine, and if they were getting it in their adolescent age or pre-college age, that protection is assumed to have 5 years. But if, as the manufacturer indicated, that the protection can be longer, the protective duration is longer, maybe up to 20 years, that would be wonderful. And the additional data on that would be very helpful. Thank you.
A quick comment, if I can get it out, and then we'll move to the next sessions. I know others have their hand raised and questions, but we'll try to, if we're not too far behind, we'll capture those. I can't even say, QPB seems easy, but when you're stocking 3 different vaccines and they all say meninge on there somewhere, you are really setting yourself up for giving the wrong vaccine. And I want you to think very clearly about that, because we thought it was so simple when we introduced conjugate to pneumococcal vaccine, and it was not. People got the wrong vaccines all the time because they both said pneumonia on it. So I would think very hard about that. I appreciate the split in the view of whether the ICERs are appropriate or not. I watched parents move their daughter's stuff out of her college dorm room. So it's very emotional for me, and I know that. So I'm okay with ICERs that are higher. We do many things in medicine that I think we could cut before we cut meninge vaccine. But I do think the group needs to go back and really find a simplified standard vaccine that does not have shared clinical decision-making. And I know I'm charging you with something very difficult, but we know shared clinical decision-making doesn't work, and I think we need a better solution. And I don't have one for you, but I'm looking forward to hearing the solutions that you bring forward. So thank you.
Dr. Talbot, may I speak very, very quickly? I know we're short on time.
Yeah, just hang tight and we'll try to get back to you. Thank you.
Can we bring up the next presentation, please?
Just a quick comment. Are there enough data for this vaccine to do a sensitivity analysis on potential protection of gonococcal disease in young adults for the future? Not for now, but is there, would that change or not change the cost estimate by to factor in a short-term protection against gonococcal disease?
Yeah, so the vaccine is anticipated to be licensed for the prevention of meningococcal disease, but we do know that these vaccines, the OMV containing MenV vaccines, have about a 30 to 40% efficacy against gonorrhea infections. So we did not factor that into the cost effectiveness analysis, but that would theoretically make it more cost favorable when considering the benefits of gonorrhea prevention.
Dr. Maldonado, did you have a last comment? Okay, all right, Dr. Schilly, we are running substantially behind in this session from where we need to be, so just, that's why we're trying to move things along.
I will now introduce the MenB4C, or Bexsero, interval and dosing label change, and deliver the next 3 presentations on the agenda, and we will have discussion and questions after the final presentation. Next slide. Throughout these presentations, I will refer to MenB4C as Bexsero and MenB-FHBP as Truminba for clarity. Neither CDC nor ACIP has a product preference for either MenB vaccine. Bexsero was initially licensed by FDA under an accelerated approval process. New immunogenicity data support changes to the dosing schedule. These proposed changes are not due to safety concerns. The new schedule, as per the FDA label, became effective August 19, 2024, and aligns with the existing schedule for Truminba. Next slide. Bexsero was previously recommended as a 2-dose series with doses administered at 0 and at least 1 month. This was for healthy adolescents who are vaccinated based on shared clinical decision-making, as well as for persons with the risk factors shown here. The Truminba schedule is for a 2-dose series for healthy adolescents with doses administered at 0 and 6 months, and a 3-dose series for persons with the risk factors depicted here at 0, 1 through 2, and 6 months. Next slide. The new Bexsero label includes a 2-dose and a 3-dose series. The 2-dose schedule is administer a dose at 0 and 6 months. If the second dose is administered earlier than 6 months after the first dose, a 3rd dose should be administered at least 4 months after the second dose. And the 3-dose schedule is to administer a dose at 0, 1 through 2, and 6 months. The label indicates the choice of dosing schedule may depend on the risk of exposure and the individual's susceptibility to meningococcal serogroup B disease. Next slide. Given the FDA label change for Bexsero, ACIP will vote on updated recommendations. The proposed recommendations will achieve alignment with the FDA label and existing recommendations for Truminba. Next slide. I will now move to the next presentation. Next slide. The work group developed 2 PICO questions shown here. PICO 1. Among persons aged 16 through 23 years recommended for MenB vaccination based on shared clinical decision-making, should Bexsero be administered on a 0-6 month dosing interval versus a 0 and at least 1 month dosing interval for the prevention of invasive meningococcal disease? And PICO 2, among persons with complement component deficiencies, those with complement inhibitor use, functional or anatomic asplenia, microbiologists routinely exposed to Neisseria meningitidis, or persons affected by an outbreak of serogroup B meningococcal disease, should Bexsero be administered on a 0, 1 through 2, 6-month schedule versus a 0, at least 1 month schedule for the prevention of invasive meningococcal disease? Next slide. Note that a yes vote for either PICO question aligns with existing Truminba recommendations. Next slide. I will now review the 7 domains of the evidence to recommendations framework, starting with public health problem. Next slide. This slide was presented previously for the GSK pentavalent vaccine term of reference and is being included again here for completeness. Next slide. Also, as noted previously, the overall incidence of meningococcal disease has declined from 2006 through 2023, and the decline in serogroup B is shown in dark blue here. Next slide. Persons at increased risk for serogroup B disease and recommended for vaccination are depicted here and include those with a persistent complement component deficiency, complement inhibitor use, anatomic or functional asplenia, microbiologists routinely exposed to Neisseria meningitidis isolates, and persons at risk during an outbreak. The excess risk increase may be up to thousands of fold higher than the general population, depending on the condition. Next slide. 9 meningococcal disease outbreaks have occurred since 2022, including 2 serogroup B outbreaks. one in a college and surrounding community, and another in an Amish community. Next slide. For both PICO 1 and 2, the work group felt that yes, invasive meningococcal disease is a problem of public health importance. Next slide. Now to the benefits and harms domain. Next slide. For PICO 1, dose 2 of the 0-6 month schedule was compared to dose 2 of the 0-2-6 month schedule to correspond to comparing the new versus previous schedule. For PICO 2, dose 3 of the 0-6 month schedule was compared to dose 2 of the 0-6 month schedule to correspond to comparing the new versus previous schedule. Note that due to the study design, it was not possible to compare to a schedule with 2 doses separated by 1 month as per the existing recommendations, but rather 2 doses separated by 2 months. Next slide. Solicited local and systemic adverse events were recorded after each dose of Bexsero and a single dose of Menveo. Doses 1 and 2 of the 0-6 month schedule are shown in blue. Doses 1, 2, and 3 of a 0-2-6 month schedule are shown in dark blue, and a single dose of Menveo is shown in green. The most common local adverse event was injection site pain, and the most common systemic adverse event was fatigue. Most of the solicited adverse events were mild or moderate, with an average duration of 1 to 4 days. Rates of adverse events did not substantially increase with subsequent doses of Bexsero. Next slide. Seroresponse was assessed after dose 2 on a 0-6 month schedule and after doses 2 and 3 on a 0-6 month schedule. Next slide. Seroresponse for the FHBP, NHBA, and OMV strains were higher following dose 2 with the 0-6 month schedule. Next slide. Compared to dose 2 of the 0-6 month schedule, with overlapping confidence intervals for the OMV strains. This corresponds to PICO 1. Next slide. Seroresponse to all 4 strains increased with a 3rd dose on a 0-6 month schedule. Next slide. Compared to dose 2 on the same schedule, with some overlapping confidence intervals. This corresponds to PICO 2. Next slide. The work group felt that the desirable effects were small for PICO 1 and small to moderate for PICO 2. Next slide. The work group felt that the undesirable effects were minimal to small for PICOs 1 and 2. Next slide. For PICO 1, the work group felt that the balance of benefits and harms favored the new dosing schedule or both schedules. And for PICO 2, the work group felt it favored the new schedule. Next slide. Now for the values domain. Next slide. Vaccine coverage from NIST may inform how adolescents and their parents value prevention of meningococcal serogroup B disease. Approximately 32% and 13% of 17-year-olds received at least 1 and 2 doses, respectively, in 2023. Next slide. The work group did not know if the target population felt that the desirable effects are large relative to the undesirable effects for PICO 1. For PICO 2, the work group was divided, as some felt the desirable effects were probably large relative to the undesirable effects, and some did not know. Next slide. The work group felt there was probably not important uncertainty or variability in how much people value the main outcome. Next slide. Now to the acceptability domain. Next slide. Harmonized dosing schedules for Bexsero and Truminba would likely be viewed favorably by providers. Next slide. Doses administered at a shorter than recommended interval can result in a suboptimal immune response. However, extended intervals prolong the time until one achieves protection. The new schedule may be challenging for patients needing to complete vaccine series prior to complement inhibitor therapy initiation, as persons using complement inhibitors should be vaccinated at least 2 weeks before complement inhibitor initiation, unless the risk for delaying treatment outweigh the risk for developing meningococcal disease. Next slide. Among unvaccinated persons for whom complement inhibitor therapy cannot be delayed, antimicrobial prophylaxis should be administered alongside meningococcal vaccination and continued for 2 weeks after vaccine administration. Persons taking complement inhibitors likely remain at substantially increased risk for meningococcal disease, even if vaccinated and/or taking prophylaxis. Providers could consider continued antimicrobial prophylaxis for the duration of complement inhibitor treatment based on clinical judgment. Next slide. The work group felt the new dosing schedule was probably acceptable to key stakeholders for PICOs 1 and 2. Next slide. Now to the resource use domain. Next slide. The number of doses remains the same for most healthy adolescents, except for situations in which the spacing is invalid. An additional dose will be needed for persons at increased risk. Next slide. The price per dose of Bexsero is higher than for Treminba. It is possible that harmonization of these two schedules can increase pricing competition. Next slide. The work group felt that the new dosing schedule is probably a reasonable and efficient allocation of resources for PICOs 1 and 2. Next slide. Now to the equity domain. Next slide. Schedules that require extended intervals or additional visits could disproportionately affect populations with lower access to health care. Next slide. Among adolescents initiating MenB vaccination and not eligible for the Vaccines for Children program, 49.6% and 35.5% completed their Bexsero and Treminba series, respectively, by age 17 years. Among those eligible for the VFC program, 51.4% and 16.2% completed their Bexsero and Treminba series, respectively. In other words, series completion was disproportionately delayed among the VFC-eligible population with an extended dosing interval. Next slide. Among commercially insured adolescents, 67% and 60% of those initiating vaccination completed their Bexsero and Treminba series, respectively, by age 19 years. In other words, series completion improved by 19 years, but still lagged for Treminba compared to Bexsero among commercially insured persons. Next slide. As such, the work group felt that equity would probably be reduced or not impacted for PICO 1 and probably not impacted for PICO 2. Next slide. Now to the feasibility domain. Next slide. Providers may need to make adjustments to their practices, including the reminder recall systems. This is especially relevant for providers who administer MenB vaccine shortly prior to college matriculation. Even though the proposed schedule for Bexsero will align with that of Treminba, different manufacturers' MenB vaccine products remain not interchangeable. Next slide. The work group felt the new dosing schedule would be feasible to implement for PICO 1 and 2. Next slide. Next slide. A summary of the evidence to recommendations framework is depicted here. Next slide. For PICO 1, the work group landed on a spectrum of desirable and undesirable consequences being closely balanced to desirable consequences clearly outweighing undesirable consequences. For PICO 2, the spectrum was desirable consequences probably or clearly outweigh undesirable consequences. Next slide. The work group felt there is sufficient information to move forward with a recommendation. Next slide. The work group does recommend the intervention for PICO 1. Next slide. And for PICO 2. Next slide. The proposed language is depicted here. ACIP recommends MenB4C, Bexsero, be administered as a 2-dose series at 0 and 6 months when given to healthy adolescents and young adults aged 16 through 23 years based on shared clinical decision-making for the prevention of serogroup B meningococcal disease. ACIP recommends MenB4C, Bexsero, be administered as a 3-dose series at 0, 1 through 2, and 6 months when given to persons aged greater than or equal to 10 years at increased risk for serogroup B meningococcal disease, i.e. persons with anatomic or functional asplenia, complement component deficiencies, or complement inhibitor use, microbiologists routinely exposed to Neisseria meningitidis isolates, and persons at increased risk during an outbreak. Next slide. I will now move into the third and final presentation. Next slide. The proposed recommendations will align with the updated FDA label for Bexsero and will be harmonized with existing recommendations for Truminba. The advantages of the new recommendations would be that the new dosing schedules are associated with increased immunogenicity compared to the previous schedule, and harmonization between Bexsero and Truminba dosing intervals and schedules will likely be viewed favorably by the providers. The disadvantages include that a longer interval between doses increases the time to achieve vaccine-induced protection and may delay series completion, and that persons receiving complement inhibitor therapy may need prolonged antimicrobial prophylaxis due to the extended time for vaccine series completion. Next slide. Consistent with the new label, the workgroup recommends healthy adolescents and young adults receive the 2-dose Bexsero series with doses at 0 and 6 months based on shared clinical decision-making, and that persons aged greater than or equal to 10 years at increased risk for serogroup B disease receive the 3-dose series with doses at 0, 1 through 2, and 6 months. Next slide. The proposal language is depicted here. This is the language ACIP will vote upon. Next slide. I will now review the proposed and existing CDC clinical considerations. These do not require an ACIP vote. There is no recommendation to recall persons previously vaccinated at 0 and at least 1 month, and this includes healthy adolescents as well as persons at increased risk. Persons should continue with booster vaccination as previously recommended. Next slide. The work group wanted to add an option for persons desiring immediate protection who initiate vaccination shorter than 6 months before anticipated increased risk. For example, new college students who start the series just prior to matriculation. The proposed clinical considerations include language that when immediate protection is desired for a healthy adolescent or young adult based on shared clinical decision-making, providers may administer the 3-dose series at 0, 1 through 2, and 6 months. This would apply to both Bexsero and Truminba. Next slide. The CDC clinical considerations depicted here are applicable to Truminba and are anticipated to be applicable to the new Bexsero schedule. They are, when administering the 2-dose series, if the second dose is administered less than 6 months after the first dose, a third dose should be administered at least 4 months after the second dose. A second dose administered at least 6 months following the first dose is valid and does not need to be repeated. When administering the 3-dose series, a third dose is not needed if the second dose was administered at least 6 months after the first dose. If the third dose is administered less than 4 months after the second dose and less than 6 months after the first dose, the dose should be repeated at least 4 months after the last dose. Next slide. Unchanged clinical considerations are depicted here. MenB vaccines from different manufacturers are not interchangeable. Bexsero may be administered simultaneously with other vaccines, and contraindications include a severe allergy to a prior dose or component of the vaccine, and precautions include pregnancy and a moderate or severe acute illness. Next slide. I would like to acknowledge those here for their contributions and now open this presentation for questions.
Can we go back to the proposed vote language, please? Are there questions from committee members for Dr. Schilly? Dr. Sines.
Thank you. So this is a clarification on the clinical considerations going forwards for patients who have already received their 2 doses. So there will not be a recall or going back to try to get people in for their 3rd dose of vaccine, if I understand this correctly. So then if somebody has already received their 1st dose and they're coming in for a 2nd dose, you would tell them to defer to the 6 months? So it would be a recommendation going forward as of whenever this language passes?
That's correct. We do not plan on a recommendation to recall persons previously vaccinated, but this is moving forward. The new schedule should be followed.
Dr. Asturias?
Yeah, thank you for that great presentation, and certainly it seems that not only the proposal aligns with the new label, but also at the same time may have some benefits. The drawbacks are the completion rates, and I question, do you have any data, even though we are not comparing apples, with the completion of 2nd dose for the quadrivalent vaccine? So in other words, is this an effect of our shared decision-making versus, the recommendation? Do you see the same effects on the quadrivalent?
So we haven't compared this to quadrivalent, but certainly our vaccine coverage data do show that, for example, the VFC population has a more delayed series compared to the non-VFC population with an extended interval when comparing Trumenba versus Bexsero, but we haven't compared this to quadrivalent.
Dr. Schechter?
I'm just wondering if, at your convenience, you can share the difference between the 0.1 and the 0.6, what the immunogenicity differences were, and also how important is this 2nd dose, or what are the post-dose 1 titers in the immunocompromised or the at-risk populations?
So it's pretty small, but if you can pull up, I guess, slide 22. So it's pretty small, but so this slide shows comparison. This would relate to the high-risk patients. So the 2 arrows would show essentially the previous immunogenicity. Granted, that would have been a 0-2-month schedule as opposed to a 0-1-month schedule versus the increase in immunogenicity with the 3rd dose. So you can see for some of the strains, it's very minimal. For others, it is a larger difference. So that would be for the high-risk patients. And then if you can go back 2 slides, I guess it would be slide 20. So this would show like the healthy adolescents. So you can see, again, if you look at the height of the bars, it is a little bit higher for the 4 strains, but for some of the strains, the increase in height is fairly small.
Thank you for walking through it again. I appreciate that.
Dr. Gamboge? Yeah, thanks very much. I want to go back to slide 22 again and just clarify what high risk means. So is your question, what
Was there
are
a
these
question?
high-risk populations?
Yes. What constitutes the high-risk population?
Sorry, I didn't hear the question, sorry. So the high-risk question is persons taking complement inhibitors, persons with an inherited complement component deficiency, persons with functional or anatomic asplenia, microbiologists routinely exposed to Neisseria meningitidis outbreaks, and to Neisseria meningitidis isolates, and then persons at risk during an outbreak situation.
Dr. Chu?
So does high risk include people going to college?
No, they are not included in the high risk. They're included under the non-high risk shared clinical decision-making recommendation. But we do want an option for them to be able to get this 3-dose series, so they could at least get 2 doses in, likely before they move off to college, and then they'd have to finish the 3rd dose after they're at college. This is for those who don't initiate their series prior to 6 months before college enrollment.
I see. I guess my concern is just looking at the VFC numbers, is that people may age out of VFC before they get their 2nd dose if there's this delay and right before they go to college. So they would get their 1st dose in, then go to college, then turn 19, and then no longer be eligible. And so that I'm glad that you included that caveat in the clinical considerations portion to address that. Thank you.
Could we get the proposed vote language back up, please?
And to Dr. Chu's point, maybe in clinical considerations, that can be spelled out about aging out. Thank you.
Will it be in the VFC? While we're getting the proposed vote language up, Ms. Arthur, do you have a quick comment?
Yes, thank you, Dr. Wharton. A couple of quick things. One, on the clinical considerations here, I know there was a letter sent in that reinforced the need for those who are getting complement inhibitors to potentially have their clinicians guided on starting earlier in the treatment. Otherwise, they're waiting 6 months to start and could actually have a lot of issues and degradation of their disease. So if there could be approaches used to help clinicians potentially do the schedule 016, do the antibiotics, but start the treatment earlier, that would be advisable. Secondly, I'm just going to go back because I know I have a few minutes. On the cost effectiveness modeling done under GSK, we noticed the prices are very off to the marketplace, and we would definitely suggest the working group go back and look at those and make sure we're using appropriate market prices, because there was a lot of sensitivity to that issue within the models, and that could help with decision-making by the group. And lastly, we just want to make sure that we're thinking about the equity issue with regard to all the different ways we're using ABCWY in the considerations of the recommendations. Thank you for the opportunity to comment.
Thank you. So this is the language that the work group has proposed. This would require 2 different motions and 2 votes to address these 2 components of the new schedule. Is there a member who would like to make a motion?
Make a motion. Edwin Asturias, no conflict, make a motion.
So Dr. Asturias, what are you making a motion on?
For the first ACIP recommended Bexero for 0 and 6 months.
So Dr. Asturias has made a motion for an ACIP recommendation as listed in the first bullet on the slide for the 0-6 month schedule. Is there a second?
Dr. Lair, second.
Dr. Lair has seconded the motion. Is there any additional discussion about this motion? Okay, hearing none, we will go on to the second component of the proposed language for the high-risk 3-dose schedule. Is a member interested in making a motion regarding this proposed language? Dr. Sineas?
I would like to make a motion that ACIP recommends MenB4C to be administered as a 3-dose series for persons at increased risk.
Thank you, Dr. Sineas. Dr. Jamieson?
I'd like to second that.
So Dr. Jamieson has seconded the motion for the 3-dose schedule. Does this motion require any additional, is there any additional discussion needed on this part of the question? Okay, not seeing any. Dr. Schilly, can we now move on to the VFC resolution?
Yes, please.
Okay. So when we get the slides up, we'll turn things over to Dr. Santoli to review the VFC resolution that will, I believe, accompany these two votes, should they pass. We have actually a break scheduled at 10:40, and in order to get the appropriate slides loaded up, we're going to take our break now, and we'll reconvene at 10:50. So see you in a few minutes.
Okay. So we're going to walk, oh, sorry.
It's now 10:50. We'll resume, and we'll start with Dr. Santoli presenting the updated VFC resolution for your consideration.
Thank you. So we're going to walk through the VFC resolution. Next slide. As a reminder, things that are not changed are in black font. You'll see that most of the resolution is in black font, and we've highlighted in orange what is changed. Next slide. So the purpose of the resolution is to update the resolution to revise the recommended vaccination schedule and interval sections within the meningococcal B component of the resolution, and to update linked documents as needed throughout the resolution. Next slide. In the first component, the meningococcal conjugate vaccines, there are no changes to the eligible groups. Next slide. No changes to the table within the recommended vaccination schedule and intervals. Next slide. There is a slight change where we updated the link to be the latest statement from the ACIP on meningococcal vaccination. No changes to the recommended dosage or the contraindications and precautions. Next slide. In the Men B component of the resolution, there are no changes to the eligible groups. Next slide. But in the recommended vaccination schedule and intervals table, you'll see that the top row of that table okay, you'll see the top row where Bexsero had its own row is going to be removed, and actually Men B 4C Bexsero is moving down into the second row, and it will have the same dosing schedule for primary series and booster dose as Trumemba. Next slide. There are no changes to the table notes, the recommended dosage, or the contraindications and precautions. Next slide. For the final component of the resolution, there are no changes to the eligible groups for the combined meningococcal vaccine. Next slide. Within the table for the recommended schedule, there was a minor change to remove the word monovalent, which we felt was not the appropriate word, and to just refer to Men B FHBP, and then in parentheses, Trumemba. Next slide. No changes to the table notes, recommended dosages, or contraindications and precautions. Next slide. And then no change to the statement about upcoming published documents. And that concludes the VFC resolution update.
Is there some proposed vote language for the VFC resolution? Are there any questions? Are there any comments about this presentation or questions for Dr. Santoli on the VFC resolution? If not, do we have is a member interested in making a motion regarding the VFC resolution? Dr. Sneas?
I make a motion to approve the Vaccines for Children resolution for meningococcal vaccines.
Dr. Sineas has made a motion. Dr. Maldonado?
I second the motion.
Dr. Maldonado has seconded the motion. Is any additional discussion needed? Not seeing any. Thank you, Dr. Santoli, for that presentation. Thank you for thanks to the committee for a robust discussion during this session. And we will move on to our next session on adult RSV vaccines. This session will be introduced by the work group chair, Dr. Shah. Dr. Shah?
Okay. Thank you very much. I'm pleased to lead this introductory session to the RSV vaccination in adults on behalf of the Adult RSV Work Group. Next slide, please. First, I'd like to thank our CDC co-leads, Dr. Amadea Britton and Dr. Michael Melgar, who have really been exceptional in their leadership commitment and rigor with which they have led our discussions. I'd like to thank my fellow ACIP members on the committee, Drs. Helen Chu, Minnie Cambodge, and Kip Talbot, our ex officio members, and in addition, we have a very active group of liaison members and consultants that have been very valuable in our discussions. I'd particularly like to thank Dr. Camille Cotton, the previous chair of the Adult RSV Work Group, who has really helped me tremendously with my transition to the work group and continues as a consultant member. Next slide, please. And of course, we'd like to thank our colleagues at CDC who continue to contribute their expertise to our discussions. Next slide. So I'd like to summarize what transpired in the June ACIP meeting when ACIP voted to recommend that all adults age 75 and up and adults age 60 to 74 who had increased risk of severe RSV disease receive a single dose of an RSV vaccine. Those who are at increased risk of severe RSV disease would include those with chronic heart, lung, liver, or kidney disease, diabetes with end organ damage or requiring insulin or an SGLT inhibitor, certain blood disorders like sickle cell disease, neurologic conditions, severe obesity, immune compromise, or residence in a nursing home, among other conditions. There was no recommendation for a specific product, which we'll go over in the subsequent slides, and no current recommendation for revaccination. And I should remind all of us that this was a transition from shared clinical decision-making to specific recommendations for ages and medical conditions. Next slide, please. These are the currently FDA-approved RSV vaccines. There are two protein subunit vaccines, each based on the stabilized pre-fusion conformation of the RSV-F protein. The GSK product, Arexvy, is a monovalent vaccine based on the RSV-A serotype. It contains the AS01E adjuvant. The Pfizer vaccine, Abrysvo, is a bivalent vaccine containing RSV-A and B. It has no adjuvant. And there is a mRNA vaccine made by Moderna, Mresvia, which is a monovalent RSV-A based vaccine. It has no adjuvant beyond the presumed adjuvant role of the lipid nanoparticle platform. Next slide. So all three of these vaccines are approved by FDA for prevention of lower respiratory tract infection caused by RSV in adults 60 years of age and up. Next slide. The GSK product, Arexvy, is also approved for prevention of lower respiratory tract disease caused by RSV in adults aged 50 to 59 years who are at increased risk for severe disease caused by RSV in the lower respiratory tract with the conditions I outlined previously. Next slide. The Pfizer vaccine, as we heard yesterday, is approved and recommended by ACIP for active immunization of pregnant persons at any age at 32 to 36 weeks of gestation for the prevention of lower respiratory tract disease and severe disease caused by RSV in infants from birth through 6 months of age. Next slide. And as we heard earlier from Dr. Kaslow, 2 days ago, FDA approved the Pfizer vaccine, Abrysvo, for prevention of lower respiratory tract disease caused by RSV in adults 18 to 59 years of age who are at increased risk for severe disease caused by RSV in the lower respiratory tract. I should say this makes 2 products now that are approved for adults under age 60, one 18 to 59, one 50 to 59, and currently there's no ACIP recommendation for RSV vaccination in non-pregnant adults under the age of 60. Next slide, please. So we are not planning a vote at today's meeting. I will say that since the June meeting, the Adult RSV Work Group has really been reviewing a lot of data relevant to current recommendations and discussing potential policy options moving forward for vaccination in adults under age 60. We will hear presentations from FDA as well as manufacturers, representatives with updates on co-administration, duration of protection, and some data on an important group, immunogenicity in adults with immune compromise, and we'll share our interpretations and hopefully have some good discussions. The next slide, please. So here are the presentations that we'll have today. Dr. Rita Das from Moderna will discuss the mRNA vaccine co-administration with high-dose influenza vaccine. Dr. Iona Munjal from Pfizer will discuss Abrysvo immunogenicity in immunocompromised adults and co-administration with COVID-19 and influenza vaccines. Dr. Susan Gerber from GSK will provide a Season 3 update on Arexvy safety, efficacy, and immunogenicity in solid organ transplant recipients. Dr. Patricia Lloyd from FDA will present results of a self-controlled case series study of Guillain-Barré syndrome following protein subunit RSV vaccination in adults 65 years of age and older. This is data, I will say, that was first presented to the work group 2 weeks ago. So we are still digesting it, but we also want our colleagues on ACIP to be aware of this data in a timely fashion. And then Dr. Michael Melgar will present the work group interpretations on behalf of the work group. And I think that's all I had. And if we wanted to go to the first presentation.
Thank you, Dr. Shah. Our next presentation is by Dr. Das from Moderna. I will ask our next several presenters to please be cognizant of the time you are allotted, as time is very tight in this particular session, and we really need to be careful that we don't run over. Can we get Dr. Das's slides up? Dr. Das, are you on?
Yes, I'm on. And just confirming, you're seeing one screen?
Yes, we are. It looks good. Thank you.
Great. Thank you so much. Good morning, and thank you to the ACIP for the opportunity to present today. I'm Rita Das, the R&D Therapeutic Area Head for Respiratory Vaccines at Moderna. I'll be presenting data from our clinical development program supporting the concomitant administration of our RSV vaccine, Mrezvia, with influenza and COVID-19 vaccines in older adults. Older adults face a significant burden from seasonal respiratory viruses with high hospitalization rates for COVID-19, influenza, and RSV. However, vaccine coverage remains inconsistent in older adults, with influenza at 70%, but remaining significantly lower for COVID-19 and RSV. To address this gap, concomitant administration offers an important tool to improve uptake and protection against these major seasonal viral threats. The Mrezvia clinical development program is comprehensive. Our pivotal study, 301, demonstrated high and durable efficacy against RSV disease, including severe disease in older adults. We used the efficacy and immunogenicity data from our pivotal study to develop a correlative protection model, which could be used to contextualize immunogenicity results from other studies. Today, the focus will be on our co-administration studies, where mRNA 1345 was administered alongside standard dose flu vaccines and COVID-19 vaccines in study 302, as well as high-dose flu vaccine in study 304. I'll present data showing that co-administration maintains strong immune responses while offering a practical way to expand vaccine coverage and protect against these critical respiratory threats. Here are the key takeaways from our discussion today. We have previously shown you data that co-administration of mRNA 1345 with standard dose influenza and COVID-19 vaccines is well tolerated with no safety concerns. Additionally, robust immunogenicity is observed for all influenza strains, COVID-19 and RSV supporting their co-administration. Today's presentation will show you data for co-administration with high-dose influenza vaccine. Co-administration of mRNA 1345 with high-dose influenza vaccine is well tolerated with a safety profile consistent with that observed in our large efficacy study. No events of GBS, ADEM, or myo or pericarditis were seen. Robust immunogenicity is observed for all influenza strains and RSV. RSV titers are lower with co-administration, but using a correlative protection model developed from our efficacy study, study 301, we are reassured that clinical efficacy against RSV disease, including severe disease, would be maintained. Overall, the benefit risk of co-administration of mRNA 1345 with standard and high-dose influenza vaccines, as well as COVID-19 vaccines, is positive. As a reminder, all the RSV vaccine pivotal efficacy studies were conducted differently. In our studies, surveillance for RSV cases was conducted year-round with weekly diary prompts to participants and swabbing of all suspected cases. All cases were used then for efficacy assessment. We conducted surveillance over 3 seasons, and many of our cases came from the 2 high RSV circulation seasons, 22-23 and 23-24. And here's a review of our efficacy analyses. The total number of cases for the 3 analyses is on the left, and the efficacy for RSV LRTD2+ and severe RSV is on the right. We have conducted 3 analyses to date: the pre-specified primary analysis, the first durability analysis, which covered through season 2 in the study, and the second durability analysis, which covered through season 3 in the study. In our pivotal efficacy study, we pre-planned a case cohort assessment of antibodies as the correlate of protection. We collected blood samples from all 37,000 participants, and we measured RSV A and B neutralizing titers at baseline and day 29 from about 2,000 non-cases from vaccine and placebo recipients, as well as from all 271 RSV cases. Our comprehensive case collection allowed for identification of a high number of cases, which facilitated the analysis. Now, antibodies have been demonstrated to play a role in protection against RSV infection in both children and adults. While the mechanism of protection from RSV is likely multifactorial, including antibodies as well as cell-mediated immunity, antibodies may be a surrogate biomarker or a statistical correlate of protection. We used Cox proportional hazards model to determine whether RSV neutralizing antibodies were correlated with the risk of developing RSV infection. And finally, we created a correlative protection model where antibody titers could be used to predict clinical efficacy. This can be particularly useful in the setting of RSV vaccines in order to predict things like efficacy over time with additional doses or with co-administration. Now, here's the graphical representation of our Cox model outputs. I'm presenting RSV-A neutralizing antibody with the LRTD2+ endpoint as representative. On the left is the correlate of risk, with the cumulative risk on the y-axis and RSV-A neutralizing titers on the x-axis. You can see as you move to the higher titers, the risk for RSV infection falls. At high titers, the risk for RSV infection is extremely low. The line for vaccine, red, and placebo, blue, correlative risk are overlapping, indicating it is the neutralizing antibody correlating with protection regardless of vaccination status. This robust risk model allows us to develop the correlative protection model on the right, where antibody titers can be used to predict vaccine efficacy. I want to walk you through this curve. And so at low titers, the vaccine, you are on the steep portion of the curve, where the incremental rise in titers greatly impacts efficacy. However, as the titers increase, for instance, above the 10 to the 4th for RSV-A neutralizing antibody, you hit a flatter portion of the curve. Here, the impact of incremental rises in titer has a lower impact on predicted vaccine efficacy. Now I'll show you our co-administration data for mRESVIA and high-dose influenza vaccine, study 304, and how we use the correlative protection model to provide clinical context for the results of the study. We chose Fluzone HD for the study. Approximately 1,900 participants were enrolled who were randomized 1-to-1 to receive the vaccines co-administered, group 1, or in sequential administration, group 2, Fluzone HD first, and mRESVIA 21 days later. The study enriched for participants 75 years and older. Both co-administration, shown in blue, and sequential administration, shown in gray, generated robust immune responses. I'm showing you RSV-A neutralizing titers as representative for RSV and influenza H3N2 HAI titers as representative for flu, but RSV-B and the other influenza strains were consistent. The titers are a bit lower for co-administration, which has been seen in other RSV and influenza vaccine co-administration studies, although the clinical significance of this is unknown. And here's the immunogenicity results displayed on a forest plot. The GMR is the ratio of immunogenicity of co-administration over individual vaccine administration. On the top part of the panel are the GMRs for influenza. For all strains, including H3N2, the GMR is closer to 1. On the bottom part of the panel are the GMRs for RSV-A and B neutralizing antibodies. The GMRs are just below the pre-specified 0.67 margin, which is the more stringent historical success criteria, but needs to be put into clinical context. Notably, if we had pre-specified a 0.5 margin, which has sometimes been used, all the success criteria would have been met. Next, we used a correlative protection model to contextualize the RSV titer seen with co-administration with Fluzone HD. This slide has a lot of information, so I'll walk you through this. On the left, we have the titers for each biomarker observed with co-administration in blue and individual administration in black. As we mentioned, the titers for RSV-A are above the 10 to the 4th range, which corresponds to the flatter part of the relationship between immunogenicity and efficacy. And you see on the left the predicted vaccine efficacy for LRTD2+, as well as LRTD3+. For LRTD2+, the predicted efficacy for sequential administration and co-administration are both above 70%, and the confidence intervals for the estimates are overlapping. The same is observed for LRTD3+, where the point estimates for efficacy are higher and even closer. Then we have the titers for RSV-B neutralizing antibody. I didn't show you the correlative protection curve for this parameter, but this is a different assay and also puts us in the flatter part of the immunogenicity and efficacy relationship. Again, the predicted efficacy for LRTD2+ are 73 and 69% with co-overlapping confidence interval, and higher efficacy is seen for LRTD3+, again with close point estimates. These data provide confidence that co-administered mRESVIA and Fluzone HD will be protective against RSV LRTD, including severe disease. And now onto the safety. Co-administration was well tolerated and similar to administration of mRESVIA alone. Most reactogenicity events were mild. Injection site pain was the most common local event. Fatigue and myalgia were the most common systemic events. Reactogenicity after vaccination was short-lived, 1 to 3 days. The safety profile was consistent with what has been observed In our pivotal phase 3 efficacy study, there was no GBS or ADEM. There was no anaphylaxis or thrombocytopenia. There was no myocarditis or pericarditis. There was no imbalance in safety events between co-administration and individual vaccine administration. The first co-administration study we conducted was presented in detail at the February 2024 ACIP meeting. This study looked at co-administration with standard dose influenza vaccine, we used Afluria, and COVID-19 vaccine, which was Spikevax bivalent at that point. The data from that study support co-administration of mRNA 1345 with standard dose flu vaccines. And for COVID-19, our data also support co-administration with the periodically updated COVID-19 vaccines. So to close, I'd like to bring the presentation back to the context we provided at the beginning. The burden of respiratory viruses in older adults remains substantial, as reflected by high hospitalization rates. Vaccine coverage could be improved for all vaccines. Concomitant administration of our mRNA 1345 RSV vaccine with flu and COVID-19 vaccines offers an important solution to these challenges. Our clinical data demonstrate that co-administration is not only well tolerated with no safety concerns, but importantly, preserves immune responses which underlie efficacy to influenza, COVID-19, and RSV. And this is key to maximizing protection against these significant viral threats. Thank you again to the ACIP for the opportunity to present today and to all the individuals participating in these studies. With that, we'll be happy to address any questions.
Thank you, Dr. Doss. We've got a few minutes for questions from the committee. Dr. Chu.
So thank you for this nice presentation. I had a couple of questions on your correlative protection curve. I was wondering if you could go back to that slide.
Sure.
And maybe while it's loading, I'm wondering if you were able to do the same analysis for both subtype B, neutralizing antibody, as well as pre-F.
Yes, absolutely. So we looked at, we did it for A, B, and pre-F. A and pre-F correlated with RSV overall. B correlated the best with RSV-B and had a slightly lower correlation with RSV overall, but the general relationships were very, very similar. And we have our manuscript almost ready to submit, which details all of this out.
Thank you. Can I ask one more question about, you showed the standard dose data, and it looks like you met the non-inferiority threshold for standard dose flu vaccine in combination with your RSV vaccine, but with high dose, you did not meet the non-inferiority threshold. And can you comment on why if you've explored why that might be?
Yeah, no, we certainly, with standard dose flu and with COVID-19, all the criteria were met. With high dose flu, while the criteria were met for flu, for RSV, the titers were a bit lower and were just under the pre-specified 0.67 threshold. We thought of a number of things here. I think the 0.67 threshold is a historical threshold that has been used for a lot of vaccines, but it's not clear that it has a clinical significance to it. And so sometimes a bit lower thresholds have been proposed. And so if we had used a bit of a lower threshold, of course, we would have met it. In terms of why, I think, I think with co-administration, it's not uncommon to see a bit lower titers for influenza or RSV, and for us, the lower titers were on the RSV side. And so, we are confident with the correlative protection work that we've done that we're in the range where those titers would not impact clinical efficacy.
A follow-up question to Dr. Chu's question. This is Dr. Wharton. Did the the age of the study populations differ in those two studies?
Yes. So in our correlative protection study, which was our pivotal study, the age of the population was 60 and above. And then for the Fluzone HD co-administration study, the age was 65 and above. So the predictive modeling that I showed you here is adjusted for 65 and above. And then I showed this at the work group, but I did not have that slide up here. But we subdivided the co-administration study to look at 75 and above and see whether, and to ensure that these differences weren't magnified in 75 and above. And actually, 75 and above, the differences were less between co-administration and sequential administration, which we were very reassured by as well.
Thank you. Dr. Talbot and then Dr. Shaw. No, Dr. Shaw.
Yeah, thanks very much. I just was curious about whether you had any data on T-cell responses. I think there's data that even in very high neutralizing antibody titers for RSV, say from challenge experiments, infection is still possible, and it could be the T-cell response that prevents people from really getting sick. So do you have any data on that, and did that correlate? Was that able to be used? You may not have done it, but as a correlate for efficacy.
Yeah. So yes, absolutely. I think the T-cell immunity piece is such an important piece here. In our smaller studies, we have done T-cell responses. We have strong CD4 and CD8 responses, and the CD4 responses are Th1 biased. We do see a correlation between our neutralizing antibody responses and CD4 responses. So that gives us confidence that neutralizing antibody, that neutralizing antibody measure kind of captures the full protective milieu, although it is very likely that this is multifactorial. We did not look at T-cell responses from co-administration, and then the correlates work is very tough with cellular immunity because of the requirement to collect and store samples from all the study participants.
Thank you, Dr. Doss. I don't see any additional questions. Dr. Brooks.
Yes, quick question. So no data on administration of all three vaccines, just either with COVID-19 or with influenza?
Right. We do have them two at a time in our clinical program so far.
Thank you. Appreciate that. And we'll now move on to our next presentation from Dr. Munjal. And again, ask to please stick to the allotted time because time is tight in this session this morning.
Thank you very much. Iona Munjal from Pfizer. I just want to confirm that you can see my slides and hear me well.
Yes, you're good and your slides look good.
I appreciate it. Morning, and thank you to the committee for the opportunity to present our data today. My name is Iona Munjal, and I'm the clinical franchise lead for the RSV programs. Abrysvo is Pfizer's bivalent RSV prefusion F protein vaccine that is currently approved for both adult and maternal indications. This includes a newly expanded indication for adults 18 to 59 years of age who are at increased risk for lower respiratory tract disease caused by RSV. The results I will present today in purple complement prior and future studies in the adult RSV pre-F clinical development program. On the left, we summarize the completed and ongoing studies in older adults, including Renoir, the pivotal phase 3 efficacy study, and data from 2 co-administration studies, including a published flu co-ed study, which met non-inferiority. We've also presented data from the ongoing real-world effectiveness study that continues to evaluate revaccination and RSV administration through 5 RSV seasons. On the right, we summarize studies in younger adults, including those who are in high-risk and immunocompromised populations. And lastly, on the bottom is a summary of the post-authorization safety studies, which are ongoing in adults. Acknowledging that some conditions, including immunocompromising conditions and safety of certain outcomes of interest, are seen infrequently in clinical trials, it's these post-licensure studies that produce sizable data sets over many RSV seasons following licensure. Today, I'll review the data from a study in which RSV, COVID, and influenza vaccines were co-administered. This study demonstrated non-inferiority, providing affirming evidence for the ACIP recommendation to allow administration of RSV with other adult vaccines during the same visit. I'll also discuss data from our study in immunocompromised and high-risk adults, including those with organ transplant, cancer, and those on hemodialysis. Data from this study suggests that a single dose of RSV pre-F may protect the most vulnerable adults from RSV disease. Studies in immunocompromised and high-risk individuals are important due to the high incidence rate seen within this group. Though significant disease occurs in all older adults, the difference in risk between immunocompromised and competent adults is most pronounced in younger patients. Therefore, the MONET study was designed as a single-arm, open-label, multi-center study of RSV pre-F among immunocompromised adults 18 years of age and older. The study enrolled approximately 200 participants at 11 sites in the United States and was conducted beginning in May 2023 and ending in March 2024. The study assessed safety, tolerability, and immunogenicity. All participants received 2 doses of RSV pre-F 1 month apart. Participants had immunogenicity assessments before and 1 month following each dose, and safety assessments were obtained through 7 months post-dose 1, including self-reported electronic diaries during the week after each dose. Qualifying conditions included non-small cell lung cancer, recipients of a solid organ transplant, participants with autoimmune inflammatory disorders on active immunomodulatory therapy, and hemodialysis participants. Inclusion of end-stage renal disease on hemodialysis is consistent with ACIP definitions of clinically immunocompromised used in pneumococcal and COVID-19 vaccine recommendations. All participants received 2 doses of RSV pre-F, and baseline characteristics were fairly balanced across the younger and older age groups, as shown here, along with the study total. The race and ethnicity are summarized, and the median age in the younger population was 51 years and 66 years in the older population. Among the immunocompromised and high-risk conditions, the most common among study participants was autoimmune inflammatory disorders, followed by solid organ transplant. We acknowledge that some of the subgroups contain small numbers of participants. Thus, this safety and immunogenicity data will continue to be complemented by our post-authorization studies that include immunocompromised population-specific analyses. This graph shows immunogenicity results before dose 1, after dose 1, and after dose 2. In this immunocompromised population, for both RSV A and B, geometric mean titers did not increase further after a second dose 1 month after the first dose. Similarly, the geometric mean fold rises, GMFRs, shown across the bottom, were highest after the first dose, with no increase after a second dose 1 month later. In this subgroup analysis by immunocompromised group, RSV-A GMTs and GMFRs demonstrated that all groups had robust responses 1 month post-doses 1 and 2. Interestingly, participants with end-stage renal disease on hemodialysis had the highest baseline and post-dose responses in the trial. Please note that the smaller sample sizes in subgroups should be interpreted with caution due to the wide confidence intervals. Shown here on the slide is RSV-A responses, and I'll now show RSV-B. These are RSV-B GMTs and GMFRs, which demonstrated increases after dose 1, similar to RSV-A responses shown on the previous slide. When comparing RSV GMTs and GMFRs across studies, it was observed that the responses we see in the MONET immunocompromised and high-risk population highlighted by the green box were similar to the responses observed in the Renoir older study on the left. You'll recall that the older Renoir study was the pivotal efficacy trial. On the right is the data we showed in June from younger adults with chronic conditions. This population met non-inferiority to Renoir and were the basis for the recent licensure approval in 18 to 59 years of age. Thus, all ages in at-risk groups demonstrate high titers comparable to those seen in a study demonstrating efficacy for at least 2 years. In the absence of a correlative protection, the results suggest that a robust neutralizing titer response is achievable in the immunocompromised population after a single dose, and fold rises are likely high enough to confer protection. Safety was analyzed overall and by the older and younger age groups as shown here. Local reactions including pain, redness, and swelling were actively monitored within 7 days after vaccination and were shown to be mild in green to moderate in yellow and typically resolved within 1 to 2 days. The dose 1 is shown in the upper 3 graphs and dose 2 is shown below. The most common local reaction was injection site pain, with a greater proportion of participants reporting pain after dose 2. Systemic events within 7 days after vaccination were also mostly mild to moderate and typically resolved within 1 to 4 days. The proportion of participants reporting any systemic event was similar after dose 1 or 2, and the most common event was fatigue. These are the adverse events for the whole study by age group. Given the complex medical history of participants, the most adverse events were expected and not related to vaccination. The proportion of participants reporting any adverse event was slightly higher in the older age group. Severe events were rare, and all were assessed by the investigators to be not related. There were 2 participants with events considered related to vaccination by the investigators. Both were in the 60-year and older age group. One was pain in the upper extremity on day 11 distal to the vaccination site, and the second was in a 66-year-old male with a history of psoriatic arthritis but no cardiac history, who was diagnosed with atrial fibrillation and aflutter beginning 15 days after receiving dose 1. Adverse events of special interest include the aforementioned atrial fibrillation deemed related by the investigator, an additional unrelated event of recurrent atrial fibrillation in a 65-year-old male with a history of atrial fibrillation who had a recurrence 200 days after dose 1 and during hemodialysis. There were no events of Guillain-Barré syndrome reported through the study, nor any deaths. There were 2 events leading to withdrawal, but neither were deemed related to vaccination. To summarize, RSV pre-F was well tolerated with no safety concerns among immunocompromised adults age 18 years or older. 1 dose of RSV pre-F elicited high GMTs and GMFRs in an immunocompromised population, with no additional increase after the second dose 1 month apart. The real-world effectiveness study we presented initial data on in June is ongoing, where approximately 15% of participants are immunocompromised. That study is expected to yield further insight into vaccine effectiveness during the RSV season and regarding the durability of protection in this group. I'll now discuss our study of RSV, COVID, and influenza vaccines, which met non-inferiority endpoints when co-administered during the same visits. Co-administration data is important because RSV has been observed to be given with other vaccines in practice, most commonly influenza and COVID. These are administration claims from October of last year and demonstrate that while about 1/3 of Abrysvo vaccines were administered by a single administration, it was more common to see co-administration with either 1 or 2 or more vaccines. Therefore, we conducted a randomized parallel group observer-blinded study to assess the safety, tolerability, and immunogenicity of co-administration of RSV pre-F with COVID-19 vaccine and influenza vaccine. The study was conducted at 30 sites in the US among approximately 750 healthy adults 65 years of age and older who met study criteria. Groups were approximately 150 participants and were randomized at visit 1 to receive COVID alone, RSV or influenza QIV vaccine, RSV co-administered with COVID vaccine in the right arm and placebo in the left, or RSV co-administered with COVID vaccine in the right arm and influenza vaccine in the left arm. Participants had immunogenicity assessments before and 1 month following vaccination. Safety assessments were obtained through 6 months post-vaccination, including self-reported electronic diaries during the first week after vaccination. The COVID-19 Comirnaty vaccine used in the study was bivalent, containing both the original BNT162b2 vaccine and the Omicron BA4-BA5 sublineage. The influenza vaccine used in the study was quadrivalent Fluzone high dose. Demographic and baseline characteristics were balanced across vaccine groups, and the median age was 70 to 71 years. As per the protocol, the study was designed to show a twofold non-inferiority or a margin above 0.5. Among participants who received RSV and COVID co-administration, the geometric mean titer ratio met the pre-specified twofold non-inferiority per protocol and met a more stringent 1.5-fold non-inferiority for all 4 antigens shown by the dotted line. Participants who received RSV, COVID, and flu co-administration demonstrated a geometric mean titer ratio that met the twofold non-inferiority per protocol shown by the dotted line. The antigen responses even met a more stringent 1.5-fold non-inferiority for 7 of the 8 antigens, with the Omicron BA.4, BA.5 antigen meeting the twofold non-inferiority pre-specified endpoint. Local reactions within 7 days after vaccination in the co-administration groups were mostly mild to moderate and typically resolved in about 1 to 3 days. The vaccine reactogenicity was very similar when you compare a combination vaccine to its own standalone comparator or comparator vaccines. The most common local reaction was injection site pain, with a greater proportion of participants reporting pain after vaccination with a COVID vaccine or combo, followed by influenza vaccine. Severe local reactions were rare and similar to those observed with single administration studies. Systemic events within 7 days after vaccination, the co-administration groups were mostly mild to moderate and typically resolved within 1 to 2 days. As with local reactions, systemic reactions with co-administered vaccines were typical with what was seen in their standalone counterparts. The most frequent systemic event in all vaccine groups was fatigue, with a greater proportion of participants reporting fatigue in the triple co-administration group. These are the adverse events for the standalone or co-administration groups. Overall, the adverse events were similar across all vaccine groups. These are the related events. They varied, with the most frequent being lymphadenopathy. None of these were assessed as serious by the investigators. There were 2 severe AEs, 1 unrelated episode of stroke in the COVID vaccine group, and 1 related event of injection site hemorrhage in the triple co-administration group. That event resolved. The proportion of participants reporting serious adverse events was similar across all vaccine groups, and none were assessed by the investigator as related. The proportion of adverse events of special interest were between 2 and 6% across all vaccine groups, and all of these were COVID-19 infections. There were no events of Guillain-Barré syndrome reported throughout the study, nor any deaths. In addition to this study, Pfizer continues to review data with the oversight of our data monitoring committee in the ongoing and clinically complete trials in adult, pregnant women, and children. And there have been no new cases of GBS or polyneuropathies identified in any of the clinical trial or study populations. The only 2 related GBS cases identified in clinical trials occurred within an older adult original pivotal trial, and those are reflected in the original 2023 label.
Can you please wrap this up? Thank you.
Of course. So in summary, co-administration is common. Safety and immunogenicity data from the study and prior study on influenza co-administration study supports the ACIP co-administration guidelines regarding RSV with COVID and/or with flu vaccines. Safety and immunogenicity was demonstrated for a single dose of RSV pre-F in immunocompromised and high-risk adults. And ongoing clinical trials and post-licensure studies continue to provide meaningful data to assess the safety, effectiveness, and benefit risk of the product. There have been no new safety concerns identified in the post-licensure period to date. Thank you very much, and I'll be happy to take any questions.
Thank you. Are there questions from the committee?
Hi, this is Kip Talbot. Can you talk a little bit about why you spaced the vaccine so close together for the immunocompromised when we know that you get much better immune responses as you space them out?
Yeah, thank you very much for that question. So what we didn't know at the time was whether or not we could achieve robust immune responses on that first dose or not. We had seen from prior studies that we have published from healthy immunocompetent adults that there was no boost after 1 year. And what we were trying to achieve was data to see whether or not the immunocompromised persons could be protected before 1 RSV season. So it was critical that we achieved protection early on. When we saw those robust responses and no increase in dose in the second dose, it leads us to think that we need to now explore these more extended vaccine schedules as we're doing in ongoing revaccination studies.
Any other questions? Dr. Chu. Dr. Shaw.
Okay, yeah, thank you very much for that. I certainly applaud you for studying immunocompromised individuals. It's obviously an important group at risk for RSV disease. I will say that I think, and I think the work group has already expressed this opinion that the range of immunocompromised individuals in this particular study is on the mild side, particularly with the inclusion of people with end-stage renal disease who do have altered responses, but I wouldn't put it in the range of the solid organ transplant recipients, for example. And then certainly, I know my colleagues on the work group would encourage evaluation in folks that are much more immune compromised, for which we see most severe disease, people with bone marrow transplants and the like. I did have one question about the severe events in the immunocompromised host study, and wondered about what they were, and if, in particular, if there were any episodes of transplant rejection that were observed.
Yeah, thank you very much for the question. So in regards to the population that we chose, we concur that there are a wide range of immunocompromised populations. We are doing a much larger post-licensure safety and effectiveness study in which persons in that study will be evaluated for sub-analyses by immunocompromised states. So we hope to gain more information through that. And also we have done studies looking with and without the hemodialysis population, and the results are similar. Without the hemodialysis population, the GMFR is still 8 post-vaccination. In regards to the severe events that you identified that are here, there were 2 participants with severe AEs in the younger group and 4 in the older group. And kidney transplant rejection was among those. There was also an episode that was not deemed severe, but that was an episode of transplant rejection that was lung that is now recovered. Both of those were deemed unrelated by the investigator to vaccination and due to other mechanisms.
Dr. Chu?
So thank you for this nice presentation. These data are really important. I just want to echo Dr. Shah's point about the degree of immunocompromise that you studied. I feel like a lot of the population that we really need the data in are those who are recently post-transplant, particularly lung and stem cell transplant. And I would really encourage you to study that population, because I feel like for clinicians, it might be hard for us to be convinced of a single dose in that population. And we would like to see the data in that population showing similar immunogenicity. Thank you.
Yeah, thank you very much for that. In terms of enrollment, obviously the cadence of enrollment is challenging to enroll that population and to get sizable populations to represent meaningful data. So they are included in the post-licensure studies particularly, and we will be generating data in those populations. And we fully appreciate the importance of that data, and we'll continue to explore it going forward.
Okay, thank you very much. I don't see any additional questions, so we'll move on to our next presentation. Thank you very much, Dr. Munjal.
Thank you.
Next up is Dr. Gerber from GlaxoSmithKline. Dr. Gerber, are you there, and can you get your slides up?
Yes, thank you for the opportunity to speak. We're just going to check and make sure that we are live. Can you hear me? Can you please let
Yes, we can
GSK
hear
share
you.
screen?
We can hear you.
Thank you. Can you please let GSK share screen?
So what you've got, okay. Just a moment. Okay, we can see the
Thank you
slides.
for your patience. Good morning. I'm Dr. Susan Gerber, a medical director at GSK. I'm pleased to be here to share updates on Arexvy. As a reminder, here are the current indications for Arexvy. The recent label update now includes Season 2 data from the pivotal efficacy trial 006, and later in the presentation, I'll provide an update on Season 3 data. Since approval, approximately 9 million doses of Arexvy have been administered in the U.S. We would next like to share with you preliminary results from the 023 immunogenicity trial in lung and kidney transplant recipients. We are focusing on these solid organ transplant recipients as a first step toward understanding Arexvy's role in protecting immunocompromised individuals. Study 023 evaluated the immunogenicity and safety after 1 dose of Arexvy versus 2 doses of Arexvy 1 month apart in lung and kidney transplant recipients 18 years of age and older, as compared to adults 50 years of age and older. At the top are the solid organ transplant recipients. The 1-dose group is in light blue and the 2-dose group is in dark blue. At the bottom in orange are adults 50 years of age and older. The syringes indicate vaccinations. The tubes represent blood samples for humoral immunity. Cell-mediated immunity was obtained in a subset of participants. And at the bottom of the slide is a safety analysis. At visit 1, all groups are vaccinated. At visit 3, the 2-dose solid organ transplant group is revaccinated 1 month after their first dose. Visit 4, 1 month after the 2-dose solid organ transplant group receives their second dose, is the time point of the analysis we'll be sharing today. This study will extend to 6 months and 12 months for further immunogenicity and safety evaluations. To be included in the study, solid organ transplants recipients needed to be at least 12 months out after transplant on immunosuppressive therapy and medically stable. Adults 50 years of age and older needed to be medically stable, but could have chronic stable underlying conditions or comorbidities. Demographics were generally balanced. The majority of solid organ transplant recipients were 50 years of age and older. Approximately 70% were kidney transplants and 30% lung transplants. Time from transplant was a median of approximately 5 to 6 years out. This was a worldwide study, including 8 countries. And now to the preliminary immunogenicity results. For the primary endpoint, neutralizing antibodies for both RSV-A and RSV-B were higher after the second dose as compared to the first dose. Let me discuss this in more detail. Here, you can see the humoral responses for RSV-A on the left and RSV-B on the right. The light blue line is the 1-dose solid organ transplant group, where there was a robust neutralizing antibody response 1 month post-vaccine dose, but not comparable to 1 month post-vaccine dose for adults 50 years of age and older, the orange line. And there is a plateau effect 2 months post-vaccine dose 1. Now, compared to the dark blue line, these solid organ transplant recipients received 2 doses of vaccine 1 month apart. 1 month after the second vaccine dose, you can see there has been an increase in neutralizing antibodies since the 1 month time point, or 1 month post-dose 1. 1 month post-dose 2 neutralizing antibodies reached titers similar to adults 50 years of age and older, the line in orange. Trends are similar for RSV-A and RSV-B. Now, looking at the results by kidney versus lung, the kidney 1-dose group in light purple is similar to the lung 1-dose group in light pink, mirroring the previous slide where there was an initial robust response followed by a plateau effect. For the 2-dose group, dark purple for kidney transplant recipients and dark pink for lung transplant recipients, they are also similar, and they mirror previous results for the 2-dose group, indicating similar neutralizing antibody responses for kidney versus lung transplant recipients. In order to better understand the additional increase in neutralizing antibody responses after a second dose of vaccine, we looked at immunosuppressive regimens. And it is known that the presence of mycophenolate as part of immunosuppressive regimens in solid organ transplant recipients is associated with decreased immune responses, as observed with COVID-19 and influenza vaccines. Here, we looked at the presence and absence of mycophenolate in immunosuppressive regimens of the solid organ transplant recipients who participated in this study. First, We see here the 1-dose and 2-dose vaccine groups when mycophenolate is included in immunosuppressive regimens for the solid organ transplant recipients. For the 1-dose group in light blue, there is an initial increase in neutralizing antibodies 1 month post-dose 1 and then a plateau. For the 2-dose group in dark blue, vaccines administered 1 month apart, we observed a similar increase at 1 month, followed by the additional increase in neutralizing antibodies after dose 2. At this time point, neutralizing antibodies in the 2-dose group approached neutralizing antibody responses observed for the 50 years of age and older group in orange. Now, when mycophenolate is not present in the immunosuppressive regimens shown by light blue dotted line for the 1-dose group and the dark blue dotted line for the 2-dose group, both responses are similar and robust at 1 month after dose 1, followed by a plateau. No additional increase in neutralizing antibody responses 1 month after dose 2. These dotted lines representing solid organ transplant recipients who did not receive mycophenolate are similar to the response observed after 1 dose in adults 50 years of age and older in orange. CD4 positive T cell responses were evaluated in a subset of study participants. There were robust CD4 positive T cell responses across all groups. The solid organ transplant recipient groups had similar CD4 positive T cell responses as compared to the adults in the 50 years of age and older group. And now let's turn to safety. This slide shows solicited adverse events for solid organ transplant recipients post-dose 1 in striped blue and post-dose 2 in solid blue for those solid organ transplant recipients who received 2 doses and adults 50 years of age and older in orange. Local and systemic reactogenicity is broadly similar between the solid organ transplant recipients who received 1 or 2 doses compared to adults 50 years of age and older. Grade 3 adverse events were less than 3% across all the groups. Here I'm showing unsolicited adverse events reported up to 30 days after each vaccine dose. The striped blue bars are reports from solid organ transplant recipients after dose 1, and solid blue bars represent those solid organ transplant recipients after dose 2, and orange bars represent adults 50 years of age and older. On the left side, there is a slightly higher frequency of adverse events following the second dose, but when looking at related unsolicited adverse events on the right, as determined by the investigator, the frequencies between these solid organ transplant recipients after 1 dose as compared to after the second dose are more evenly balanced. The majority of event types reflect what's likely to be background morbidity in the transplant groups, which included types of infections, gastrointestinal syndromes, as well as administration site events, with no specific pattern or clustering of events to suggest a safety concern. Serious adverse events, or SAEs, are shown here broken down by median follow-up time. The adverse event reports after 1 dose in the 2-dose group separate from the group that only received 1 dose. And this is because the median follow-up time for SAEs was 170 days for the group that only received 1 dose versus approximately 45 days for the group that received the first dose until administration of the second dose. We observe that the frequency in the 1-dose group with 170-day follow-up is similar to after the second dose in the 2-dose group with 136 days follow-up. The majority of SAEs reflect background morbidity in the transplant recipient population. There was no specific pattern or clustering of SAEs. The observed frequency of SAEs for adults 50 years of age and older after 1 dose is lower as expected. Overall, the safety profile of dose 1 and dose 2 are comparable, and no safety concerns have been identified in these transplant populations. Now let me provide a brief update on our pivotal efficacy trial. Study 006 is a phase 3 randomized placebo-controlled observer-blind multi-country efficacy study investigating the efficacy of Arexvy in preventing RSV LRTD over 3 seasons. Today, we will be sharing results from the end of study analysis, or the end of the traditional 3rd season in the Northern Hemisphere, with a data lock point of April 30th, 2024. This study includes approximately 25,000 study participants from 17 countries. Case definitions are shown here for your reference. All RSV cases were PCR confirmed. The cumulative efficacy of a single vaccine dose over 3 RSV seasons is 69.1% without season as a covariate and with tight confidence intervals. Likewise, the cumulative vaccine efficacy against severe LRTD over 3 seasons is 72.3% without season as a covariate. When we look at cumulative vaccine efficacy over 3 seasons, including different age groups, RSV-A and RSV-B, at least one comorbidity of interest and at least one cardiorespiratory and one endocrine metabolic conditions of interest, as well as those determined to be pre-frail, we see consistent vaccine efficacy. And each of the subgroups investigated, the lower limit of the confidence interval remains above 30%. Here is data looking at vaccine efficacy of a single dose at specific season time points. Looking at the totality of the data on this slide, some vaccine waning is evident. However, there is clinically meaningful vaccine efficacy of 48% against RSV LRTD in the 3rd season. Here are the same time points as seen on the previous slide, but for vaccine efficacy against RSV LRTD in adults with at least one comorbidity. Vaccine efficacy in the 3rd season was 57.8%. Approximately 39% of participants in the study had at least one pre-existing established comorbidity associated with risk of severe RSV disease. With nearly 25,000 participants in the pivotal efficacy trial, the safety profile of Arexvy remains consistent and acceptable over 3 seasons. Cumulative follow-up occurred across all groups for a median of 31.7 months. There were no reports of GBS or ATEM. After 9 million doses, the safety profile of Arexvy remains unchanged. To contextualize the level of protection of vaccine efficacy over 3 seasons from 006, we turn to the estimated public health impact. Using the example of U.S. 50 to 59 years of age adults with COPD, a high-risk population with unmet needs related to RSV prevention, we can see the additional benefit of vaccination incorporating the new 3rd season vaccine efficacy data. From a 2-year to a 3-year time horizon, an addition of more than 2,300 RSV-associated hospitalizations would be expected to be averted, illustrating the additional value of one single dose of vaccine. Lastly, we'd like to share with you an overview of GSK's evolving clinical development program and planned studies. To focus on select updates, please note that the 012 study is an extension of the 006 study and does include immunogenicity and safety of the different revaccination schedules, as well as persistence of a single dose. The COVID-19 co-administration study is ongoing, and the PCV20 co-administration study results are being analyzed. The Shingrix co-administration study results show non-inferiority when Arexvy and Shingrix are co-administered with an acceptable safety profile. Let me summarize the data you've heard today. 1 dose of Arexvy provides robust RSV-A and RSV-B neutralizing antibody responses and high CD4 positive T cell responses, as well as an acceptable safety profile in kidney and lung transplant recipients. For solid organ transplant recipients on mycophenolate, a 2nd dose of vaccine resulted in RSV-A and RSV-B neutralizing antibody responses that were close to levels observed in adults 50 years of age and older at the same time point. Arexvy provides clinically meaningful efficacy over 3 seasons in 60 years of age and over adults with a continued acceptable safety profile. The estimated public health benefits of Arexvy in high-risk adults 50 to 59 years of age and older are increased given its efficacy over 3 seasons as compared to previous efficacy estimates. Ahead of this year's RSV season, it is important to protect vulnerable individuals 50 years of age and older who are at high risk for severe RSV disease. GSK would like to thank all the trial participants and study investigators whose contributions are greatly appreciated. Thank you, and we are happy to take questions.
Thank you, Dr. Gerber. We've got a couple of minutes for questions from the committee. Dr. Chu, and then Dr. Shaw.
Thank you, Dr. Gerber. That was a really nice presentation. I'm wondering if, I'm really interested in the third season data. And I'm wondering if you could go back to slide number 26. It was a little bit quick. For season 3, this is against RSV LRTI. Do you have any season 3 efficacy against hospitalization?
Thank you for that question. We had in this study 8 total hospitalizations, and the study was not designed to actually conclude vaccine efficacy against hospitalizations. Of the 8 hospitalizations, 2 were in the vaccine arm and 6 were in the placebo arm.
Okay, thank you.
Hi, it's Al Shaw. Thank you very much. As with the previous presentation, I also had a similar question with regard to the serious events in the transplant recipients, whether there were any episodes of transplant rejection.
Thank you for the question. I'm Phil Bryan, GSK Global Safety. There was 1 report of renal transplant rejection in a 72-year-old male, which occurred 147 days after the 2nd dose of RXV. And the patient was also found to have a BK infection on biopsy, which can increase the risk of rejection. Based on the case details, both the investigator and GSK considered this event to be unrelated to RXV. Regarding the grade 3 events, most grade 3 unsolicited events related to isolated types of infection and reflect background morbidity in the transplant groups. There was 1 related unsolicited grade 3 event in those 2 group, which was a case of diarrhea, considered unrelated to GSK. And then unrelated by GSK. And in relation to SAEs, again, there was no clustering in types of SAEs. These generally reflect background morbidity in the transplant groups, and no safety concerns were identified in this study. Thank you.
Thank you.
Similar question to before. Have you looked at extending the interval between immunizations to see if you can get an improved immune response in this population? And I understand that the idea is that RSV season is coming, but the idea is that this will last multiple seasons, so there may be benefit.
Thank you. This is a first step to look at solid organ transplants. And this study will actually, we are expecting 6-month and 12-month results from this particular study. We are looking into and discussing other high-risk immunocompromised populations and hope to perform more immunogenicity studies on different types of immunocompromised populations and discussing study design. And thank you for that comment.
I do not see any more questions from the committee. So, I'm sorry, Dr. Schechter.
Thank you. Thank you for the presentation. I'm wondering how you're approaching the thought about additional doses in the non-immunocompromised, what level of waning or what level of effectiveness would merit consideration of additional doses, and maybe the work group's thinking about that as well.
Thank you for that question. We have demonstrated clinically meaningful efficacy over 3 RSV seasons. The 012 study will extend 006 study and will include another 2 RSV seasons, and that coupled with our immunogenicity 004 study, which has a total of 60 months, will look at different immunization schedules as well as persistence of a single dose. In addition, we're in discussions to perform real-world effectiveness studies that will also include looking at, over time, persistence of a single dose as well. And together, using all this information, we believe that this will help to inform revaccination strategy and future guidance.
Thank you very much, Dr. Gerber. With that, we will move on to our next presentation by Dr. Patricia Lloyd from FDA.
Great. Hello. Perfect. Okay, can everyone hear me okay?
Yes, we can hear you and we can see your slides.
Great, thank you. Good morning or good afternoon. My name is Patricia Lloyd, and I'm a health statistician within the Office of Biostatistics and Pharmacovigilance within the Center for Biologics Evaluation and Research at the U.S. Food and Drug Administration. Thank you for this opportunity to present results from our analysis of Guillain-Barré syndrome, or GBS, following RSV vaccination among adults 65 years and older. Next slide, please. Following a brief introduction, I will present the end of season analysis results, followed by a discussion of our overall conclusions of the findings. Next slide, please. As you've heard, there are currently 3 RSV vaccines approved for use in the US in adults aged 60 years and older. The GSK RSV vaccine, RSV Pre-F3 AS01 or Arexvy, Pfizer RSV Pre-F or Abrysvo, and the Moderna mRNA 1345 or Mrezvia. I will note that the analyses described in this presentation included vaccinations administered through January 2024, which was prior to the approval of Mrezvia. So this presentation will only include results on Arexvy and Abrysvo. In pre-licensure clinical trials, there were a small number of GBS cases identified following Arexvy and Abrysvo, and in reports submitted to the Vaccine Adverse Events Reporting System, or VAERS, GBS reporting rates were higher compared to expected background rates following Arexvy and Abrysvo. Next slide, please. To assess the safety of RSV vaccines among adults 65 years and older, we conducted self-controlled case series study. In an early season analysis presented in June of this year, we included vaccines that were administered through October of 2023. There were approximately 1.3 million doses and a total of 28 cases. In our end of season analysis, which we're presenting today, we have included vaccines administered through January 2024, and with approximately 3 million doses and a total of 95 incident GBS cases, which are inclusive of the 28 cases from the early season analysis. Next slide, please. This figure summarizes our self-controlled case series, or SCCS design. In this design, the GBS rate observed in the risk interval is compared to the rate observed in the control interval. We identified the incident GBS cases during the 90-day post-vaccination observation period, and we defined the risk interval as days 1 to 42 post-vaccination, and the control interval as days 43 to 90 post-vaccination. Incident GBS cases were defined as not having a GBS outcome in the 365 days prior to their GBS outcome observed during the post-vaccination observation period. Next slide. To summarize our methods and design, the study participants included Medicare fee-for-service beneficiaries aged 65 years and older that were enrolled on the date of their RSV vaccination and during 1 year prior to vaccination. All study participants were incident GBS cases during the observation period who were vaccinated with either Arexvy or Abrysvo prior to January 28, 2024. Our study start date was May 2023, corresponding to the approval dates of the 2 RSV vaccines, and the study end date was July 2024, and we included vaccinations through January 2024. We used ICD-10 codes to identify GBS cases in the inpatient care setting within Medicare administrative claims data. And in this study, we calculate the incidence rate ratios and the attributable risk per 100,000 doses and per 100,000 person years. 95% confidence intervals were calculated for the point estimates. We adjusted for outcome-dependent observation time using a Farrington adjustment for seasonality and misclassification of GBS using a positive predictive value, or PPV, adjustment. Additionally, we conducted an analysis with chart-confirmed cases, including Farrington and seasonality adjustments. As a secondary analysis, we stratified the analysis by same-day concomitant vaccination with updated COVID-19, updated influenza, pneumococcal, and shingles vaccine. Next slide, please. Trends in vaccination are shown in this slide, with Arexvy shown in green and Abrysvo in blue. The first vertical dotted line is in October 2023, and this was the vaccination cutoff date that was used in the early season analysis. The more recent results are based on a study that included vaccines through January 2024, the second dotted line. You can see that in our end of season analysis, we've been able to include many more RSV vaccinations. The purple dotted line is the end of the 90-day observation period from the end of the vaccination cutoff date, and the orange dotted line represents the additional 11 weeks that were needed to reach 90% of complete claims. Next slide, please. As mentioned previously, the number of RSV vaccinations and cases included in the end of season analysis is approximately 3 times the number observed in the early season analysis. We observed a total of 95 incident GBS cases in the end of season analysis, with 56 vaccinated with the Arexvy and 39 vaccinated with the Brisvo. Next slide, please. We conducted a medical record review of GBS cases. The first table summarizes our case classification result. Of the 95 incident GBS cases observed, we received records for 75 cases. Of these, 51 were classified as chart-confirmed GBS based on the Brighton collaboration clinical case definition, and 24 cases were classified as having insufficient evidence or deemed not to be a case. There were 20 records that were not returned. The second table summarizes PPV results from the medical record review. Overall, the PPV was 68%. We also present the PPV by the timing of the GBS event from vaccination. The PPV during the risk interval was 62.3%, while the PPV in the control interval was 81.8%. Next slide, please. In this slide, we present a forest plot with the incidence rate ratios and corresponding 95% confidence intervals for our evaluation of GBS and Arexvy from the end of season analysis and the early season analysis. In red, we highlight those results that include the most adjustments. So in the end of season analysis, the analysis with the most adjustments adjusted for seasonality, event-dependent observation time, and PPV in chart-confirmed and non-returned cases. And we observed a statistically significant elevation in GBS risk with a point estimate of 2.46 and a 95% confidence interval of 1.19 to 5.08. I will note 2 key features. First, these results are also consistent when we restrict only to chart-confirmed cases, which is that second incidence rate ratio shown right below. And then secondly, compared to the early season results, we gain more precision in the end of season analysis due to the increased number of GBS cases. So while the point estimate did not change very much in the 2 analyses, we did improve the precision of our estimate. Next slide, please. This slide is similar to the previous slide, but summarizes our results between GBS and Brisvo from the end of season and early season analyses. Again, in red, we're highlighting those results that included the most adjustments. So in the end of season analysis, which adjusted for seasonality, Farrington, PPV for chart-confirmed and non-returned cases, we observed a non-statistically significant elevation in GBS risk with a point estimate of 2.02 and a 95% confidence interval of 0.93 to 4.40. So similarly, our results are consistent when we restrict only to chart-confirmed cases. And again, compared to our early season results also shown here, we gain more precision in the end of season analysis due to the number of GBS cases. And next slide, please. This table summarizes results from the 2 previous slides and provides attributable risk estimates for the end of season analysis, including the most adjustments. For Arexvy, we estimated 0.65 excess GBS cases per 100,000 doses with a 95% confidence interval of 0.18 to 1.12, and 5.71 excess GBS cases per 100,000 person years. For Brisvo, we estimated 0.90 excess GBS cases per 100,000 doses with a 95% confidence interval of negative 0.02 to 1.81, and 7.82 excess cases per 100,000 person years. Next slide. Before presenting our secondary analysis, which includes a stratification by concomitant vaccination status, this table presents the number and percent of GBS cases for Arexvy and Brisvo that received another vaccination, COVID-19, influenza, pneumococcal, and shingles, on the same day as their RSV vaccination. Approximately 36% of GBS cases that received Arexvy and 49% of GBS cases that received Brisvo also received a concomitant vaccination on the same day as their RSV vaccine. Next slide, please. Next slide, please. Thank you. In the seasonality and parenting adjusted analysis of all cases, I think we can go back one. Yeah, thank you. In the seasonality and Barrington adjusted analysis of all cases, we observed a statistically significant elevated risk of GBS among individuals who did not receive another same-day vaccination, and a non-statistically significant elevated risk of GBS among adults who received another same-day vaccination. From this analysis, there was no evidence of a difference in GBS risk among persons with and without same-day concomitant vaccination with RSV vaccines. Next slide, please. In this slide and the slide that follows, I present a summary of the concomitant vaccination results for each vaccine. I want to highlight here that in analyses for both vaccines, the number of cases in the risk and control intervals is relatively small, and the confidence intervals, as we saw in the previous slide, are fairly wide. So in this slide, we focus on results among GBS cases vaccinated with Arexvy. The incidence rate ratio among those with concomitant vaccination was 2.19, and among those without concomitant vaccination, the incidence rate ratio is 3.47. Next slide, please. In this slide, we now focus on results among GBS cases vaccinated with Abrysvo. The incidence rate ratio among those with concomitant vaccination was 2.26, and among those without concomitant vaccination was 4.48. And in the interest of time, we will move on to talk about our discussion and conclusions, but I know that there is a lot of information on both these two slides, so we can definitely come back if there are questions. So next slide. So the study presented today has several strengths worth mentioning. These include the ability to adjust for potential time invariant confounders, our improved precision in our point estimates from using large claims database, which also is a strong representation of the US population age 65 years and older. And with medical record review, we improved our classification of GBS. There are also limitations worth noting. There is still potential for a misclassification of GBS in administrative claims data. Also, we cannot directly compare GBS risk between the two vaccine products. Our estimates of the incidence rate ratio may be sensitive to the number of records that are returned and adjudicated through medical record review. Also, in our design, we may have misspecified the appropriate post-vaccination risk and control intervals for GBS. And despite our ability to control for time invariant confounders, there is still potential for residual confounding. And also to note, attributable risk calculations that are based on a small number of cases may be difficult to interpret. Next slide, please. To summarize our results, the observed versus expected analysis with data through December 2023, we had observed an elevated risk of GBS following both vaccines. These results were not statistically significant for Arexvy when we adjusted for PPV. In the early season SCCS analysis with data through April 2024, we observed a statistically significant elevation in GBS risk following Abrysvo vaccine. These results did not remain statistically significant for Abrysvo when we adjusted for PPV-based multiple imputations. And in our end of season SCCS analysis with data through July 2024, there was a statistically significant elevated incidence rate ratio observed for GBS following vaccination with Arexvy. This risk was elevated yet not statistically significant following Abrysvo vaccination. Results remain the same when we restricted to confirmed GBS cases through medical record review. And lastly, there was no evidence of a difference in GBS risk among persons with and without same-day concomitant vaccination with RSV vaccines. Next slide, please. In conclusion, our findings suggest an increased GBS risk following Arexvy and Abrysvo among adults aged 65 years and older. These results are consistent with pre-licensure clinical trials and surveillance systems such as theirs. The end-of-season SCCS analyses the results from this study are largely chart confirmed from medical record review and include approximately 3 times more vaccine doses in GBS cases compared to the early season FCCS results. GBS risk following vaccination with Arexvy and Abrysvo is rare, with less than 10 cases per 1 million vaccinations. And lastly, there is no difference in the GBS risk among persons with and without same-day concomitant vaccination with RSV vaccine. Next slide. So this concludes my presentation. Next slide. I would like to thank my colleagues that contributed their time and efforts on this study and presentation. And thank you. I can take your questions at this time.
Thank you. So I see there's some questions for Dr. Lloyd, Dr. Asturias, and then Dr. Maldonado.
Yeah, thank you for that very interesting analysis. Anything that you can say about the effect of age on the incidence of GBS?
Yeah, thank you for that question. Unfortunately, we were not able to look at smaller groups of age groups just because of the sample size. So unfortunately, we're not able to speak on that.
Thank you for that presentation. I have a question on slide 9. When you talk about positive predictive value of GBS, can you talk just a little bit more about what the significance of a PPV would be in a situation like this, and what were your? It sounds like you calculated PPV based on MRR in the denominator. So how did you adjudicate the PPV there? And can you just give us a little more detail?
Sure. Thank you for that question. Yeah, so the positive predictive value gives us an idea of how true that diagnosis is, if you will. So of the 95 cases that were observed, we requested records from all of those cases. We had 2 neurologists that reviewed the records and determined, based on right and collaboration clinical case definition, whether the case was a true case. And so what we saw was that, for all of the cases, if we looked overall at the 75 cases that were reviewed, that 68% of those cases were deemed to be true cases. And we did this by risk interval and control interval so that we could use those estimates and apply them to our analyses. And in our PPV adjusted analysis, essentially what we're doing is we're creating multiple data sets where the status of the claims identified cases was imputed by assigning them the status of a chart confirmed status based on the probability equal to the PPV, so that we could estimate, what the precision of our estimate is, based on the fact some of the cases are not necessarily true cases. So in our most adjusted analysis, what we did is we included the chart confirmed cases, and we also included the 20 cases that were not returned, where we're not sure if they're true cases or not, and we applied the PPV based on whether they were observed in the risk interval or the control interval. And we generated an estimate for the incidence rate ratio based on those values.
Oh, I see. So you were using. So it sounds like you used the PPV to calculate, to adjust for the records that weren't returned. Is that what you're saying?
Exactly. Yeah, for the 20.
Okay.
Correct.
So then I have another question. Sorry, briefly. Why do you think the risk, the PPV was just different between the 2 groups?
Yeah, I think that is a great question. One thought that we had, I think that we're still, considering what could be these differences. I think one thing could be is, that perhaps if a physician knows that, or clinician knows that a individual was recently vaccinated, they might be more likely to classify them as GBS, perhaps, even if there might be other things that really could be driving that diagnosis. That's a possibility. Whereas for someone who may not necessarily have the if a physician may not necessarily know that the person was vaccinated, which that is possible if they were vaccinated a while ago, that, maybe they would be more likely to give a diagnosis with more, more sure of that diagnosis, I guess.
Got
I
it.
think
Thank you.
that's
That's helpful. Thank you.
This is Kip Talbot. I just want to send a big thank you. This was data that we really were looking forward to, and I know it was a ton of work. And you did it twice, once interim and once final. So thank you to you and all of your colleagues. It's been incredibly helpful.
Thank you.
Are there any other questions for Dr. Lloyd? Okay, I am not seeing any. Next, we have a request from both GSK and Moderna to make brief comments. And again, because of time in the session, I would ask that the speakers stick to the allocated time. Dr. Friedland, are you ready?
Hear me?
Yes, we can. Thank you.
ACIP members, I'm Leonard Friedland from GSK. I refer the committee to GSK's letter submitted to the Federal Register. When discussing RSV adult vaccine recommendations, GSK thanks the ACIP for the opportunity to comment and requests the following to maximize public health benefit. First, bring to a vote that the RSV vaccine Arexvy, consistent with the FDA label indication, be recommended for the 13 million U.S. adults aged 50 to 59 with recognized medical conditions that increase their risk for severe RSV outcomes. An age 50 to 59 at-risk recommendation would help ensure equitable access to vaccines. Go ahead.
This is Jan Sajari from GSK, so I'm just going to take over. While RXV is now FDA approved for individual age 50-59 who are at increased risk, insurers are not covering the cost of vaccinations without an ACIP recommendation. This is a burden on patient and a barrier to receive the vaccine in retail pharmacy, even if a patient has been prescribed the vaccine by their physician and the prescription is consistent with the approved FDA label. Prevention must be a priority for our community. Lack of vote as today's meeting is a missed opportunity to provide access to the vaccine for this age group in advance of the upcoming respiratory season. Second, we ask the committee to amend the policy from a high-risk recommendation for individual age 60 to 74 to a routine recommendation for all adults age 60 and older, as this also would help close the RSV vaccination equity gap and ensure all those eligible can gain access to this vaccine to help protect them from RSV. Thank you very much for your consideration.
Thank you. We also have a request from Moderna. Dr. Mancy?
Yes, good afternoon. Can you hear me?
Yes, I can. Thank you.
Great, thank you. Good afternoon. My name is James Mancy, and I'm the head of U.S. Medical Affairs for Moderna. Thank you for the opportunity to provide this statement. To address the critical public health need of improving vaccine coverage for RSV and other respiratory infections, such as SARS-CoV-2 and influenza, co-administration of vaccines represents an urgent public health priority. Mresvia has demonstrated robust efficacy and safety, with protection rates up to 86.7% against severe RSV-related respiratory illness. And importantly, this protection has proven durable through 3 RSV seasons, including during periods of heightened viral activity. With a strong safety profile, co-administration simplifies the vaccination process, reducing barriers for healthcare providers and patients alike. Co-administration data, substantiated by correlates of protection, demonstrate that clinical efficacy is maintained. We are committed to providing strong evidence to support ongoing discussions on RSV vaccination strategies, and we're ready to share our data to include at-risk adults. And Mresvia has demonstrated the ability to restore immune responses, offering critical insights into revaccination schedules to sustain protection in vulnerable populations. As we continue to contribute to the evolving landscape of respiratory vaccines, we look forward to working closely with the ACIP and public health to expand access and protection for all individuals at risk of RSV exposure. Thank you.
Thank you. That concludes those comments, and I'll now turn the session over to to the work group leads, Dr. Melgar.
All right. Thank you to the committee. I'm Michael Melgar, Medical Officer in CDC's National Center for Immunization and Respiratory Diseases. Together with my colleague, Dr. Amadea Britton, I co-lead the adult RSV work group. I'll be presenting the work group's interpretations of the data that were presented this morning. And during this talk, I'll refer to the different vaccine products by trade name, and this is for ease of reference. It's not to indicate endorsement of any specific product. Next slide, please. So today we'll cover interpretations of the current RSV vaccine safety surveillance data and the balance of estimated benefits and risks, data on co-administration of RSV vaccines with other adult vaccines, and the clinical trial evidence we've reviewed from GSK and Pfizer in immunocompromised adults. Then we'll summarize some forward-looking policy considerations for the adult RSV vaccine program. Next slide. So we'll start with safety. Next slide. To recap what we knew regarding Guillain-Barré syndrome as of the last ACIP meeting, a small number of GBS cases were observed in clinical trials within 42 days after protein subunit RSV vaccination, in other words, GSK's Arexvy and Pfizer's Abrysvo. Due to the small number of cases, it was unclear whether they represented a genuine association between RSV vaccine and GBS. Then, post-licensure data from the Vaccine Adverse Event Reporting System, the Vaccine Safety Data Link, and from the partnership between FDA and CMS suggested an elevated risk of GBS after protein subunit RSV vaccination. In light of that, the current older adult RSV vaccine recommendation is intended to focus the vaccination program on older adults in whom the benefits of vaccination most clearly outweigh the potential risks. And that includes all adults 75 and older and adults 60 to 74 who are at increased risk of severe RSV disease. And importantly to date, there have been no data to suggest an association between Moderna's mRNA RSV vaccine and GBS, but post-licensure safety surveillance for this vaccine only began in June after its licensure. Next slide. So what have we learned about GBS risk from the FDA CMS analysis since June? As of June, the analysis had recorded about 1.3 million subunit RSV vaccine doses and included 28 cases of GBS identified through diagnostic codes. In the October update, there were about 3.2 million doses and 95 cases of GBS identified through diagnostic codes. So the statistical power has increased with about a threefold increase in sample size. Additionally, FDA was able to conduct chart review of 75 of these initially identified GBS cases, confirming the diagnosis in 51 cases and concluding that 24 did not meet the Brighton collaboration GBS case definition of level 1 through 3 diagnostic certainty. Back in June, we observed an elevated incidence rate ratio of GBS following both GSK and Pfizer RSV vaccination, but estimates were not statistically significant. Now, again, we saw an elevated incidence rate ratio following both vaccines, and the results reached statistical significance for GSK, but not for Pfizer, which had fewer doses administered and therefore less statistical power to detect an association. In June, we saw a potential difference in attributable risk of GBS by product, with a higher estimate for Pfizer. However, with additional data, we now see attributable GBS risk is similar for both products. Now, we also have some data regarding co-administration. Between 30 and 50% of RSV vaccine doses were given concomitantly with another vaccine, and we have no evidence that concomitant vaccination explains the increase in GBS rate after protein subunit vaccination. Next slide. To better contextualize the estimates of risk, the work group has reviewed examples of benefit-risk discussions that have been had regarding other licensed and recommended vaccines that have been associated with GBS. That includes seasonal influenza vaccine. The data on the association between GBS and seasonal influenza vaccine are variable and inconsistent across seasons. And if there is an increased risk of GBS following influenza vaccination, it is small, on the order of 1 or 2 additional cases per 1 million people vaccinated. Influenza disease itself has also been associated with a greater GBS risk than influenza vaccination, which means that vaccination may actually prevent some GBS cases. Next slide. The other example is recombinant zoster vaccine, brand name Shingrix. CDC recommends 2 doses of recombinant zoster vaccine 2 to 6 months apart for all adults 50 and older, and for adults 19 and older who are or will be immunocompromised. Data from a formal benefit risk analysis projected that 3 to 6 additional cases of GBS might occur per million persons who receive recombinant zoster vaccination. Next slide. To turn back to RSV, the work group concluded that available data support existence of an increased risk of GBS after protein subunit RSV vaccination, and that available data suggest that it's comparable to and potentially greater than that of other currently licensed and recommended adult vaccines. Further, there does not appear to be a difference in risk by specific vaccine product between GSK and Pfizer. However, we should consider the risk of GBS in the context of the public health benefits of RSV vaccination. In June, ACIP reviewed results of mathematical modeling of the number of RSV-associated outcomes avertable per 1 million persons vaccinated, compared against the number of potential vaccine-attributable GBS cases. This analysis has been updated to use the most current information on protein subunit RSV vaccine effectiveness, duration of protection, and GBS risk. Next slide. We'll share updated results on behalf of our modeling colleagues.
Oh, sorry.
But first, here's a brief summary of the methods updates. The mathematical model is the same as that presented in June, except for a few changes. The assumed attributable risk of GBS was updated to reflect the results presented by FDA this morning. The duration of vaccine protection was assumed to be 36 months, updated from 24 months based on data presented by GSK. The starting point of first season vaccine effectiveness was updated to include preliminary estimates from an FDA analysis of CMS data. And lastly, the main results evaluate protein subunit vaccination generally rather than the GSK and Pfizer vaccines individually. Again, Moderna's mRNA vaccine is not included in this analysis because that vaccine has not been associated with GBS to date. Next slide. Here are the updated results. The graphs show estimated preventable RSV-associated hospitalizations, ICU admissions, and deaths over 3 consecutive RSV seasons per 1 million older adults vaccinated with a single dose of protein subunit RSV vaccine. These preventable illnesses are not annualized. In other words, they represent the total preventable illnesses over the 3-year period. On the left in green are the preventable outcomes for 1 million vaccinated adults 75 and older, general population. And on the right in purple are those for 1 million vaccinated adults 60 to 74 who are at increased risk of severe RSV disease. Those numbers are compared against the number of GBS cases that might be attributable to RSV vaccination, again per 1 million persons vaccinated, denoted in red at the bottom. The range encompasses the lowest lower bound and the highest upper bound observed in the FDA CMS analysis for either of the GSK and Pfizer vaccines. You can see here that preventable RSV outcomes continued to exceed potential cases of GBS for both populations by a substantial margin, with no overlap in the ranges. Next slide. In addition to the FDA CMS analysis, the work group reviewed and updated data from the Vaccine Safety Data Link. Although those data were not presented primarily here, we'll here summarize the findings for the committee. To date, there's been no statistical signal for GBS in rapid cycle analysis from VSD. And as we saw from VSD in June, though, there continues to be a numerical imbalance in the number of GBS cases after GSK Arexvy vaccination in adults 60 and older, but the number of cases is small and the system remains underpowered to determine whether there is an association with GBS. Similarly, after medical record review, there is a numerical imbalance in the small number of cases of immune thrombocytopenia, or ITP, after GSK Arexvy vaccination without another simultaneous vaccine. But again, the system remains underpowered to determine whether there is an association with ITP. Fewer doses of Pfizer's Abrysvo were administered in VSD, and no conclusions can currently be drawn from this system regarding the safety of that vaccine. Next slide. Now to switch topics, here are the work group's interpretations on co-administration. Next slide. We've seen in practice that co-administration of RSV vaccine and other adult vaccines is common, particularly with seasonal influenza and COVID-19 vaccines. The work group was reassured to see data from Pfizer showing that triple co-administration of protein subunit RSV vaccine, mRNA COVID-19 vaccine, and high-dose influenza vaccine was safe and generated a non-inferior humoral immune response. The work group acknowledges the findings of an inferior RSV neutralizing antibody response when Moderna's RSV vaccine was concomitantly administered with high-dose influenza vaccine, but the clinical significance of this finding is unknown. These data should be placed in the context that there has not been a consistent pattern in the combinations of RSV vaccine with other concomitant vaccinations that resulted in inferior immune responses. Next slide. Here's a table summarizing the RSV, flu, and COVID-19 co-administration results available in older adults. You can see that where data was available, the non-inferiority criteria were met, except for the influenza A H3N2 response when GSK's RSV vaccine was given with adjuvanted influenza vaccine. That result was first presented in 2023. The new exception is on the right. Moderna found that co-administration with high-dose influenza resulted in non-inferior flu titers, but the response to the RSV vaccine was reduced. Next slide. Overall, the workgroup notes our limited understanding of the clinical significance of decreased antibody titers with RSV vaccine co-administration. Given the considerable benefits of co-administration for increased uptake and the evidence of safety, the workgroup continues to feel that co-administration is acceptable. Notably, this RSV-specific language differs from what is in CDC's general best practices guidelines for immunization, which states that routine administration of all indicated vaccine doses simultaneously is recommended for persons for whom no specific contraindications exist. The RSV guidance was drafted using the term acceptable because of the uncertainty in the immunogenicity results from the co-administration studies. This guidance may be updated in the future, and the workgroup looks forward to learning more about the analysis from Moderna regarding an immunologic correlate of protection for RSV when those methods have been peer-reviewed. Next slide. Since June, the workgroup also reviewed the first clinical trial data on RSV vaccination in immunocompromised adults. Next slide. GSK and Pfizer presented results of these trials this morning. Notably, the trial studied safety and immunogenicity following RSV vaccination, but did not estimate efficacy against clinical endpoints. Next slide. GSK's trial included adult participants with renal or lung transplant. 1 month after a single dose of Arexvy, these participants had lower RSV neutralizing antibody titers compared with immunocompetent adults 50 and older. After a second dose of Arexvy 1 month after the first, RSV neutralizing antibody titers increased and were similar to those in immunocompetent adults 50 and older who were at 2 months post-vaccination. GSK also showed that measures of cellular immunity after Arexvy vaccination were similar between immunocompromised and immunocompetent participants. Next slide. Pfizer's trial included adult participants with a variety of immune-compromising conditions, including autoimmune disorders on immunomodulator therapy, solid organ transplant, end-stage renal disease on dialysis, or non-small cell lung cancer on therapy. 1 month after a single dose of Abrysvo, these participants had similar RSV neutralizing antibody titers compared with immunocompetent adults 60 and older from Pfizer's main phase 3 trial. The neutralizing antibody response in participants with autoimmune disorders and solid organ transplant appeared lower than that in adults with end-stage renal disease. A second dose of Abrysvo, 1 month after the first, did not appreciably increase neutralizing antibody titers. There were no specific safety concerns identified in either trial, but one participant in each trial experienced renal transplant rejection after RSV vaccination. In both cases, the investigator judged the event to be unrelated to vaccination. Next slide. The workgroup was encouraged to see clinical trial data in this population, but would have preferred to see data in adults with the most severe forms of immune compromise, including hematopoietic cell transplant and recent lung transplant. The solid organ transplant recipients in the trials were a median of 4 to 6 months 4 to 6 years post-transplants. The workgroup also felt that Pfizer's inclusion of adults with end-stage renal disease used too broad a definition of immune compromise and therefore challenged interpretation of their results. The workgroup also expressed uncertainty in whether neutralizing antibody titers will correspond to similar clinical efficacy observed in immunocompetent older adults. On the other hand, absent clinical trial efficacy data, the workgroup expressed uncertainty in whether 2 doses of GSK's Arexvy would be required to result in adequate protection against severe RSV disease in solid organ transplant recipients. Next slide. Finally, we'll close with some policy considerations in light of the evidence that we just reviewed. Next slide. The workgroup affirms that the current older adult RSV vaccine recommendations are appropriate, namely that all adults 75 and older should receive a single dose of RSV vaccine, and that adults 60 to 74 who are at increased risk of severe RSV disease should receive a single dose of RSV vaccine. Although uncertainty remains about the magnitude of GBS risk associated with protein subunit RSV vaccination, the work group believes that the benefits outweigh the risks among the populations for whom RSV vaccination is currently recommended. Next slide. The work group continues to evaluate recommendations for the use of RSV vaccines in adults younger than 60, acknowledging that there are now 2 FDA-approved products for RSV prevention in this age group. While risk of severe RSV disease increases with age, adults younger than 60 with certain chronic medical conditions have an elevated risk of severe RSV disease, and those with some chronic medical conditions may have risk comparable to that in older adults. Adults from certain racial and ethnic groups may be at increased risk of these conditions at younger ages compared with white adults. And conditions that elevate the risk of severe RSV disease may differ by age group. Conditions that place adults 60 to 74 at increased risk of severe RSV may not confer the same degree of absolute risk in adults 18 to 59. So developing RSV vaccine policy in adults younger than 60 will require continued careful consideration of the balance of public health benefits and risks, as was done for older adults. Next slide. As was discussed at the June ACIP meeting this year, the work group felt that additional data on the potential risk of GBS associated with RSV vaccines was essential prior to considering an expansion to younger adults. Today, we've seen updated results increasing certainty that protein subunit RSV vaccination is associated with GBS risk, though uncertainty remains regarding the magnitude of the risk. These results were shared recently with the work group, and the work group will use them to continue evaluating risks and benefits, including which risk groups among adults under 60 might benefit most. Next slide. Regarding immunocompromised adults specifically, the work group recognizes this is a heterogeneous group who are not all at the same risk of severe RSV disease. While the data presented today covered a subset of those with immune compromise, the work group does not feel they substantially increase certainty that those most severely immune compromised will benefit from vaccination. Therefore, the work group did not feel that the data presented today motivated an immediate policy expansion for this group in younger adults, particularly while the FDA CMS analysis on GBS risk is still ongoing and final results are not yet available. Next slide. A reminder that at the June ACIP meeting, the work group indicated they would like to see the following data before making a recommendation for younger age groups: at least 1 complete season of safety surveillance data, immunobridging data in adults with immune compromise, which we've now seen, and additional data on duration of protection with immune response after revaccination. Next slide. The work group continues to feel additional data are necessary before recommending RSV vaccination in younger adults. Specifically, final results from the FDA CMS analysis from the first season of RSV vaccination in Medicare beneficiaries. Depending on the certainty of the findings, additional data may be needed. Pending certainty in the safety findings, potentially data demonstrating vaccine efficacy or effectiveness against clinical endpoints in the most severely immunocompromised adults, and immunogenicity data after revaccination with longer time intervals. The work group will continue to reevaluate the adult RSV vaccine recommendations as data become available and bring a vote to ACIP when a specific policy change can be supported by evidence. Next slide. And with that, Dr. Britton and I would like to thank the committee for their attention. We'd like to thank the work group and all of the CDC staff who contributed their expertise to this work, and we'd like to turn it back to the Secretariat. Thanks.
So Dr. Melgar, we do have some, take a few minutes for committee questions and discussion.
Yes.
Dr. Asturias.
Yeah, Edwin Asturias, and thank you so much for that great summary. I will encourage, not only the working group, but also others working on the safety of this vaccine to, if using the SCCS method, that we should be looking at age as an important sort of way of categorizing the risk of GBS. I just feel like, not only feel, but I think you have hard evidence showing that Guillain-Barré syndrome is, background rates are higher in older ages, and it's a little bit, counterproductive saying that, because the risk we're seeing here in older ages is there, we're going to be seeing in the lower ages when we know that the risk is lower in those ages. So important to sort of categorize that. And as the data increases in terms of number of vaccinees, I think we should be able to sort of parse out those effects.
Dr. Maldonado? Dr. Snance. Oh, sorry, Dr. Kamboj.
Yeah, just wanted to add a comment on the immunogenicity data that was presented in immunocompromised patients and just highlight the critical gaps that remain, the most glaring of which is the exclusion of patients with hematologic malignancy and hematopoietic stem cell transplant. As an example, in the oncology population, heme malignancies or liquid tumors or hematologic malignancies account for about 10% of all cancers. If you look at RSV-related hospitalizations, more than half of the hospitalization happen in this population. So that's one of the gaps. The other, of course, as Dr. Talbot highlighted, is the redosing and the interval between redosing, the durability of response, and possible immunologic interference between co-administered vaccine to be examined exclusively in immunocompromised patients. Thank you.
Thank you. Dr. Brewer?
I really appreciate the committee summary. The data that framing the lives saved through vaccination, in contrast to the current data on GBS, is really helpful. And I found that to be one of the things that's likely to be remembered through this by the public. The other thing is sort of calling back to a previous presentation. There was a slide up by Pfizer on slide 24 that showed co-administration is now the norm. And I wasn't sure if I was going to discuss it at the time, but I think that's a really important slide. In my own interactions with pharmacists, what I found is that there's a meaningful number who think that there's a problem with the co-administration, that it's not a good idea. And so being able to show that this is a norm is helpful. But let me close by saying that I think that it would be helpful to elaborate on those data in any way that we can to see if there is an equity component here, showing that, that this co-administration is benefiting or not benefiting certain groups. And it may be age groups, but perhaps it could be regional areas that have higher rates, or other groups such as racial groups that are disadvantaged differentially.
Dr. Brooks?
Yes, thank you. I think the summary was excellent. There was a lot of data presented before that, and the summary was needed. I will echo what Dr. Brewer said in terms of that slide 10 that showed the number of hospitalizations, deaths, prevented over 3 seasons versus the number of GBS cases. Again, also in raw numbers, there was a statement maybe 2 cases per million doses given. Those raw numbers are very important. And then lastly, there was non-inferiority not shown in 2 cases, but what Dr. Shaw had mentioned about the T-cell response is crucial in viral illnesses, and so we won't even know the relevance of that lack of non-inferiority. So overall, it just gives me confidence in the process, and it gives me confidence in the fact that this vaccine still works. These vaccines still work. And just remember, 2 years ago, 3 years ago, we had nothing against RSV. And so it's helpful to hear this, and again, reassuring to me.
Dr. Schechter?
I want to second the thanks for the summary and the reassurance that it provided. You mentioned the association with influenza disease and GBS. I'm wondering if there's any information to support an association or with RSV disease and vaccine that would further add to the risk-benefit calculation.
That has been a recurring question in the work group. There have been case reports of individual cases of GBS in which that were preceded by documented lab-confirmed RSV infection. However, there hasn't been an epidemiological study that has, calculated an elevated risk of GBS after RSV vaccination. We know that GBS is often preceded by a respiratory prodrome, and it's very possible that RSV is responsible for some portion of GBS that happens, in the community. Without direct evidence being able to quantify such a risk, that has not been included in any of the benefit risk calculations. But we continue to review the literature to see if anything in that line gets published, and that has been also on the list of analyses that CDC is exploring on whether that can be done with available data sources.
Dr. Melgar, is there anything else the the team would like done in this session?
I think that's it from our
Okay.
perspective.
So with that, we'll conclude the adult RSV vaccine session. We will break for lunch until 1:25 p.m. See you back. Good afternoon. This is Dr. Horton reconvening for Dr. Talbot. And we're ready to start this afternoon's first session on immunization schedules. And so I will turn things over to Dr. Sineas for an introduction of the schedule session. Thank you.
Thank you. I will be presenting the recommendations from the Combined Immunization Schedule Work Group for the 2025 immunization schedules for children, adolescents, and adults. Next slide. The Combined Immunization Schedules Work Group updates the child, adolescent, and adult immunization schedules annually. The child and adolescent immunization schedule summarizes ACIP vaccination recommendations for persons 18 years of age or younger, and the adult immunization schedule summarizes ACIP's vaccination recommendations for persons 19 years of age or older. Additionally, the work group harmonizes the content between the child, adolescent, and the adult immunization schedules. Next slide. Both immunization schedules represent current, approved ACIP policy and are designed to be a guide for healthcare providers to ensure individuals get all the vaccines they need when they need them. Next slide. I would like to emphasize that no new vaccine policy is established by the Immunization Schedules Work Group. The immunization schedules reflect a summary of ACIP vaccine recommendations that have been approved by the CDC director. Next slide, please. I'd like to remind the committee and the audience why we present the schedule for a vote every fall. ACIP's approval is necessary prior to approval by the CDC director and publication of the immunization schedules by CDC. In addition, ACIP's approval is necessary before our partners from the professional organizations listed on this slide approve the schedules. Next slide. The workgroup members for the 2025 schedules are shown here. I would like to acknowledge my ACIP colleague, Charlotte Moser, our liaison representatives, workgroup consultants, ex officio members, and CDC contributors and subject matters listed on the next slide for the contributions to the work group. And particular thanks to our CDC co-leads, Drs. Woody and Issa, for their leadership and guidance. Next slide. Next slide. As a reminder, presentation on updates to both immunization schedules may include the use of vaccine trade names. This is for identification purposes only and does not imply endorsement by CDC. The proposed edits that will be discussed are subject to change based on ACIP's discussion and vote. Next slide. Dr. Issa will now discuss the proposed edits for the 2025 child-adolescent schedule, and Dr. Woody will discuss the proposed edits for the 2025 adult immunization schedule. These edits are intended to incorporate ACIP recommendations that have occurred since October of 2023 and improve readability and utility of the schedule. The session will conclude with discussion of the proposed edits, followed by a vote on the adult schedule and the child and adolescent schedule. I will now ask Dr. Issa to take us through the proposed edits in the child and adolescent schedule. Thank you.
Next slide. Thank you, Dr. Sineas. Good afternoon, everybody. I'll present the 2025 updates to the child and adolescent schedule, which summarizes current ACIP recommendations for persons 18 years of age or younger. Next slide. Next slide. So before we begin, I just wanted to briefly go over how to use the immunization schedule. Instructions on how to use the immunization schedule are included in each version of the schedules. The child and adolescent immunization schedule is made up of a cover page listing all the vaccines in the schedule, Table 1 listing the recommendations by age, Table 2 is the catch-up schedule, and Table 3 listing the recommendations by selected medical conditions. In addition, the schedule has vaccine-specific notes outlining vaccine type, dosing intervals, and considerations for special populations. An appendix listing the contraindications and precautions for each vaccine type, and lastly, an addendum for ACIP recommendations that will occur after the 2025 schedule is published. Next slide. Now for an overview of the proposed updates. I'll walk through the proposed edits to the cover page and tables, and then the vaccination notes, and lastly, the appendix. The blue bolded text signifies updates based on ACIP vaccine recommendations that have occurred since the ACIP meeting in October 2023. In all sections of the schedule, including the appendix, influenza vaccines have been changed from quadrivalent to trivalent, reflecting the vaccine formulations available for the 2024-25 influenza season. Lastly, clarifying edits were made to other vaccines listed on the slide and harmonized with the adult schedule. However, all minor grammatical and formatting edits that are meant to improve the clarity in the language will not be presented. Next slide. Start with the cover page of the immunization schedule. Next slide. Shown here is the cover page with the proposed changes highlighted with a red box. These specific changes are highlighted here in the cover page and are in all sections of the schedule, as we just mentioned. The changes are the ones that show the influenza vaccines have been changed from quadrivalent for trivalent, reflecting the vaccine formulations for this season. And additionally, we have a new row for the cell culture-based inactivated influenza vaccine. Next slide. Okay, we'll go on to Table 1, which outlines the immunization schedule by age group. In Table 1, we added the abbreviation for the cell culture-based inactivated influenza vaccine, as we just described. Further, to harmonize with the adult schedule, we modified the overlaying text for the yellow bars for influenza vaccines to 1 dose annually or 1 to 2 doses annually. Next slide. In the COVID-19 vaccine row, we changed the overlaying text to 1 or more doses of 2024-2025 vaccine, see notes, to reflect the vaccine products currently approved or authorized by the FDA. Next slide. For the inactivated poliovirus row, we deleted the less than 18 years notation from the vaccine column. Additionally, for age 18 years, we changed the gray bar reflecting no guidance or not applicable to the green bar indicating catch-up vaccination is recommended. This change was made to align with the ACIP recommendation in June of 2023 for the use of inactivated poliovirus vaccine in persons aged 18 years or older. Next slide. For the dengue row, we changed the previous yellow bar to a purple bar to reflect that dengue vaccine is recommended for only certain populations in the age group. You'll also notice that we changed the purple legend text from range of recommended ages for certain high-risk groups to range of recommended ages for certain high-risk groups or populations. Next slide. To harmonize with Table 3, the legend for the gray bar was changed from no recommendation, not applicable, to no guidance, no, not applicable. Next slide. So now we'll go on to Table 2, which outlines the catch-up immunization schedule for children and adolescents who start their immunizations late or are more than 1 month behind. Next slide. And there are no proposed updates to Table 2. Next slide. So I'll move on to Table 3, which outlines the recommendations by medical indication. Next slide. Okay, next slide. In the COVID-19 row, the columns for immunocompromised patients and HIV infection with severe immunosuppression have been changed from a yellow to a brown bar to reflect additional doses are recommended. Next slide. For the inactivated influenza vaccine row, we added the overlaying text, solid organ transplant 18 years, to the immunocompromised column. This is to reflect the ACIP recommendation allowing use of adjuvanted or high-dose inactivated influenza vaccine in certain solid organ transplant recipients aged 18 years. Next slide. Okay, now I'll walk through the proposed edits to the vaccination notes, which list the dosing intervals, frequencies, and considerations for special situations for each vaccine in the schedule. Next slide. Maybe the computer's got an after-lunch drowsiness too. I'm not sure. There we go. Okay, so COVID-19 vaccination notes have been revised to be aligned with the recommendation for use of the 2024-25 updated COVID-19 vaccines. Similar to the 2024 schedule, the routine vaccination section describes the recommendations for children and adolescents who are not moderately or severely immunocompromised, and the special situations section describes the recommendations for those who are moderately or severely immunocompromised. In each section, we outline the recommended vaccination series by age group and COVID-19 vaccination history. Next slide. Here also, we added that all vaccine doses should be from the same manufacturer for healthy children ages 6 months through 4 years, and anyone aged 6 months and older who is moderately or severely immunocompromised receiving their initial vaccination series. Next slide. We also provided the link to the guidance on interchangeability of COVID-19 vaccines. Next slide. Lastly, at the end of the COVID-19 vaccination notes, we included helpful information such as the definition for unvaccinated persons, a statement that there is no preferential recommendation for one product over the other, additional dose recommendations for persons who are moderately or severely immunocompromised, as well as links to age transition guidance, interim recommendations, and emergency use authorizations. Next slide. Moving on to the notes section for the DTaP vaccination. In the special situations section, we added a new bullet summarizing the guidance for use of TD in children younger than 7 years of age who have a contraindication specific to the pertussis component of DTaP. As a reminder, DT is no longer distributed in the United States. Next slide. In the Haemophilus influenza type B vaccination notes, we have made 2 updates. In the routine vaccination section, we added the preferential recommendation to use Vaxelis and PEDVax-Hib for primary doses in American Indian and Alaska Native infants. In the special situations section, we added use of early component complement inhibitors to the eligibility criteria for Hib vaccination in children's aged 12 to 59 months. Next slide. The influenza vaccination notes were updated with the recommendations for use of the 2024-25 influenza vaccines, including information for use of adjuvanted and high-dose inactivated influenza vaccines in solid organ recipients aged 18 years who are receiving immunosuppressive medications. Next slide. The MMR note was revised to clarify the recommendations for international travel. The recommendations are now outlined based on age group and MMR vaccination history. Next slide. In both routine vaccination and special situations of the MenB notes, we updated the Bexsero vaccination schedule to reflect the new ACIP recommendation for 2-dose series for healthy adolescents and 3-dose series for those at increased risk for meningococcal serogroup B disease. For healthy adolescents and young adults with less than 6 months prior to college entry, we have indicated that the 3-dose Bexsero series may be used to optimize rapid protection. Next slide. In the pneumococcal notes, we added information clarifying there is no current ACIP recommendation for use of PCV or PPSV23 vaccines during pregnancy due to limited data. A link to the existing data is also provided. Next slide. In the RSV immunization notes addressing use of nirsevimab, we included updated CDC guidance stating for infants born October through March, 1 dose of nirsevimab should be administered within 1 week of birth, ideally during the birth hospitalization. For infants born October through March and April through September, we also included guidance clarifying those infants whose mothers received RSV vaccine in a previous pregnancy should also be given nirsevimab. Next slide. We also added information on the optimal time of year to administer nirsevimab is October through November or within 1 week of birth. Next slide. Lastly, in the RSV vaccination notes, we updated the information on use of the RSV vaccine during a subsequent pregnancy, clarifying additional doses are not recommended. Infants born to pregnant persons who received RSV vaccine during a previous pregnancy should receive nirsevimab. Next slide. Okay, I'll go over the proposed edits for the appendix, which lists the contraindications and precautions for each vaccine in the child and adolescent schedule. Next slide. In the row for MMR and MMRV, we have clarified the use of MMRV is contraindicated in persons with HIV infection. Because MMRV contains the varicella vaccine, we included a note in both the varicella and MMR rows that if MMRV is being administered, both rows should be reviewed for contraindications and precautions. Next slide. Thank you, and we'll take questions.
Are there any questions? Dr. Jamieson.
Thanks. I had more of a comment than it's sort of a question, but we've heard multiple examples during this meeting of the importance of vaccination during pregnancy, both to protect the pregnant person as well as to protect the newborn. And I think as you just saw in these, the messages about pregnancy sometimes get lost in a complex array of footnotes. And despite the importance of maternal vaccination during pregnancy, we have unacceptably low and decreasing rates of many vaccines that are recommended during pregnancy. So I think it's always important to look for opportunities to promote vaccine during pregnancy, and I think the revision of the immunization schedules may be just such an opportunity. Currently, as you saw, pregnancy is included as a medical condition in both the child and adolescent, and as you'll see in the adult tables. And it may really help to separate out pregnancy as a separate table, given the complexity of the vaccine schedules for pregnant persons, which are only going to get more complex as more vaccines come online. And some of the subtleties, as you just saw in those footnotes, really get lost in the footnotes. So I would urge CDC to reconsider how information about vaccination during pregnancy and the postpartum period is summarized and communicated in the immunization schedules. Thank you.
Thank you for that comment. We'll definitely take that into consideration.
Ms. Moser.
Thank you. Dr. Allaire and I were just speaking, so with our meningococcal presentation earlier today, we talked about using a lowered interval for special circumstances, like when somebody's going to college and they don't have the full 6 months. So whether or not we can fit something related to that here would be something that we should consider to clarify it.
Could you show slide 27? Because it looks different in our handout.
Oh, okay, sure.
So,
yes, go ahead.
So there's a comment there that students with less than 6 months prior to college entry, et cetera. But I think that statement would be true for anyone who wants an accelerated protection. And I'm not sure that just giving that one example conveys the work group's thoughts that if someone wants accelerated protection for travel reasons or for other reasons, they could use the accelerated schedule.
Okay.
Does that make sense?
Yes, that makes sense. Thank you.
Thank you.
Can our work group has to adhere to the recommendations made by the meningococcal work group, and in the clinical consideration, that was the only one we saw for college students, so we can't make new recommendations. We have to accept what the other work groups have recommended.
So, Dr. Schilly, would you like to comment on this?
I do agree with Dr. Lair and Ms. Moser's comment. I think to be broad as opposed to restrictive would be appropriate here. I think the college students are probably the most obvious example, but I don't think we should limit it to them.
So I think in the meningococcal work group clinical considerations, which will be coming out from the vote, there might be a broader something that you can reference when you're doing this.
Yeah.
And maybe you could work together with Dr. Schilly on
So
that.
I think, yeah, the CDC clinical considerations will include more broad language than just specifying college students.
Thank you.
Dr. Schilly, since those are CDC clinical considerations, perhaps you all can get those posted online in time for it to be cited by the schedule.
Yes.
Would that help, Dr. Wody?
Yes, that would help. Yes, thank you.
Okay, great. Thank you.
Dr. Brewer.
This is a very low-level comment. On slide 29, I noticed that RSV is referred to as immunization. All the others are vaccination, it seems, and it wasn't clear why there was a switch in language, and if it's meaningful, it should be explained. If it's not meaningful, then maybe just use one term. I couldn't really follow what that was about. And then below, just sort out the heading. The headings have different formattings that I can tell you about offline.
On the pediatric side, the RSV product is a long-acting monoclonal antibody, which provides passive immunization. It's not a traditional vaccine. So I think that's why the change in language.
Thank you.
Dr. Schechter.
Hi, thank you. Maybe a bit off tangent or related both to the best practices as well as the schedule. Have heard from some pediatricians about the implications for a 6-month visit during fall or winter. Now, that would involve 5 or 6 injections for the visit to get the hexavalent antigens, pneumococcal, RSV, COVID, influenza, and rotavirus, 1 to 2 shots to get the 6 antigens in. So I think a reaffirmation of the safety and efficacy of doing so, or additional guidance around that would be helpful. And again, this may be outside of the schedule, but an implementation issue. Thank you.
Are there other questions or comments from committee members? Dr. Cheer.
This is also more of a comment that I've also received quite a bit of feedback that particularly in regards to nirsevimab administration, that the use of the language ideally during birth hospitalization is challenging because hospitals are afraid of not being reimbursed for the nirsevimab administration as part of the bundle. And I know there will be some feedback sessions, but just making others aware as well. Also, in terms of the seasonality of administration for both maternal vaccine and nirsevimab, especially in the Western United States, we have a later RSV season, and so that has also been very challenging in terms of being able to have availability of product later in the season. So, thank you.
Are there other questions or comments? I don't see any. So, Dr. Wody, would you like to proceed with the adult schedule?
Sorry?
Yeah. Would you like to proceed with the adult schedule?
Yeah, sure. Thank you. Next slide. Next slide. Thank you. Good afternoon. My name is Dr. Patricia Woody, and I'll present the 2025 updates to the adult schedule. Some of these will be similar to the updates made in the child schedule. Also, I would also like to give a brief overview of the adult schedule. Instructions on how to use the schedule is included in all versions. The adult immunization schedule is made up of a cover page listing all the vaccines in the schedule, Table 1 listing the recommendations by age, and Table 2 listing the recommendations by selected medical and other conditions. In addition, the schedule has vaccine-specific notes outlining dosing intervals and considerations for special population, an appendix listing the contraindications and precautions for each vaccine in the schedule, and lastly, an addendum for ACIP recommendations that will occur after the 2025 schedule is published. Next slide. I'll walk through the proposed edits to the cover page and tables, then the vaccination notes, and lastly, the appendix. The blue bold text signifies updates based on ACIP vaccination recommendations that have occurred since the ACIP meeting in October 2023. In all sections of the schedules, including the appendix, influenza vaccine has been changed from quadrivalent to trivalent to reflect the vaccine formulation available for the 2024-25 influenza season. Next slide. I'll begin with the cover page. Next slide. In the table of vaccine names and abbreviations, the influenza rule has been updated to include the cell culture, adjuvanted, and high-dose inactivated influenza vaccines. This is to assist providers in interpreting the recommendations in Table 1 for persons aged 65 years and older and solid organ transplant recipients. Next slide. In the pneumococcal conjugate vaccine rule, we have added the newly licensed PCV21 vaccine. Next slide. And in the RSV rule, we have added the newly licensed mRNA RSV vaccine. Next slide. Now I'll go through the updates to Table 1. Next slide. In the COVID-19 vaccine rule, we have updated the overlaying text to reflect the 2024-25 vaccine products currently approved or authorized by the FDA. For age 65 years and older, we have included an overlaying text indicating 2 or more doses of the 2024-25 vaccine is recommended. For other age groups, we have indicated 1 or more doses are recommended. Next slide. In the influenza rule for age 65 years and older, we have an overlaying text clarifying that the high-dose, recombinant, or adjuvanted inactivated influenza vaccines are preferred. Next slide. The influenza rule now includes a new purple bar for age 18 through 64 years with the overlaying text solid organ transplant, C notes, to indicate adjuvanted or high-dose influenza vaccines can be used in this population. Next slide. The RSV rule has been revised, and we now have a yellow bar indicating all adults aged 75 years and older should be vaccinated. We have used a purple bar to indicate the risk-based recommendations for ages 60 through 74 years. Next slide. In the pneumococcal vaccine rule, we have added PCV21. Next slide. Additionally, we now have a yellow bar for ages 50 years and older, indicating everyone in this age group should be vaccinated. For ages 19 through 49 years, we have a purple bar showing this is a risk-based recommendation. In the 65 years and older column, we have continued to include the blue bar indicating recommendation based on shared clinical decision-making. Next slide. New in Table 1 is a rule for inactivated poliovirus vaccine. We have used the yellow bar and overlaying text to indicate adults who are incompletely vaccinated should complete a 3-dose series. We have also clarified self-report of previous doses is acceptable. Next slide. In the Mpox rule, we have added the overlaying text 2 doses for consistency with other rules in the schedule. Next slide. And lastly, in Table 1, to harmonize with Table 2 and with the child and adolescent schedule, we have changed the legend for the gray bar from no recommendation, not applicable, to no guidance and not applicable. Next slide. Now, moving on to Table 2, which outlines the recommendations by medical and other conditions. Next slide. In the COVID-19 role, the columns for immunocompromising conditions and HIV infection with severe immunosuppression has been changed from a yellow to brown bar to reflect additional doses are recommended. Next slide. In the role for inactivated and recombinant influenza vaccines, we have added the overlaying text solid organ transplant to the immunocompromised column. This is to reflect ACIP recommendation for allowing use of adjuvanted or high-dose influenza vaccine in solid organ transplant recipients aged 18 through 64 years. Next slide. In the RSV role, we now have purple bars for all medical conditions to indicate RSV vaccination is recommended for some adults with these conditions who are at increased risk for severe disease. We have used the overlaying text C notes for certain medical conditions that are known to increase the risk for severe RSV disease, prompting providers to review the RSV vaccination notes for details. Next slide. Similar to Table 1, we have added a new role for inactivated poliovirus vaccine. A yellow bar is used with an overlaying text indicating adults with any of these conditions except pregnancy who are incompletely vaccinated should complete a 3-dose series. We have also clarified self-report of previous doses is acceptable. Next slide. Now I'll walk through the proposed edits to the vaccination notes. Next slide. The COVID-19 vaccination notes have been revised to align with the recommendations for the use of the 2024-25 vaccines. The routine vaccination section describes the recommendations for adults who are not moderately or severely immunocompromised, and the special situations section describes the recommendations for those who are moderately or severely immunocompromised. In each section, we have outlined the recommended vaccination series by COVID-19 vaccination history. Next slide. At the end of the routine vaccination note, we have included the recommendation for a second dose in persons aged 65 years and older. Next slide. In the special situations section, we have clarified that the vaccine doses in the initial vaccination series should be from the same manufacturer. Next slide. And we have included the link to the guidance on interchangeability of COVID-19 vaccine products. Next slide. Lastly, we have included the recommendation for additional doses for those who are moderately or severely immunocompromised. Next slide. At the end of the COVID-19 vaccination notes, we provided some information we thought would be helpful to providers, such as noting that there is no preferential recommendation for one product over another, the definition of unvaccinated persons, and links to the interim recommendations and emergency use authorizations. Next slide. Moving on to the hepatitis B vaccination notes. In the special situations section, we have included the recommendations for persons ages 20 years or older who have an immunocompromising condition because the recommended vaccine dose is higher than for those in this age group who are immunocompetent. Next slide. In the hepatitis B note, we are proposing removing the language that states Heplicef B and Prehebrio are not recommended in pregnancy due to lack of safety data in pregnant persons. This change will also be made in the child and adolescent schedule. CDC's Division of Viral Hepatitis is working to update the guidance for the use of Heplicef B during pregnancy based on changes made to the FDA package insert. However, this updated guidance might not be available before the 2025 schedule is published. This proposed deletion was not discussed with the work group due to the time frame for updating the guidance. Next slide. The influenza vaccination note was updated with the recommendations for use of the 2024-25 influenza vaccines, including information that adjuvanted and high-dose inactivated influenza vaccine can be used in solid organ recipients aged 19 through 64 years who are receiving immunosuppressive medications. Next slide. Similar to the child schedule, we've updated the meningococcal vaccination notes with the new Bexsero vaccination schedules for both healthy persons and those at increased risk for meningococcal serogroup B disease. For healthy adolescents and young adults with less than 6 months prior to college entry, we have indicated the 3-dose Bexsero series may be used to optimize rapid protection. Next slide. The guidance for use of Med-B vaccine during pregnancy was updated to clarify that the rationale for delaying vaccination until after pregnancy is due to lack of safety data in pregnant persons. Next slide. In the Mpox vaccination notes, the guidance for vaccinating healthcare personnel was revised for clarity and now reads, vaccination is not routinely recommended specifically for healthcare personnel due to occupational risk in the workplace. Next slide. Now, moving on to the meningococcal vaccination notes, this has been updated with the new recommendation for routine vaccination for those aged 50 years and older, and the risk-based vaccination for those aged 19 through 49 years. Next slide. We have also added the recommendations for use of PCV21. Next slide. And we have provided bullets clarifying that adults who have received either PCV20 or PCV21 do not need additional doses of meningococcal vaccine. And we've included information stating that there is no ACIP recommendations for use of either PCV or PPSV23 vaccines during pregnancy due to limited data. Next slide. Lastly, in the pneumococcal notes, we have included the guidance for when PPSV23 is not available to complete the series in those who received PCV15. In this scenario, a single dose of either PCV20 or PCV21 can be administered. Next slide. The RSV vaccination note has been revised to align with the updated ACIP recommendations. The routine vaccination section now has 2 populations. We have the guidance for pregnant persons of any age and the guidance for use in adults 75 years of age and older. Next slide. In the section for pregnant persons, we have updated the information on use of RSV vaccine during subsequent pregnancy, clarifying additional doses are not recommended. Infants born to pregnant persons who received RSV vaccine during a previous pregnancy should receive nirsevimab. Next slide. In the special situations section of the RSV vaccination notes, we have included the risk-based recommendation for those aged 60 through 74 years, and also included the list of medical and other conditions that increase the risk for severe RSV disease. Language has been added to clarify people can self-attest to the presence of a risk factor. Next slide. Lastly, in the RSV notes, we have included guidance on the optimal timing of the year to administer RSV vaccine to adults who are 60 years and older. Next slide. The routine vaccination section of the TDAP notes have been revised for clarity. We now list the recommendations by previous vaccination history. Next slide. I will now go over the proposed edits for the appendix, which lists the contraindications and precautions for each vaccine in the adult schedule. Next slide. In the role for pneumococcal conjugate vaccine, we've added PCV21. Next slide. And similar to the hepatitis B notes, we're proposing deleting the guidance stating Heplicef B and Prehebrio are not recommended due to lack of safety data in pregnant persons. Use other hepatitis B vaccines if hepatitis B vaccine is indicated. We're proposing deleting this until CDC's updated guidance for use of Heplicef B during pregnancy becomes available. This proposed deletion was not discussed with the work group. Thank you for your attention. I'll now take questions.
Thank you for that whirlwind tour of the adult schedule. Dr. Lear?
Thank you to Dr. Issa and Dr. Wody for a wonderful presentation. I can't think of a year when it's gone so smoothly, and I really appreciate the effort that went into this and the presentations. Could we go to slide 40, please? A small technical note, you had a sentence that said, maybe one back from that. That one. Age 19 and older who's received PCV21, no additional pneumococcal vaccine dose is recommended.
Yeah.
But if you look to the bottom left of that slide, based on shared clinical decision-making, you can give an extra PCV20 or 21. And so there's a discrepancy between those two paragraphs. And so I'm not sure how you want to fix that, but I just wanted to point out the discrepancy.
Okay. Miwako, are you on the line?
I'm sorry?
Yes.
Yes, this is Dr. Kobayashi. I'm on the line if you can hear me. Can you hear me?
Yes, we can hear you.
Yes, we can.
Yes, so I'm sorry, could you point to where you're seeing the discrepancy, Dr. Lear? Because the shared clinical decision-making currently is only for adults 65 and older in the old schedule, completed the recommended series with PCV13 and PPSV23.
So in the top red box on the screen, it says adults age 19 and older who have received PCV20 or PCV21. I'm sorry. I stand corrected. I'm in error. Thank you.
Sorry, here. I was going to point out that the shared clinical decision making is for those who receive PCV13 and PPSV23. So, yeah.
Thank you. My error.
Well, that's the problem with our pneumococcal recommendations, right? Are there? I see that there are some hands from liaison representatives, but before I go to them, are there any other comments or questions from committee members? Okay, Ms. Aker?
Thanks, Dr. Warren. Can we go to slide 32, please? On the hepatitis B, it looks, I have a question about the Prehebrio guidance. The package insert for Hepislav was updated to not include a registry for pregnancy with Hepislav vaccination, but to our knowledge, that was not updated for Prehebrio. So I think there's an error there in which one the pregnancy safety concerns should be updated for. And it's, I believe, one and not the other.
So you think the language should be retained for Prehebrio? Is that?
Yes. The label, the package insert for Hepislav was updated, and I do not think it was updated in the same way for Prehebrio.
That is accurate. The Heplicef B package insert has been updated, and the Division of Viral Hepatitis, they are currently working on a new updated guidance, but that it's not likely, I'm told that is not likely to be available until after the schedule is published. And per our terms of reference, we cannot use the schedule to announce a new CDC guidance or vaccination recommendation. So we have to wait for the Division of Viral Hepatitis to publish their new guidance before we update that language.
Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. I want to compliment the team on updating the language on pregnancy because it is so much clearer than it has been in years past. And I also just want to thank the CDC colleagues on continuing to work on the safety of the hepatitis B vaccine in pregnancy. I feel like it's something that we really need as another thing in our toolbox. So keep up the good work, guys.
Thank you. Dr. Ibarra?
Yes, thank you, Michael Ibarra, liaison for pharma and emergency physician. Thanks for the fantastic discussion thus far. I think my comment goes to slide 16, where honestly it builds on the last discussion we were having with respect to the RSV vaccines. It just sort of jumped out to me, the gray box there in the 50 to 64. And how that can, when there's a difference between FDA approval and the recommendations, how that can create some confusion in clinical settings and certainly access issues for patients. So I thought it was a great discussion and fantastic presentations, but as an emergency physician, I think the opportunity to really change the reality of respiratory viral season is upon us, and with low rates of RSV vaccination, I think there's obviously opportunities there. So thank you, and thanks for the opportunity to provide comment.
Thank you. Dr. Freihofer.
Sandra Feiko for American Medical Association, speaking as a practicing physician. Back on slide 32, Dr. Woody, this is with respect to that comment that the person had just made. So it seems like for right now, it should say the pre-hep, we could delete the pre-hep brio, but we should delete the comment about Heplisab, but we have to keep it for pre-hep brio. Was that what you said? Because that's not what I heard.
No, that wasn't what I said. Our proposal is to remove the entire language until it becomes a CDC policy. If not, we're going to run into an issue where the information on the schedule is different from what is present on other CDC websites. We have to wait for the Division of Viral Hepatitis to finish their work and publish their guidance before we make the change in the schedule. Thank you.
So was that on the schedule already, that note from last year?
Yes, it was there from last year.
Well, would it be more accurate just to take off the one for Heplisab and leave the pre-hep brio on there? Because I think you're putting practitioners at risk until that changes.
If we do that, that is going to be in conflict with the current policy that says that Heplisab and pre-hep brio, the current published policy that says Heplisab and pre-hep brio are not recommended during pregnancy. And that language is not only on the schedule, it's on other CDC websites.
Okay. I still don't understand exactly what we're doing and why we're doing it, but I trust that you do. So I have one other little comment about PCV 21, and I raised my hand yesterday and wasn't called on. It's not available in Atlanta. I've had patients go on the website, try to find it, but is there a problem with supply for the Capvaxive? Does anyone know about that? Because my patients cannot get it. It's not available.
Dr. Freihofer, I don't know if anyone from Merck is on, but Dr. Kobayashi, are you aware of any supplier distribution issues regarding PCV 21?
Yes, thank you. So I think it was mentioned briefly in the statement by Merck yesterday, but according to the manufacturer, it is covered at least by insurance companies, and they were working on ensuring that the vaccines were available, but probably more accurate information would be available from the manufacturer. Thank you.
Dr. Chen?
Yes, thank you for the tremendous work on updating these immunization schedules. And I see that references to pregnancy are listed for some of these vaccines, it would be great if they can be synthesized on the CDC website on vaccination during pregnancy. I think there used to be a very nice, useful table, and that's not there anymore. So if there's a way to resurrect such synthesis, it will be very helpful for clinicians. Thank you.
Yeah, can I respond to that? We do have a separate vaccination schedule for pregnancy available on our website. If you send us an email at nipinfo@cdc.gov, we can send you the schedule and let you know where it is. But it is available in our, I think it's called Pregnancy and Vaccines website. Yeah, thank you.
Are there any additional questions or comments? Is there some proposed vote language for the schedules?
Yes. Let me pull up.
Can we go to the schedule vote language, please? So this is a summary statement that's been proposed for ACIP to approve the recommended child and adolescent immunization schedules. Dr. Brooks?
Motion to approve, excuse me, the recommended child and adolescent immunization schedule, U.S. 2025, and recommendations for adult immunization schedule, United States 2025.
Dr. Brooks has made a motion. Is there a second? Ms. Moser has made a second. Oh. I'm sorry, Dr. Jameson, I didn't see that. So we have a motion and a second to approve the schedules as just presented by Dr. Zisa and Wody. Is there any additional discussion that the committee would like to have? I believe we need to do public comment at the scheduled time. Given that that is the next thing on our agenda, we will break and we'll reconvene for public comment at 2:35 p.m. Eastern Time. Thank you. Sorry, I am sorry. Is it 2:45? 2:35 is public comment. Yeah, I think I must have an old version of the agenda. Hang on.
2:25 is public comment. All right, 2:25.
2:25.
Be fast.
Good afternoon. It's 2:25 p.m. and we are reconvening for our public comment session at this afternoon's ACIP meeting. I'd like to welcome and thank our public comment speakers for addressing the committee today. All of today's speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, each speaker needs to limit his or her remarks to 3 minutes. We are displaying a timer on the screen so you know how much time you have left. We do appreciate diverse viewpoints that are respectful in nature and focused on the issues being discussed at our 2-day meeting. Thank you again to our speakers, and we look forward to your comments. Our first speaker is Mrs. Wukovitz. Mrs. Wukovitz, are you on?
Yes, I am.
Can you speak up just a little bit?
Sure. Can you hear me better now?
Yes, that's much better. Thank you. Please proceed.
Can I start?
Yes, please do.
Okay, great. Thank you. I'm Patty Wukovitz, a registered nurse from New York. Meningococcal vaccination is very close to my heart, and I want to thank the ACIP for allowing me to share my thoughts on this important topic. In 2012, I lost my healthy daughter, Kimberly Coffey, to meningitis B at the age of 17, just 3 days before her high school graduation. Within hours of Kimberly's first flu-like symptoms, she was in multi-organ failure and septic shock and was fighting for her life. Despite a prompt diagnosis and appropriate medical treatment, shortly after she was declared brain dead, and I was faced with the impossible decision to remove her from life support. While she had received the MenACWY vaccine, at that time, meningitis B vaccination was not yet available to her. Since her passing, I've dedicated myself to raising awareness by establishing the Kimberly Coffey Foundation and co-founding the American Society for Meningitis Prevention. I understand the conversation surrounding the review of the current meningococcal vaccination schedule has been postponed. However, I want to ensure that it's revisited as soon as possible because meningococcal meningitis strikes without warning and can be deadly in as little as 24 hours. Meningococcal cases are rising in the U.S., antibiotic resistance is growing, and significant gaps in Men-B vaccine coverage exist with the current shared clinical decision-making recommendation. Also, annual well-visit adherence for older adolescents is at an all-time low. Add to all of this the tremendous confusion among providers, patients, and parents. Through my experience over the last decade, I can attest to the confusion that exists surrounding meningococcal vaccination. While I am ecstatic that attention and focus were given today to discussing the Bexsero dosing change and a second pentavalent vaccine, I worry that current recommendations will remain confusing and perhaps be further complicated without a comprehensive review by the ACIP. But despite being a complicated issue, we have witnessed remarkable innovations related to meningitis prevention. If there is one thing I can leave you with today, we have witnessed remarkable. If there's one thing I can leave with you today, it is not to underutilize innovation. Innovation has yielded Men-B products that now save lives from this very devastating disease. Innovation has finally yielded 2 pentavalent meningococcal vaccines that offer more comprehensive coverage and simplify administration. Yet the current ACIP recommendation for using pentavalent vaccines essentially discourages their use. As a nurse, a vaccinator, an advocate, and most importantly, Kim's mom, I urge you to consider the far-reaching public health consequences of delaying your review of current meningococcal vaccines. Please give routine recommendations for all meningococcal vaccines that support strong, practical, and equitable use of available tools. My daughter didn't have the chance to be vaccinated, but we owe it to all the other children to give them that choice. Thank you.
Thank you, Mrs. Wukovitz, and we're so sorry to hear about your daughter's illness. We're very sorry.
Thank you.
Our next speaker is Ms. Humbert.
Hi, can you hear me?
We can. Please begin.
Okay, thank you. Hi, I'm Chloe Humbert, and I have no conflicts to report. So where is the COVID vaccine campaign? Where are the ads? Where are the billboards? Why are doctors not required to recommend vaccines? If a doctor knew somebody had high blood pressure and they failed to recommend medication, that wouldn't be okay. Yet doctors are remiss in recommending even to patients with known risks. Too many doctors seem to have been tricked by anti-vax disinformation amplification campaigns that have been aimed at North America. Prime Minister Trudeau recently testified about this in Canada. Not to be confused with the Pentagon's anti-vax operations, which were aimed at Asia, but which probably helped confuse Americans too on the World Wide Web. Since when does uptake with vaccination not matter? It's always mattered. The polio campaign in the US was successful because of concerted effort to do a door-to-door campaign that started before the vaccine was even available. Successful vaccine campaigns do not pussyfoot around. High uptake is needed. Evolutionary epidemiologist Rob Wallace submitted a public comment to FDA Vaccine Committee in January 2023, saying that yearly vaccination as a simplified course is the wrong approach because it would, quote, further handcuff a public health response already limited by abandonment of non-pharmaceutical interventions, unquote. But of course, there's no hands to handcuff. The CDC's hands have been idle in the response to COVID. At the June 2024 meeting of this committee, Dr. Denise Jamieson described being, quote, really struck with the low proportion of healthcare providers that recommend it, and given what we know about influenza and other vaccines and the critical role that healthcare providers play in recommending vaccines, unquote. And the doctor was worried that, quote, if it were not a universal recommendation, that the role of the healthcare provider in identifying and appropriately counseling those with risk, that would become even more problematic, unquote. Well, we're there because the restrictions on the spring dose have allowed for some affluent people who are just over 65 to rightly get an extra dose before their fancy vacations. But meanwhile, working class people who are in their early 60s with cardiac conditions or diabetes, working frontline jobs in retail, food service, or at crowded DMVs have been prevented from getting that spring dose because of this pointless gatekeeping of safe vaccines just because of the cost to big health insurance companies and when uptake is in the ditch. Do your job, get vaccines into arms. It's 2024. Where is the progress on vaccine uptake? Thank you.
Thank you, Ms. Humbert. Our next speaker is Dr. Fiscus. Dr. Fiscus,
yes.
you on?
I'm here, thank you.
Okay.
My name is
we can hear you
Dr.
fine,
Michelle
and you can start.
Okay, thank you. My name is Dr. Michelle Fiscus. I'm a board-certified pediatrician, and I serve as the Chief Medical Officer for the Association of Immunization Managers, a 501c3 nonprofit member organization that supports the managers of the 64 CDC-funded immunization programs across the 50 states, 8 U.S. territories, and freely associated states, and 6 major cities. AIM would like to extend its thanks to the members of the ACIP and its work groups for the difficult work you undertake to make recommendations that are based upon the latest and most trustworthy data available at the time. One of the biggest challenges immunization programs face is that vaccinating the approximately 26 million U.S. adults who are uninsured has become nearly impossible. While each immunization program receives federal funding under Section 317 of the Public Health Service Act, currently fiscal year 2025 congressional budgets have the program nearly flat funded for the 3rd year in a row, and at less than half of the $1.6 billion a year CDC estimates is needed to operate programs at full capacity, despite the addition of COVID-19 and RSV vaccines and newly recommended lowering of the age of the pneumococcal vaccine. 9 new vaccine doses have been added to the recommended adult immunization schedule in the past 20 years, increasing the cost to fully vaccinate an adult by 1,023%, while funding increased only 46% over that same period of time. The lack of necessary funding often forces immunization programs to choose which vaccines they can provide to their uninsured adult populations, often making the difficult choice to exclude more expensive vaccines, such as those that prevent shingles, HPV, or serious RSV infections. This, of course, increases disparities and places populations that are already at most vulnerable to poor outcomes from these preventable diseases at even greater risk. AIM congratulates the committee for expanding the pneumococcal conjugate vaccine recommendation to provide protection to more adults and a broader age range. However, we remain concerned about the ability of programs to assure vaccine access to pneumococcal vaccine without additional funds. To avoid vaccine-preventable diseases among all adults, regardless of insurance status, the United States needs a national Vaccines for Adults program that provides vaccines to adults who otherwise would remain unvaccinated due to the cost of those vaccines. AIM would like to thank the ACIP and the meningococcal work group for its ongoing and thoughtful deliberation of the timing recommendations for meningococcal vaccinations for children. We would like to stress that changes to the adolescent vaccination schedule are likely to impact state school vaccination requirements and may have unintended policy consequences that could negatively impact childhood vaccination rates. We encourage ACIP and the work group to continue to engage in discussions with liaisons and consult with the jurisdictions before recommendations are made to fully understand the impact of such recommendations and what is needed to fully support the implementation of any new recommendations and to mitigate any unintended consequences that may result from changes to the existing recommendations. Thank you.
Thank you, Dr. Fiscus. Our next speaker is Mr. Jersey. Mr. Jersey, are you on?
Yes, I am. Can you hear me?
I can hear you very well, and you may start.
Awesome. Thank you. Good afternoon to the Advisory Committee on Immunization Practices. Thank you for allowing me to speak. My name is Jester Jersey, and I have no financial conflicts to disclose. Although I'm generally a vaccine advocate for all safe and scientifically sound vaccines, today I speak on behalf of the American Society for Meningitis Prevention. The unpredictable nature of meningitis requires simple yet robust recommendations from ACIP to protect adolescents and young adults. However, due to mixed messaging on usage recommendations of newly available pentavalent vaccines, confusion persists among providers and patients on which options to provide and which option to choose, respectively. With the detection of penicillin and ciprofloxacin-resistant serogroup-wide meningococcal isolates in recent years, coupled with the highest incidences of meningitis in a decade just last year, growing antibiotic resistance not only threatens to overwhelm our already burdened health system and diminish our existing solutions, but the health of the very people we're trying to save. Even when medical care is administered, it will unfortunately be too late for some, but it doesn't have to be that way. We already have the tools we need to fight back. We just need clearer messaging so that recommendations can be understood and trusted better by health providers and the patients they serve. I want to share two things. Earlier this month, October 5th, was World Meningitis Day, a day of remembrance, but also a call to action. Doing the right thing shouldn't be limited to just one day. Because of today's discussion on meningococcal vaccines, I see it as another opportunity to shed more light on this important issue that has affected so many families. The second thing I want to mention is that many of us were all college students at one point. As a college graduate, I was grateful for the opportunity to pursue higher education at 16 and for life-saving vaccines. So when 16-year-olds became eligible for the first set of COVID vaccines early in the pandemic, I was relieved to see young people were given tools and a fighting chance to fight disease. However, meningitis remains a silent threat, robbing young people of educational experiences, time with their family, and their lives, especially serogroup B meningitis. We need to invest in our young people and give them a chance to live a fulfilling life. Clarifying recommendations will diminish confusion in the health field, promote vaccine uptake, reduce meningitis cases, combat misinformation, protect young Americans from this dread disease, echoing the sentiments of our first public speaker. In conclusion, I urge ACIP to revisit meningococcal recommendations as needed to clear up confusing language around vaccine guidelines, prioritize the option that balances saving the most lives while also being fiscally feasible, and work with the CDC at large, other government health departments, advocacy groups, and vaccine advocates on a national educational campaign that maximizes the efficacy of meningococcal messaging outreach. Thank you for your work, your time, and your.
Thank you for your comment. Our next speaker is Dr. Narayana Swamy. Dr. Narayana Swamy, are you on, please?
Hi, yes, I am on. Can you hear me?
I can hear you very well, and you can begin.
Yes, thank you. I'm Pushpa Narayanaswamy. I'm a neuromuscular neurologist. I'm associate professor of neurology at the Harvard Medical School, and I'm also vice chair of clinical operations at Beth Israel Deaconess Medical Center. In my clinical practice, I'm also a myasthenia gravis expert, and I'd like to really thank the committee for its ongoing work and commitment to patient safety. Today, I'd like to address two issues. Both related to the use of meningococcal vaccines in patients who are receiving C5 complement inhibitors for the treatment of myasthenia gravis. The first issue is the difference between the ACIP guidelines. I believe the most recent ones were 2020, and the FDA approved labels, the most recent being August 2024, for meningococcal vaccination of patients with GMG or myasthenia gravis who are planning to start C5 inhibitors. These are discrepancies that are causing confusion to us clinicians who take care of them. The key issue is that the FDA labels for these complement inhibitors require meningococcal vaccines to be completed or updated at least 2 weeks before starting therapy. However, the ACIP guidance of 2020 suggests that only the initial doses of MenACWY and MenB need to be administered 2 weeks prior to the therapy. As a result, many of us are confused by the two interpretations. This misalignment between the two organizations and labeling or guidance has led to inconsistent patient care. We kindly ask for clarification on this matter. Another area where we would really appreciate your clarification is the area of prophylactic antibiotic therapy in these patients and the duration of this therapy. The FDA labels in August 2024 do not specify the duration of antibiotic prophylaxis or the length of antibiotic use, while ACIP recommends a 2-week course. It's interesting that the FDA labeling for all 3 drugs state follow ACIP recommendations, but are quite, in their own verbiage, are not consistent with ACIP recommendations. Again, this issue has gained even more significance with the recent Bexero label update, which could lead a patient needing up to 6 months of antibiotic prophylaxis. In myasthenia gravis, this can be especially difficult. If somebody is penicillin allergic, we cannot give them ciprofloxacin because it worsens myasthenia gravis. There are a lot of clinical nuances here, and we kindly request the ACIP to provide guidance and clarification of this discrepancy. I'm happy to take a meeting with you in any other time to give you some patient stories. Thank you again for your time. I'm actually calling in from Perth, Australia, 2:25 a.m.
Thank you, and I hope you can get some rest. We appreciate your comment. Our final public comment speaker is Ms. Colburn. Ms. Colburn, are you on?
Yes, I am.
We can hear you well. You can go ahead and speak, please.
Good afternoon. Thank you for the opportunity to comment on behalf of the National Foundation for Infectious Diseases, or NFID. I am Joanna Colburn, Deputy Executive Director of NFID. NFID commends ACIP and CDC for their vital role in protecting U.S. public health. Respiratory diseases, including flu, COVID-19, RSV, and pneumococcal disease, can have serious complications, causing thousands of hospitalizations and deaths among U.S. children and adults each year. Vaccination can help prevent infections and help ensure that those who do get infected are less likely to become seriously ill or die. Data show that flu vaccination prevented approximately 131,000 hospitalizations and 7,000 deaths during the 23 to 24 season. And COVID-19 vaccination prevented up to 100,000 hospitalizations in 2023. Vaccination is especially important for people at higher risk, including infants and young children, pregnant women, older adults, those with chronic health conditions, and those who are immunocompromised. Despite the availability of vaccines to protect against these respiratory diseases, overall vaccination rates remain below U.S. public health goals. A recent NFID survey found that few U.S. adults intend to get vaccinated this season. In fact, fewer than 1 in 5 U.S. adults are concerned about flu, COVID-19, RSV, or pneumococcal disease. Only 38% of U.S. adults say they will definitely get a flu vaccine, and only 23% say they will definitely get an updated COVID-19 vaccine. Among adults for whom vaccination against pneumococcal disease is currently recommended, only 24% say that they will definitely get vaccinated. And among adults for whom RSV vaccination is currently recommended, only 21% say that they will definitely get vaccinated. Top reasons cited for not getting vaccinated include concerns about side effects and distrust of vaccines in general. However, the NFID survey did highlight opportunities to help address these concerns. 75% of U.S. adults trust doctors, nurses, and pharmacists as their primary source for information about vaccines. As trusted sources, healthcare professionals can play a key role in making strong vaccine recommendations and emphasizing that vaccine side effects are rare and much less severe than the diseases that vaccines prevent. Although building vaccine confidence is critical, addressing suboptimal vaccination rates will require a multifaceted strategy. The NFID call to action, strategies to improve adult vaccination in the US, includes recommended strategies at the healthcare system, provider, patient, and legislative or public policy levels. Developed in collaboration with more than 25 organizations, the recommendations include establishing a Vaccines for Adults program to cover all recommended vaccines at no cost for uninsured and underinsured adults. NFID remains steadfast in our commitment to work with CDC and partners to communicate clearly about the benefits and risks of vaccination, increase vaccination confidence and coverage, reduce the burden of vaccine-preventable diseases, and improve overall U.S. public health. Thank you for your time today.
Thank you, Ms. Colburn, and that concludes our public comment session. Thank you to all of our public comment speakers, and I also want to thank those who took the time to submit written public comments via the CDC docket. Thank you all, and can we have the vote language up? Dr. Talbot, will your voice allow you to handle the voting session?
We're going to try. All right, next slide. This is the meningococcal vote number 1. ACIP recommends MenB4C, also known as Bexsero, be administered as a 2-dose series at 0 and 6 months when given to healthy adolescents and young adults aged 16 to 23 years, based on shared clinical decision-making for the prevention of serogroup B meningococcal disease. We'll start with Dr. Asturias. Please say your name, your conflict, and your vote. Not if you're a conflict, if you have a conflict. Thank you.
Thank you. Edwin Asturias, no conflicts, yes.
Dr. Brewer.
Noel Brewer, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Chen.
Lin Chen, no conflicts, yes.
Dr. Chu.
Helen Chu, no conflicts, yes.
Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Jameson.
Denise Jameson, no conflicts, yes.
Dr. Cambodge.
Minnie Cambodge, no conflicts, yes.
Dr. Kushel.
George Kushel, no conflicts, yes.
That was a yes.
Dr. Kushel, can you please repeat that?
George Kushel, no conflicts, yes.
Okay, thank you.
Thank you very much. Dr. Lair.
Jamie Lair, no conflicts, yes.
Dr. Maldonado.
Bonnie Maldonado, no conflicts, yes.
Ms. Moser.
Charlotte Moser, no conflicts, yes.
Dr. Schechter.
Rob Schechter, no conflicts, yes. Pardon me.
Dr. Shaw.
Al Shaw, no conflicts, yes.
And I'm Dr. Talbot. I have no conflicts, and I vote yes. So I have 15 yeses and 0 noes. The motion passes. All right, next vote.
Maybe I can read it. Yes. Okay, we're going to try to spare Dr. Talbot's voice. I'll read vote 2. ACIP recommends MenB AC Bexsero to be administered as a 3-dose series at 0, 1 to 2, and 6 months when given to persons aged greater than 10 years of old or greater at increased risk for serogroup B meningococcal disease, i.e. persons with anatomic or functional asplenia, complement component deficiencies, or complement inhibitor use, microbiologists routinely exposed to N-meningitidis isolates, and persons at increased risk during an outbreak.
Name potential conflicts. If there are any conflicts of interest, and vote. Dr. Asturias.
Edwin Asturias, no conflicts, yes.
Dr. Brewer.
Noel Brewer, no conflicts, yes.
Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Dr. Chen.
Lin Chen, no conflicts, yes.
Dr. Chu.
Helen Chu, no conflicts, yes.
Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Dr. Jameson.
Denise Jameson, no conflicts, yes.
Dr. Cambodge.
Minnie Cambodge, no conflicts, yes.
Dr. Kushel.
George Cashel, no conflicts, yes.
Dr. Lair,
Jamie Lair, no conflicts, yes.
Dr. Maldonado,
Bonnie Maldonado, no conflicts, yes.
Ms. Moser,
Charlotte Moser, no conflicts, yes.
Dr. Schechter,
Rob Schechter, no conflicts, yes.
Dr. Shaw,
Al Shaw, no conflicts, yes.
and I'm Dr. Talbot, no conflicts, yes. Once again, 15 yeses, 0 noes, motion passes. Next vote.
Next slide. I'll read the vote, Dr. Talbot. Thank you. So the next vote is the VFC vote to update the VFC resolution. So the vote will be to approve the Vaccines for Children VFC resolution for vaccines to prevent meningococcal disease.
All right, Dr. Asturias,
Edwin Asturias, no conflicts, yes.
Dr. Brewer,
Noel Brewer, no conflicts, yes.
Dr. Brooks,
Oliver Brooks, no conflicts, yes.
Dr. Chen,
Lynn Chen, no conflicts, yes.
Dr. Chu,
Helen Chu, no conflicts, yes.
Dr. Sineas,
Sybil Sineas, no conflicts, yes.
Dr. Jameson,
Denise Jameson, no conflicts, yes.
Dr. Camboge,
Minnie Camboge, no conflicts, yes.
Dr. Kushel,
George Cashel, no conflicts, yes.
Dr. Lair,
Jamie Lair, no conflicts, yes.
Dr. Maldonado,
Bonnie Maldonado, no conflicts, yes.
Ms. Moser,
Charlotte Moser, no conflicts, yes.
Dr. Schechter,
Rob Schechter, no conflicts, yes.
Dr. Shaw,
Al Shaw, no conflicts, yes.
and I'm Kip Talbot, no conflicts, yes. The motion passes 15 yeses, 0 noes.
And now we're ready for the immunization schedules vote. This vote is to approve the recommended child and adolescent immunization schedule, United States 2025, and the recommended adult immunization schedule, United States 2025. Dr. Talbot?
Last time. Dr. Asturias,
Edwin Asturias, no conflicts, yes.
Dr. Brewer,
Noel Brewer, no conflicts, yes.
Dr. Brooks,
Oliver Brooks, no conflicts, yes.
Dr. Chen,
Lynn Chen, no conflicts, yes.
Dr. Chu,
Helen Chu, no conflicts, yes.
Dr. Sineas,
Sybil Sineas, no conflicts, yes.
Dr. Jameson,
Denise Jameson, no conflicts, yes.
Dr. Camboge,
Minnie Camboge, no conflicts, yes.
Dr. Kushel,
George Cashel, no conflicts, yes.
Dr. Lair,
Jamie Lair, no conflicts, yes.
Dr. Maldonado,
Bonnie Maldonado, no conflicts, yes.
Ms. Moser,
Charlotte Moser, no conflicts, yes.
Dr. Schechter,
Rob Schechter, no conflicts, yes.
Dr. Shaw,
Al Shaw, no conflicts, yes.
and I'm Dr. Talbot, no conflicts, yes. The motion passes 15 yeses, 0 noes. Thank you all.
And I believe that concludes our votes. We will now move on to our this afternoon's, we actually had a break scheduled.
I think we're good. Y'all okay?
Yeah.
Keep going? Yes.
Okay, so we will continue with this afternoon's agenda for the HPV vaccine session. Slowly.
All right, very good. Can we bring up the first set of slides, please? All right, thank you. And sorry, there's no break. So we'll just keep going. Maybe we'll get out a little early. Maybe not. All right, so good afternoon, everyone. This is an introduction to the human papillomavirus vaccines work group. Next slide. So for a little background, the HPV vaccines work group reformulation was announced at the last meeting in June, the ACIP meeting. There was a HPV vaccine work group that previously met for many years, but has been inactive since 2019. And this particular work group has been active and meeting since July. We've had 3 meetings. Next slide. All right, so let's look at the current HPV vaccination recommendations here in the U.S. So routine vaccination is age 11 to 12. It can be started at age 9, and that language there is relevant. And 2 doses at 0 and 6 to 12 months, and if started after the 14th birthday or before the 15th birthday, then that is, if it's after that, then it is 3 doses, 0, 1 to 2, and 6 months. And there's catch-up through age 26 and shared clinical decision-making, age 27 to 45. It's the current recommendation. Next slide. Next slide. All right, so we looked at 3 terms of reference that when we announced in June. So far, we have been discussing and deliberating 2 of them. First one is the number of doses in the recommended HPV vaccination series. So there is accumulating evidence on the efficacy of HPV vaccination with fewer doses. So in 2022, the WHO recommended a 2-dose schedule for persons 9 years or older, and as an off-label option, a single-dose schedule can be used for those aged 9 to 20, and this has been adopted by many countries. Our work group is reviewing data to inform policy for 2 doses age 15 years and older, and right now the recommendation is 3, and then 1 dose for persons aged 9 years and older, and for a subset of those, the recommendation is 2 doses, so that's a significant change. Next slide. So the other area that we've been discussing is the wording of the age for routine HPV vaccination. So there has been interest from some stakeholders in the U.S. That are interested in starting the vaccination at age 9. Now, the current ACIP recommendation is consistent with vaccinating at age 9. So the discussion is not a change in the recommendation, but a change in the wording. So the work group is considering modification of the wording to HPV vaccination is routinely recommended at age 9 to 12 years, and that would allow more flexibility. It's interesting, we just discussed the schedule, so it would be a change in that schedule as it is now formulated. Next slide. So far in our 3 meetings, the work group progress has been, we've reviewed the background data on the 2 issues being considered. First one being the number of doses in the recommended HPV vaccination series. So we have started the grade process, and we're planning a full ETR, evidence recommendations framework, and ACIP vote at a future meeting. And the second area of discussion is the wording, as previously stated, wording for the age of routine HPV vaccination. We've reviewed the related literature. We are not using grade because it is change in wording and not a major recommendation change. And we're planning a modified ETR and ACIP vote at a future meeting. Next slide. So I would like to acknowledge the HPV vaccines work group, the other voting members on ACIP, Dr. Noel Brewer and Dr. Sybil Sineas, and especially the CDC co-leads, Dr. Carla DeSisto and Dr. Lori Markowitz. A lot of work has gone in with their leadership. And would also like to recognize and acknowledge the liaison members, the ex officio members, the consultant members and the grade consultants. Next slide. So also recognize the ACIP HPV vaccines work group CDC staff. It's a lot of work that is going into this, and it doesn't just happen. Next slide. So today, first we'll be hearing an introduction to the policy consideration of the reduced number of doses from Dr. Markowitz, one of our co-leads. Then we will have an introduction to policy consideration regarding the wording of the age of routine vaccination from Dr. Ruth Stefanos. Then we'll have a review of the literature on that very area, change in vaccination at ages 9, 10, and why potentially increase coverage from Dr. Sarah Brewer. And then we'll close this session out with next steps by the co-lead from the CDC, Dr. Carla DeSisto. So with that, I would like to then turn it over back to our chair and first presentation, which would be Dr. Markowitz. Thank you.
Okay, thank you for that introduction to the session. And in this talk, I'm going to give an introduction to one of the policy considerations being addressed by the work group, and that is, as you heard, vaccination schedules with a reduced number of doses. And we are going to be using GRADE and the ETR for this. But in this talk, I'm really setting the stage and providing a broad overview of this topic. First, because this is our first session of the reconstituted work group, I'll give a brief introduction to HPV, review HPV vaccines and vaccination recommendations in the U.S. Then I'll summarize data on vaccination with a reduced number of doses leading to a change in the World Health Organization recommendation, and end with a review of recommendations and the international vaccination policy landscape. So it has been 18 years since the first HPV vaccine licensure in the United States, and overall, these vaccines have exceeded expectations in terms of high efficacy in clinical trials, high population impact in real-world settings. An initial trial studied efficacy against cervical precancer as the main outcomes, but now there's evidence for effectiveness against other outcomes, including cervical cancer. And there's been strong herd effects observed in vaccination programs. However, there have been implementation challenges in many countries and a lag in vaccine introduction in low and middle income countries. HPV is a small double-stranded DNA virus. There's more than 200 different types that are all closely related. HPV has 2 capsid proteins, and the L1 is the major capsid protein, and the sequence of the L1 gene determines the virus type assignment. 12 types have been classified as high risk or oncogenic, and 2 of these, 16 and 18, are responsible for most HPV attributable cancer. These include cervical, vaginal, vulvar cancer in females, penile in males, and anal and oropharyngeal in females and males. The low-risk types rarely cause cancer, and low-risk types 6 and 11 cause most anogenital warts and a rare but serious outcome, recurrent respiratory papillomatosis. HPV is the most common sexually transmitted infection. It's estimated about 13 million persons in the United States will become infected with a disease-causing type each year. Most of the HPV infections are asymptomatic, and over 90% will become undetectable in 2 years. But persistent infection can progress to cancer and other cancers in years to decades. This figure shows infections at the cervical site. After HPV infects the cervix, it can cause mild cytologic abnormalities, and these abnormalities are transient, and persistent infection with high-risk types, though, can progress to precancer lesions, and then these can regress or progress to invasive cancer. Now, this slide shows the average number of HPV-associated and the estimated number of HPV attributable cancer cases per year in the United States from 2017 to 21, our most recent data. The number of HPV-associated cancers are from our national cancer registries, and the percentages probably caused by HPV are from special studies using HPV typing. Each year, an estimated 37,800 HPV-attributable cancers occur, and the most common in women is cervical cancer, and the most common in men is oropharyngeal cancer. Now moving on to talk about the vaccines. All available prophylactic vaccines for HPV are virus-like particle vaccines made from the L1 major capsid protein of the virus. The L1 proteins expressed using recombinant technology self-assemble into virus-like particles that are structurally similar to HPV virions but without any viral DNA. The VLPs retain their dominant conformational epitopes. These vaccines have been found to have high efficacy against vaccine-type outcomes studied with durable protection for as long as they've been studied, now up to 16 years. 3 vaccines are licensed in the United States and many other countries: bivalent, quadrivalent, and 9-valent. All 3 target 16-18, the 2 types that cause most HPV attributable cancer, and the quadrivalent and 9-valent also target 6 and 11, types that cause most anogenital warts, and the 9-valent targets 5 additional cancer-causing types. Another difference between the vaccines is the adjuvant, with the bivalent containing AS04. The quadrivalent and the 9-valent contain an alum adjuvant. Quadrivalent was the first vaccine licensed in 2006, followed by the bivalent in 2009, and the 9-valent in 2014. Although all 3 of these vaccines are licensed in the United States, after the end of 2016, only the 9-valent has been available. The bivalent and the quadrivalent vaccines are being used in other countries, as well as the 9-valent vaccine. Now, data for initial licensure of HPV vaccines were obtained in trials using 3 doses administered over 6 months. The pivotal trials were large, randomized, controlled efficacy trials in 15 to 26-year-old women. And in the per-protocol analyses, efficacy was over 96% and seroconversion close to 100%. And for the anticipated target age group in vaccination programs, that is adolescents before onset of sexual activity, efficacy studies were not considered feasible. Licensure in this age group was based on immunobridging, that is the demonstration of non-inferior antibody responses compared with those in women in the efficacy trials. There's been an evolution of HPV vaccine recommendations in the United States. In 2006, vaccination was first recommended for adolescent females with catch-up through age 26. And at that time, vaccine was only licensed for use in females. And in 2011, after licensure in males, routine vaccination was recommended for adolescent males with catch-up through age 21. Vaccines were first licensed and recommended in a 3-dose schedule, and in 2016, a 2-dose schedule was recommended for those starting vaccination before age 15. And then in 2019, after FDA expanded the upper age indication from 26 through 45 years, ACIP made a recommendation for shared clinical decision-making for persons 27 through 45. And at that time, catch-up was harmonized across all sexes through age 26. And as you heard in the introduction to this, since 2019, these have been the recommendations in the United States: routine vaccination in early adolescence, catch-up vaccination through age 26 years, and shared clinical decision-making is recommended for persons 27 through 45 not adequately vaccinated. And the number of doses recommended depends on the age the series was initiated, with 2 doses for persons starting the series at age 15, and 3 doses are recommended if starting the series at age 15 or older, and for persons with immunocompromising conditions. Now, next I'd like to briefly review how we got to the 2-dose recommendation in this specific age group. Interest in a 2-dose schedule was stimulated by post-hoc analyses of a 3-dose randomized controlled trial of the bivalent vaccine compared with a control vaccine conducted in Costa Rica by the U.S. National Cancer Institute. In this trial, not all participants completed the 3-dose schedule, and efficacy was analyzed by number of doses received. In these post-hoc analyses, efficacy of the bivalent vaccine against 1618 infection was similar after 3, 2, and 1 doses. Immunobridging studies were then conducted by the manufacturers to evaluate 2 doses in 9 to 14-year-olds compared with 3 doses in women in the age for which efficacy was demonstrated in the large trials. These types of trials were required by the regulatory authorities for approval of a 2-dose schedule, and seroconversion in GMTs were non-inferior in the 2-dose group. And this just shows some of the data from the 9-valent immunobridging trial. The geometric mean antibody titers for the group that received 2 doses at 6 months apart at age 9 to 14 are in yellow, and for women aged 16 to 26 who received the 3-dose schedule in blue. And you can see that for all types, GMTs in the 2-dose group were non-inferior and in fact higher than the GMTs in women who received 3 doses. Using these and other data, the manufacturers submitted supplementary applications to the regulatory authorities for a 2-dose series in 9 to 14-year-olds. And following approval, WHO, ACIP, and advisory groups in other countries recommended a 2-dose schedule for persons starting vaccination in this age group. Now moving on to single-dose vaccination. Interest in single-dose vaccination was stimulated by the same studies that led to a 2-dose schedule. However, evidence from immunobridging trials would not be sufficient because a single dose results in lower antibody titers than 2 or 3. And why the basis of protection after HPV vaccination is thought to be neutralizing antibody, there's no established minimum antibody threshold for protection. Therefore, efficacy trials would be needed to evaluate single-dose HPV vaccination. This is the study design for SCUDO, a study being conducted in Costa Rica and sponsored by the U.S. National Cancer Institute. This large, randomized, double-blind trial was designed to evaluate non-inferiority of 1 dose compared with 2 doses of bivalent and 9-valent vaccine for prevention of new cervical 16-18 infections in girls 12 to 16 years. And to evaluate 1 dose compared to those unvaccinated, there will be surveys of unvaccinated women. There's no planned interim analysis, and follow-up is through 5 years. The first data from this study will be available in 2025. After the randomized trial in Costa Rica was planned and initiated, there was increasing interest in the possibility of single-dose vaccination. This was largely because studies that initially provided data on fewer number of doses continued follow-up and had further encouraging data. An increasing interest in single-dose vaccination was also stimulated by the recognition of a global vaccine supply-demand imbalance that prevented some countries from introducing HPV vaccine or expanding their programs. And additional studies were planned and conducted. And review of these and other data then led to revised WHO recommendations in 2022, including, as an off-label option, a single-dose schedule can be used in girls and boys aged 9 through 20. Today, I will briefly review data from these 4 trials, which were part of the evidence considered by WHO. This table shows the country where the trial was conducted, the type of evidence, the vaccine product studied, the age at vaccination, and a description of the study. And none of these trials were conducted by the manufacturers. The first 2 trials, the Costa Rica vaccine trial, or CVT, and IARC India, participants were not randomized to a 1-dose group, but 1-dose data are from post-hoc analyses. And data from these trials were those that first raised interest in single-dose vaccination and provide the longest follow-up data available. Following that, I will summarize data from the 2 randomized trials. In both of these trials, participants were randomized to a 1-dose group. And these trials provide the highest quality of evidence available on 1-dose vaccination at this time. So first, the Costa Rica vaccine trial, which is the trial that originally raised interest in 2- and 1-dose schedules conducted by the U.S. National Cancer Institute. This study continued follow-up, and this slide shows data through 11 years after vaccination. Again, these are data from a post-hoc analysis of a randomized controlled trial in females vaccinated age 18 through 25 years, and they were randomized to 3 doses of bivalent or a control vaccine, but not all participants completed the assigned number of doses. And after the blinded phase of the trial, an unvaccinated control arm was recruited to allow for continued efficacy determination. And as shown, the efficacy for prevention of prevalent 16-18 infection was similar in all dose groups. In this study, serum antibody was also measured, and while antibody titers were lower in the 1-dose group, shown in blue, than in the 2- or 3-dose group, shown in red or the purple lines, HPV-16 antibody levels were relatively stable through 11 years post-vaccination in all dosing schedules, and the level in the 1-dose group was at least 10-fold above the level at enrollment among unvaccinated, shown in black at the bottom of the figure. And there are similar results for HPV-18. The IARC India study provides data on the quadrivalent vaccine. Among women who were vaccinated at age 10 through 18 years, it was designed as a cluster randomized trial to compare 2 versus 3 doses. But less than a year after initiation, the trial was stopped due to issues unrelated to the trial. Vaccination did not occur as scheduled, and the randomized trial design was lost. The study has been analyzed as an observational cohort with different vaccination schedules, including a 1-dose group. Participants were followed up yearly, and unvaccinated females aged matched to vaccinated participants were recruited as controls. And these are the data through 10 years after vaccination. As shown, vaccine efficacy against persistent 16-18 infection was over 93% and similar in all dose groups. Moving on to the randomized trials. ChemShe is a double-blind, randomized controlled trial conducted in Kenya. Sexually active females aged 15 to 20 years were randomized to receive a single dose of bivalent, 9-valent, or delayed HPV vaccination with immediate meningococcal vaccination. This trial provides the highest quality data available on single-dose vaccination. The primary objectives were to determine the efficacy of single-dose vaccination in preventing incident persistent infection with high-risk types targeted by each vaccine. Primary outcomes were assessed at month 18 with follow-up to month 36. It's 36. At month 18, in the modified intent to treat population, which includes persons vaccine type DNA negative at enrollment at month 3 and antibody negative at enrollment, there were 36 incident persistent HPV 16-18 infections in the control group and 1 infection each among participants in the bivalent and 9-valent groups. Vaccine efficacy was 97.5% for both vaccines. And at month 36, there were a total of 72 incident persistent infections in the control group, 1 in the 9-valent and 2 in the bivalent. And vaccine efficacy was 98.8% for the 9-valent and 97.5% for the bivalent. This displays graphically the efficacy results through 3 years against 16-18 infection on the left, which I just presented in the tables, as well as efficacy against any of the 7 high-risk types for the 9-valent vaccine on the right. Both figures show accumulating infections in the control group shown in green, and the flat lines at the bottom of the figures in red and blue for the infections in the vaccine groups. When WHO made a recommendation for off-label single-dose vaccination in 2022, only the 18-month data were available from this trial. The 36-month data showing sustained efficacy were published last year. And the last trial I will mention is DORIS, a randomized trial in girls aged 9 through 14 in Tanzania. Girls received 1, 2, or 3 doses of the bivalent or the 9-valent vaccine. And the objectives were to demonstrate non-inferiority of HPV 16 and 18 antibody response after 1 dose versus 2 or 3 doses of the same vaccine, and to demonstrate non-inferiority of HPV 16 and 18 geometric mean concentrations comparing 1 dose in this study with 1 dose in studies that had evaluated efficacy. Now, there were many outcomes in this study, and I'm going to give a very high-level brief summary. First, seropositivity was high after vaccination for all groups. Strict non-inferiority criteria were met for HPV 16, but not for HPV 18. However, seropositivity was at least 97.8% in all vaccine groups at 24 months after vaccination for both 16 and 18. Antibody levels are shown here for the 9-valent vaccine groups, for 16 on the left and 18 on the right. Antibody levels were similar in the 2 and 3 dose groups in the red and green lines, which are hardly distinguishable on the figures. Antibody levels were lower after 1 dose in blue than for 2 or 3 doses. However, antibody kinetics with a plateau between 12 and 24 months were similar for all vaccine doses. Antibody avidity was also determined. Avidity is shown for the bivalent on the left and the 9-valent on the right, and results for 16 are in red and 18 are in blue. Avidity for both HPV types was similar for 3, 2, and 1 doses for both vaccines. And for the immunobridging objective, 1-dose responses were non-inferior in this study compared with those among women studies where efficacy was observed. And in this publication, the antibody levels were compared with those from ChemShi, which is the randomized controlled trial from Kenya, which I just reviewed. Now, there are additional studies evaluating single-dose vaccination, and more data are forthcoming. These studies provide evidence regarding effectiveness, immunogenicity, and efficacy. And I am not going to review these today, but I did want to show this to mention that more data will be available from a variety of countries around the world. And there will be additional data with longer follow-up from some of the studies I reviewed today, including the Costa Rica vaccine trial with follow-up through 14, 16, and 20 years being planned, the IARC India study with 12-year data and possibly further, and the DORIS immunogenicity study being conducted in Tanzania. Studies of single-dose vaccine also provide data on two doses in persons aged 15 and older. 2 studies I just reviewed on single dose have a 2-dose group. The Costa Rica vaccine trial, in which participants received 2 doses at ages 18 through 25, and the IARC India trial, in which participants received 2 doses at ages 10 to 18. There's also an immunogenicity study of 2 versus 3 doses of the 9-valent vaccine among U.S. females age 15 through 26 years. The study is ongoing, but interim results were published this year with data 1 month after the last dose, and this showed similar immunogenicity in the 2 versus 3 dose groups. Now, coming back to the WHO recommendations and the current global landscape. As you heard earlier, in 2022, WHO recommendations stated that evidence supports a 2-dose schedule from the age 9 years in for all older age groups for which HPV vaccines are licensed. And as an off-label option, a single-dose schedule can be used in girls and boys aged 9 through 20. Since the updated WHO recommendations were made, many countries have changed policy. This is the most recent WHO tabulation of HPV vaccine schedules in 9 to 14-year-olds. And this is for 9 to 14-year-olds because that is the priority age group for WHO. But many of these countries have 1-dose recommendations in a wider age range. In blue are countries with a 2-dose recommendation, and countries in red, of which there are currently 58, are recommending 1 dose. It was expected that low and middle income countries would be the first to adopt a single dose schedule, but some of the first countries that changed to a single dose schedule were high income countries, including England, Ireland, and Australia. Other countries that considered the data did not change to a single dose, but changed from a 3-dose to a 2-dose schedule for persons older than age 14, and this occurred in the Netherlands and Sweden, as well as other countries. Recommendations for single-dose vaccination have also been made by some regional advisory groups, including PAHO in 2023 and AFRO in 2024. There are a variety of outstanding questions for single-dose vaccination, and these are the longer-term efficacy and immunogenicity, protection at sites other than the cervix, where most of the studies have been done. And while there are some data in males, single-dose data are limited. Other outstanding questions are efficacy and immunogenicity in immunocompromised persons and in older age groups, and additional data is expected over the next year to address some of these questions. Of note, in March of this year, Merck, the producer of the 9-valent vaccine, announced that they plan to conduct 2 prospective clinical trials of single-dose vaccination, one in females and one in males. These randomized, double-blind, multi-year clinical trials will examine short and long-term efficacy and immunogenicity of a single dose of Gardasil 9 versus the currently approved 3-dose regimen. And our understanding is that the company would seek an indication for single dose if their studies showed data that support this. And Merck is in discussions with FDA about protocols and a timeline. In summary, HPV vaccines were first studied and licensed in a 3-dose schedule in persons 9 through 26, and later in a 2-dose schedule in persons 9 through 14 years. There are now data on single-dose vaccination, including data from a high-quality randomized controlled trial with 3 years of follow-up showing high efficacy against incident persistent infection. Long-term follow-up from other studies suggests protection for more than 10 years with a single dose, and some have data through 16 years at this time. WHO 2022 updated recommendations are for 2 doses for persons age 9 and older with the option of single-dose HPV vaccination through age 20 years, except for those immunocompromised. And countries around the world are considering new or updated vaccination policy, and an increasing number have recommended single-dose vaccination. And further data on 1 and 2 doses will be available over the next year. Next steps for the ACIP work group include to review further evidence on 1 and 2 dose schedules, modeling data that are available to evaluate the hypothetical situation of waning protection with single dose, as well as other relevant data. The work group plans to review the evidence using GRADE and to evaluate the policy questions using the evidence to recommendations framework. We're still defining the specific PICOs, but the general questions will include, should a 1-dose schedule be recommended in some age groups, and should a 2-dose schedule instead of a 3-dose schedule be recommended in some age groups older than age 9 to 14 years. And this was just an introduction to the issue of reduced dose schedules, and further data will be presented at the upcoming ACIP meetings. But at this time, we would like to know if ACIP members have questions about the policy questions being addressed by the work group. Thank you.
Thank you, Dr. Markowitz. That was very comprehensive. Are there any questions from the committee? I do see there's some comments from liaisons, but I'll take committee questions first. Not seeing any. Ms. Deshawn?
Yeah, hi, thank you, from NAPNAP. And I just wanted, this is just so exciting. So as a practicing provider as well, to be able to do this at decreased doses is going to be life-changing for these young people. So this is very exciting. Thanks so much.
Thank you. Ms. Arthur?
Thank you, Dr. Wharton. Phyllis Arthur with Bio. I just wanted to actually be sure to remind the ACIP about a couple of issues. So one, thanks so much, Dr. Markowitz. She always covers these issues so beautifully, and she really did a great job reviewing the efficacy and some of the studies. And I want to remind everyone that there are a lot of things going on to capture and overcome the challenges of giving HPV vaccine in order to get to elimination. But there's a couple of points to make. First, I think it's important to remind the ACIP that the vaccine manufacturers by law are required to follow the FDA label. Hence why you see the company pursuing a regulatory process for changing the dosing schedule. So it's important to note the way that the process happened for going from 3 doses to 2 doses that Dr. Markowitz discussed, where the registration change happened and then the recommendation change happened. And so I know there's other times we've considered making a change at the ACIP level on doses required for a recommended vaccine, but it's important to note that that means the company will only be able to discuss what's in the actual label when they're talking to clinicians. So it's really important to ensure alignment between the regulatory body where the robust studies are taking place and the policy body of the ACIP, particularly to make sure that we can have clear conversations with clinicians on these issues. In addition, obviously, Merck is planning to look at many of the data points that were covered in Dr. Markowitz's questions that she asked about certain populations, et cetera. So we want to make sure that the ACIP is acutely aware of the difference between making a change in this body and the significant importance of actually making sure that there's a regulatory change, as that really drives how clinicians and the company can work together. Thank you.
Thank you. Ms. Hayes?
Yes, Carol Hayes with ACNM. I just wanted to clarify, Dr. Markowitz, on slide 11, that technically when Gardasil was first approved in 2006, it was a bivalent, and it became a quadrivalent years later. And funny story, I was invited to the very first stakeholder meeting at CDC about the original bivalent Gardasil, and I sat next to the esteemed first woman president of ACOG, Luella Klein. She leaned over and said to me, "Are they asking us to be vaccinators?" And I said, "I think they are." And she said, "Oh, that will never happen."
I didn't hear the first question. What was that?
Yes, on slide 11, when Gardasil was first approved by the FDA in 2006, it was a bivalent.
No.
Ms. Hayes, that's actually not correct.
Yeah, no, the quadrivalent was the first vaccine approved by FDA. The bivalent, because of its novel adjuvant, there was some additional reviews that were done. So the quadrivalent was actually the first vaccine approved.
Okay, I stand corrected. Thank you.
It was originally approved for use in girls and women, and then the licensure for the quadrivalent vaccine was later for boys and men, correct?
Well, what was?
The initial licensure of the 4-valent vaccine.
Yes, was in girls and women, right. And then it was in boys and men.
So there were some changes in the licensure of that product.
But it was the quadrivalent was the first vaccine licensed, yeah.
So there is a question in the room. Dr. Kambosh?
I have a request for the work group. Childhood cancer survivors have been found to be at a higher risk for secondary malignancies related to HPV. So as you look at this, I would request special consideration on the optimal approach for that group.
I'm sorry, could you say again what group you're talking about? I think I may have missed
childhood cancer survivors.
Childhood cancer survivors
are at a higher risk for developing secondary malignancies due to HPV. It's probably from a combination of factors, one of which is under-immunization, but also their immunocompromised state. I'm not aware of what the data on the optimal vaccination approach is, but it's becoming a large enough issue to be looked at. So that's the request.
Comment was that cancer survivors are at higher risk of malignancies. Do you mean HPV cancer survivors or cancer survivors in general?
Childhood cancer survivors is epidemiological data that I'm happy to pass along, which shows.
Yeah, I know we're going to be reviewing a variety of data that have emerged since the last work group met.
Thank you for raising that issue. Are there other questions or comments from the committee? Dr. Markowitz, should we move to the next presentation?
Good afternoon. I'll review the routine HPV vaccination recommendation wording as it relates to current policy questions. First, I'll review the current HPV vaccine recommendation and provide some historical context. I'll then briefly discuss the Clinical Decision Support for Immunization project as it relates to this policy issue. I'll share the most recent vaccination coverage from NIS Teen and end with considerations around vaccination at age 9 years that the work group will be discussing. As you heard from Dr. Markowitz, HPV vaccination is routinely recommended at age 11 or 12 years. Vaccination can be given starting at age 9 years. Since 2006, when ACIP and CDC made the first HPV vaccination recommendation, there have been no substantial changes to this wording around timing of initiation. HPV vaccination has been considered part of the adolescent platform, which was introduced in 1996. At that time, an annual well-child check was not routine practice, and the adolescent platform provided an opportunity for 11 to 12-year-olds to get vaccinated at an established visit. In 2005, both Tdap and meningococcal vaccines were licensed and recommended at this age and continue to be part of the adolescent platform today. And in June 2006, the HPV vaccine is recommended at ages 11 to 12 years as well. HPV vaccination has been promoted as part of the adolescent platform since its introduction. An example of this is on this slide. You can see language on CDC's website promoting this bundled approach. The HPV vaccine recommendation is depicted here in the familiar colors that are used on the vaccine schedule to designate the different types of recommendations. The yellow indicating the routine vaccination for young adolescents, the green indicating catch-up vaccination for older adolescents and young adults, and the blue indicating shared clinical decision-making for adults older than 26 years. One of the special situations with the HPV vaccine is the recommendation for children who have a history of sexual abuse or assault to start the vaccine at age 9 years. This was first added to the recommendations in 2014. And here you can see the graphical representation of the HPV vaccination recommendations on Table 1 of the Child and Adolescent Immunization Schedule. The yellow color shows the range of recommended ages for all children at 11 to 12 years. The purple color indicates the range of recommended ages for certain high-risk groups. For HPV, this would be for children who have a history of sexual abuse or assault to be vaccinated at age 9 years. The depiction of the HPV vaccination recommendation wording of can be given starting at age 9 years is currently represented on the immunization schedule by a yellow and brown checkered color pattern, which is uniquely used for HPV. This slide shows how HPV is depicted on the parent-friendly, a more easy-to-read immunization schedule. Here, you can see the light purple represents that all children ages 9 to 10 years can receive the HPV vaccine, and the dark purple represents that all children ages 11 to 12 years should receive the HPV vaccine. The next topic I will touch on will be clinical decision support for immunization, also known as CDSI. The CDC's Clinical Decision Support for Immunization project translates clinical ACIP recommendations into technical information to support consistent integration of recommendations into clinical decision support engines such as electronic health records. There has been increasing awareness of how ACIP recommendations are interpreted in CDSI resources, and I will briefly review this topic as it relates to current HPV policy issues. The CDSI resources include logic specifications such as decision tables, and for each vaccine, there's supporting data with specific values to be used in the logic specification. These resources describe the logic for applying ACIP rules to clinical decision support engines. In CDSI resources, the minimum age for HPV is 9 years, and the earliest recommended age is 11 years. Additionally, there is administrative guidance included in the CDSI resources that state the vaccination can be given starting at age 9 years. In general, clinical decision support tools use the earliest recommended age for all age-based vaccine recommendations. For HPV, this results in electronic health records and other CDS engines prompting providers at age 11 for HPV vaccination. This is one of the implementation challenges that some have described as a barrier for practices or jurisdictions who would like to start vaccination at age 9 years, although starting vaccination at this age is consistent with ACIP recommendations. Some jurisdictions have been able to modify their prompts and systems to meet their local needs. This graph shows data from the National Immunization Survey team and shows vaccination coverage of HPV, Tdap, and meningococcal vaccines from 2006 through 2023. NIS teen is one of our most accurate estimates of adolescent vaccination coverage in the US. As you can see, HPV vaccination coverage has increased since vaccination introduction, but continues to lag behind coverage for the other adolescent vaccines. For many years, there have been efforts and implementation research to help address the lower coverage for HPV vaccine. These include focusing on the provider recommendation and the presumptive approach and other strategies. One of the other strategies to increase uptake relates to age at initiation of HPV vaccination. In an effort to increase HPV vaccination uptake, beginning in the 2018 Red Book, a subtle difference between CDC and AAP HPV vaccination recommendation wording was introduced, and this recommendation is the same in the current Red Book. The AAP recommends starting the series between the ages of 9 and 12 years at an age the pediatric healthcare professional deems optimal for acceptance and completion of the vaccination series. Recommended vaccination at age 9 is a strategy that some partner groups have promoted to improve HPV vaccination coverage. There has been a recent growing number of publications evaluating the benefits of vaccination at age 9. Many of these publications can be found in this 2023 journal supplement. Because of the interest in starting vaccination at age 9, and because ACIP recommendations already are consistent with vaccination at age 9, we plan to have discussion with the work group about modifying the wording of the current recommendation. Should the ACIP recommendations state that HPV vaccination is routinely recommended at age 9 to 12 years, instead of the current wording of HPV vaccination is routinely recommended at age 11 or 12 years, vaccination can be given starting at age 9 years. Although this work group is not considering changing the routine age recommendation, because of the interest around this topic and the studies that have been conducted, CDC performed a systematic review. The following presentation by Dr. Sarah Brewer will summarize the evidence from this systematic review, and the work group will be discussing findings from this review along with other information, including a variety of data from NIS teen and from a randomized controlled trial that may provide information of interest for the work group and partners. Although complete and final data from the RCT on this topic is not expected to be available until 2026, there are some intermediate data that the work group will be reviewing. The work group will be planning on conducting a modified ETR for this policy question. I want to end this introduction with a summary of the recommendations from other countries. While vaccination programs vary by country, being aware of others' recommendations may help put the US recommendation into context. This slide summarizes the ages included in general HPV vaccine recommendations of the countries in the European Union and the European Economic Area. Age is listed on the top, and the list of the countries are down the left side of the figure. As you can see, there is a wide variation in age recommendations. Some of these countries have school-based vaccination programs. 4 countries include vaccination at age 9 years in their general recommendations. 6 countries include vaccination at age 10 years as their youngest age in their general recommendations. and 20 countries include vaccination at age 11 years or older as their youngest age in their general recommendations. Also wanted to highlight recommendations from the UK, which has a school-based program. The UK recommends starting at ages 12 to 13. I would like to end by showing this slide again. As a reminder, one of the policy questions the work group will be considering relates to the wording of the age for routine vaccination. Specifically, should the ACIP recommendations state that HPV vaccination is routinely recommended at age 9 to 12 years, instead of the current wording of HPV vaccination is routinely recommended at age 11 or 12 years, vaccination can be given starting at age 9 years. As a reminder, the work group is not considering changing the routine age of vaccination due to the lack of strong evidence. The following presentation will summarize available data from a systematic review on vaccination at age 9. And at future ACIP meetings, additional issues related to changing the wording of the routine age recommendation to age 9 to 12 years, which we are considering, will be presented. Thank you.
Thank you, Dr. Stefanos. I think we're moving on to the next presentation. So next is Dr. Sarah Brewer, who will be giving a presentation on the results of the literature review.
Good afternoon. Today I'll be presenting data on HPV vaccination in the United States and a critical summary on publications identified through a systematic review investigating HPV vaccination at ages 9 to 10 years as a strategy to increase vaccination. Since HPV vaccine was first licensed and recommended in 2006 for females, HPV vaccination recommendations have evolved. However, the wording of the routine age recommendation has remained the same. While HPV vaccination coverage has increased, uptake continues to be lower than other vaccines recommended in adolescents. There have been many efforts over the years to increase HPV vaccination in the United States. And in the past few years, there has been increasing enthusiasm for HPV vaccine initiation at age 9 as a way to increase coverage. Our objective is to critically evaluate publications investigating HPV vaccination at ages 9 to 10 years. We have completed a systematic review and a narrative summary of the literature. This has been submitted for publication and is under review. All findings shared here today are unpublished data. In the next few slides, I will describe our methodologies for the review, as well as summaries of the data and our interpretation of the findings. The selection criteria for the systematic review is listed here. We included studies published from 2014 to 2024 and conducted in the United States. Because HPV vaccination was first recommended in 2006, prior to 2014, there were few studies relevant to our search. The 10-year cut point allowed us to focus on the most recent literature pertaining to our study objective and to reduce the number of total abstracts screened. Study population included individuals 9 years old or older who were eligible to receive HPV vaccination, their caregivers, and providers who administer the HPV vaccine. All studies had some type of evaluation of HPV vaccination at ages 9 to 10. Outcomes included vaccine initiation, completion, acceptability by providers or caregivers, or feasibility of routine vaccination at ages 9 to 10. This is the PRISMA flowchart for study inclusion. A total of 1,684 studies were identified, and after each paper was screened independently by 2 reviewers, we were left with 30 studies to be included in our review. We categorized the literature identified into 3 types of studies shown here in purple, yellow, and green. Throughout the presentation, I will use these colors to differentiate the study types for clarity. This chart shows all studies included in the literature review, grouped by study type, with main outcome identified by an X. The main outcomes shown in the column headers here were completion of the vaccine schedule, initiation of HPV vaccine, provider perspectives and recommendation behavior regarding vaccination at ages 9 to 10, and caregiver perspectives on HPV vaccination at ages 9 to 10. As of note, not all of the studies looking at initiation or completion evaluated these outcomes by age at vaccination. I'm going to first talk about the retrospective cohort and observational studies, the majority of which identified HPV vaccination completion as their main outcome, with one study investigating characteristics of those initiating vaccination. Within this group of studies, various data sources were used. 4 used National Immunization Survey teen data, 3 used market scan insurance claims data, and the remaining 4 used other data sets for analyses. After reviewing all of the retrospective cohort and observational studies, we found that 9 explored the impact of age at initiation, ages 9 to 10 versus 11 or older, on completion or up-to-date status of the vaccination series. Many studies looked at series completion by age 13, but others evaluated up-to-date statuses at older ages or used an outcome defined by time to complete the series after receiving the first dose. All but 1 found that initiation at ages 9 to 10 years, compared to initiating at ages 11 to 12 years, was associated with higher completion. One study also assessed how age at initiation affected the association between race ethnicity and up-to-date status, and found an increased odds of up-to-date status across all racial ethnic groups when initiating at ages 9 to 10 compared to age 12. 1 examined the timing of HPV vaccine initiation in relation to other vaccines recommended for adolescents, Tdap and meningococcal, and found higher completion if HPV vaccine was initiated before these vaccines. And 1 investigated predictors of initiation for children ages 9 to 13 among a national sample of mothers that examined rates of HPV vaccination and predictors of HPV vaccine initiation, and found the same characteristics were associated with initiation regardless of age at initiation. Our interpretation of these data are: the retrospective cohort and observational studies found higher vaccination series completion when initiating at ages 9 to 10 versus 11 to 12, but study limitations preclude a cause and effect interpretation. A small percentage of vaccinated adolescents had initiated at ages 9 to 10 in most studies, ranging from 2 to 8%. There was no information collected on reasons for initiating at ages 9 to 10. There may have been differences in those initiating at ages 9 to 10 versus 11 to 12 that could influence initiation or completion. And lastly, there may have been differences between providers vaccinating at ages 9 to 10 and those vaccinating at ages 11 to 12, which may also influence outcomes. As we move on to quality improvement and intervention studies, we see here that these studies all included initiation as a main outcome, while others also investigated series completion. Of the studies that used quality improvement and intervention projects, all 12 studies evaluated initiation. Interventions included in these studies were multi-pronged, with 1 component focused on initiating at ages 9 to 10 years. All studies observed an increase in initiation for all ages at initiation, 9 to 10 years and 11 years or older, or at a clinic population level. However, the magnitudes of increases varied across age group. Increases were not sustained in all studies, and initiation rates at ages 9 to 10 years were still lower than initiating at ages 11 years or older. Of the 6 studies that evaluated both initiation and completion, increases in completion rates were observed in the majority of studies. This is a chart showing the quality improvement projects or interventions used for each study. These first 6 evaluated initiation only, and this chart illustrates how each study included multiple components in their interventions and quality improvement projects. The main categories of interventions included EMR change from an alert at age 11 to age 9, provider and staff training on recommending the vaccine, patient education, creation of a QI team and data feedback, clinic incentives, standing orders, and patient reminders. This is the second group of quality improvement and intervention studies. They focus both on initiation and completion as outcomes of interest. Again, you can see with this chart that each study included more than one intervention within the study. After reviewing these studies, we found that in the majority of QI or intervention studies, there were increases in initiation and completion. However, due to the multi-pronged interventions, it is unclear if the component focused on initiating at ages 9 to 10 was responsible for any of the increase in coverage. And within the QI intervention studies, vaccination at age 9 was feasible, but not necessarily better than at ages 11 to 12. Last are the provider and caregiver perspectives and behavior studies. They included in-depth qualitative interviews from a small group of providers, larger online surveys targeting primary care professionals, family medicine, pediatrics, and women's health providers, and study using both interviews and surveys focusing on caregiver perspectives and experience with HPV vaccination at ages 9 to 10. Within this group of studies, there were 2 based on clinician interviews. One was an intervention study where providers reported a positive experience recommending vaccination at ages 9 to 10, and one was a qualitative study with providers expressing mixed opinions. Of the 3 clinician surveys, one found among providers not currently recommending at age 9, family medicine physicians were more willing to recommend the vaccine at ages 9 to 10. And another found strong recommendations differed by age group and specialty. The next found recommendation framework mattered when initiating at ages 9 to 10 years, and perceived benefits of vaccination varied by initiation age. Within the 2 caregiver studies, few caregivers reported receiving information on recommendations to vaccinate children before age 11, and most reported willingness to vaccinate at ages 9 to 10 years. Our interpretation of these data is that in a limited setting and mostly small studies, vaccination at ages 9 to 10 was acceptable by caregivers and providers. In conclusion, we conducted a systematic review evaluating HPV vaccination at ages 9 to 10 years. Data from 30 studies published from 2014 to 2024 were summarized in a narrative review. I've included a breakdown of key findings and study features for each article included in the backup slides for this presentation. These included 3 general types of studies. Within the retrospective cohort studies, HPV vaccine initiation at ages 9 to 10 years was associated with higher completion by age 13. This was a small proportion of initiators in all studies. There could have been meaningful differences between children initiating at ages 9 to 10 versus 11 to 12 years, or providers vaccinating at ages 9 to 10 versus those vaccinating at the routine age. Within QI intervention studies, findings show vaccination at age 9 was feasible, but not necessarily better due to lack of data directly comparing initiation at ages 9 to 10 versus 11 to 12. Due to the multifaceted approaches, contributions of the recommendation for initiating at ages 9 to 10 on increases in coverage is unclear, and vaccination at ages 9 to 10 may be acceptable to caregivers and providers. I would like to acknowledge my colleagues on the HPV team and in ISD for their contribution to this project. Thank you for your attention.
Thank you very much, Dr. Brewer. Dr. Stefanos and Dr. Brewer's presentations are now both open for questions or comments. Dr. Asturias?
Yes, and thank you so much not only for the working group, but the great presentations done by the staff. It has been 17 years since we started this program, and while we have tremendous improvements of coverage, especially in the last few years, we're still very distant from our goal and could prevent at least another 15,000 cases of cervical and esophageal cancer in young adults. So we also have learned tremendous lessons in the past almost 2 decades. I will say that waning immunity has not been shown despite of 10 years of follow-up data, and that, as we just heard, the early age of vaccination produces better immunogenicity, better completion of the 2-dose schedule, and provides probably less crowding of vaccines in one of the visits for teens and parents and providers. So during this meeting, I think as a ACIP, we made crucial decisions to enhance the protection of adults against significant diseases. Perhaps it's time in the very near future for ACIP to revisit this issue and shift from our can-be given approach to a more comprehensive recommendation that expands the routine age for HPV vaccination. This change will come at no additional cost to us while preventing suffering and saving many lives for many years ahead. So thank you.
Thank you. Dr. Schechter?
Thank you. Presentations were wonderful. And I had a question for Dr. Brewer. Was completion defined was it only in the 2-dose era, or were some of the completion studies for a 3-dose?
Yeah, thank you for that question. It was actually quite diverse in our studies, and so it depended study to study. Some completed, they defined completion by 2 doses if under a certain age when they received their first dose. So it really just depended on the study.
Dr. Lair?
Thank you for your presentations, and thank you for addressing these issues. I'm very glad we're moving forward with them. I have a recollection from a while ago that there is evidence that when you immunized at a younger age, the antibody levels were significantly higher, 9 compared to 18, and the clinical significance of that was never proven, but I'm just sort of wondering, is that information true, and is that clinically significant? Thank you.
I have a slide we can show. I don't know if you can bring my slides up, but yeah, I mean, very early on in the HPV vaccine development programs, it was known that vaccination of the younger age groups was higher. I mean, the geometric mean antibody titers and the concentrations were higher with younger age. And that was mainly comparing like 9 to 14-year-olds, comparing individuals vaccinated at older ages. And, you know, that is the reason why the non-inferiority immunobridging studies were conducted comparing 9 to 14-year-olds with 15 to 26-year-olds, because it was felt very certain that you could show non-inferiority. It's also well known that very low levels of antibody are protective, and so the difference in the level of antibody you would get at like 9 to 10 versus 11 to 12 are really not very important. There might be some small differences. I wanted to pull up that slide. I'll show you which slide it is. Hold on one second. It is slide 87. 87. This is from a publication. Yeah, this is from a publication 2007. This is really, I put it in here to show why age 9 to 14 was studied for 2 doses, because it was known that antibody response is higher in the younger age group, and it would be feasible to show non-inferiority that what FDA required for this indication. But here you can see, this is showing the GMTs from age 9 through 23 for all 4 types in the quadrivalent vaccine. And you can see there's a slight difference between the titers at 9 to 10 versus 11 to 12, but not very much. But again, no one thinks that these small levels of difference are very important. I mean, if we really thought these were important, we'd be using the bivalent vaccine, which does create much higher antibody titers than the quadrivalent vaccine because of the adjuvant. So I think the argument that you get higher titers at 9 to 10 versus 11 to 12 is not a reason to be vaccinating at 9 to 10.
Thank you.
Ms. Moser?
Thank you. I just want to provide a few observations to think about a little bit of a different perspective here. We already approved this vaccine for use as young as 9 years of age, so we're not really changing a recommendation. But I think before we would change the wording, that we need to think about the fact that that has implications in and of itself, potentially. I would want the work group to please look at parental values related to this change, as well as the provider values, more than just the couple of studies that we were able to see, because I'm not sure how many parents necessarily want their kids to get this vaccine at 9, and we know that we've had an issue with hesitancy around this vaccine when it first came out. So I would just want to think about that. I would also want to consider keeping the HPV vaccine as part of the adolescent platform. I understand that some people don't want several vaccines at once, but we also know that when the HPV vaccine is presented as part of the adolescent platform and it's not othered in that presentation in terms of the discussion, that there's better uptake. And when I looked at the NIS 23 data, which I looked at it a little bit differently than it was presented here, what you see over time is that we're still increasing coverage as we go through the different years. So if you look at 13 years of age, there's about 45 to 53% coverage amongst the different groups of years. But when you look at the 15-year-olds, we're looking at a 60 to 65% coverage. So we're already having some indication that the kids are getting vaccinated. The completion rates are improving over time and as the kids age. So I think we need to look at those completion studies really carefully, because it was like 2% of kids that we were looking at in a lot of those related to 9 years of age. And some of those studies were, at least to my interpretation, they were evaluating completion at 13. So we might be seeing what looks like an actual increase in completion rates when really what we're just doing is giving more time for more visits. So, you know, I think there are some data that it could go, you know, that may prove that not to be the case, but I just think we need to be really careful about just changing the wording when we already can do what we're trying to accomplish, so we don't confuse people and have more pushback from parents.
So I have a question. Were there any intervention studies where the sole difference was the age of routine offering of the vaccine?
What is your question? Like in besides all the other interventions?
Correct, where there was a comprehensive quality improvement process undertaken, but in some practices where the same things were being done, but in some practices the target was vaccination beginning at 9, and in other practices the target was beginning at 11 to 12.
Thanks for the clarification. The answer is no, there wasn't any control in any of these quality improvement intervention studies, which is another limitation to the findings.
Dr. Brewer?
Yeah, yeah, there's a lot going on in this conversation. I just want to say that those are some amazing presentations, very timely, really helpful to add some specificity in a compact way to the conversation. There's the study by Christensen that addresses your question, Melinda, and they've put an asterisk on it that it supposedly had manipulated only age, but it really probably had many other undisclosed comments. So the construct validity of the manipulated variable here is not really clear. So I think that's one of the really important take-home is that a lot of the excitement that has been shared by activists and advocates about age 9 is based on trials that are comparing lots of things to lots of, so there's, you do 4 quality improvement things, one of which is age 9. Now, it doesn't mean that it wouldn't work if you did a proper trial, and we're going to hear about that, of course, but yeah, that's to be established. Then, of course, there's the observational work, which has some of the limitations that Charlotte was alluding to, but I think one of the main ones is that it's showing that it's really focusing on if you start at this earlier age, what does completion look like? And that completion argument becomes moot if we move to 1 dose. So the sort of the solidity of that argument is those data kind of goes away as well. So we're in a bit of a data-free zone. Which is disappointing. But there are other interesting data coming out. For example, there's a paper that was published by Dr. Zalaji and Dr. Kemp, and I think one or the other are going to present at some point. And they found that they found a few interesting things, but that it was it may actually make some of the discussions easier because sex doesn't come up, and then also that kids may not be quite ready, so just the sort of routine changes in approach may be an important thing to go through. I'll say from my interviews and the work we've done in this area, it's also this issue of a crowded platform with a lot else going on. So there are data suggesting that there are real implementation challenges here, including that 28% of providers won't provide more than 2 vaccines at a visit. And so HPV vaccine is often the one that gets crowded out. There's a lot more other issues. So these data, I think, are the right data, summarized in a really helpful way by Dr. Brewer. Thank you. The other Dr. Brewer, yeah. But I think there are still really important implementation issues that ACIP will have to wrestle with.
Are there other questions or comments from the committee? Dr. Schechter.
I'm sorry, just a follow-up to Dr. Lair's question. Is there any information about durability? If you're starting at the higher titer, does that have any at a younger age? Does that have any implications for durability or time to fall, either in the pace of waning or the time to get to any implications on durability, I guess?
I'm not aware of any data, and as you know, the very high efficacy in the large clinical trials were done in that, the right part here in 15 to 26-year-olds where you do see the lower titers. So we know that the very high efficacy has been seen in the young adults, and we know that from the follow it's been done, and that's been mainly done by follow-up of women who are in the clinical trials that are in the Nordic cancer registries, and they've been able to follow those out through 16 years. There's no waning. So, there's no waning in that age group. I can't tell you if it's better in the younger, but we know that there's no really waning that's been detected in young adults that are getting vaccinated. So I don't think that there'd be any, we can't dissect out whether or not 9 to 10 is going to be better than 11 to 12 for those reasons. That's why we've been really focusing on the programmatic aspects of 9 to 10 rather than these other aspects that you're asking about. And so our review of the literature was really focusing on the programmatic issues that people have raised as being advantages.
And then as completion has changed from 3 to 2 and possibly 1, which metric is the right metric in terms of is initiation completion, or how to think about the goals?
Is that a question or a statement?
I'm just puzzled and thinking out loud, I guess.
Yeah. I mean, I think that initiation is important. Yeah. I'm not saying it's more important, but it is very important. Yeah.
Dr. Middleman, did you want to make a comment?
Yes, thank you so much. It's Amy Middleman from SAM. I love this conversation. I appreciated the presentation so much. I do want to start off saying we've been trying, it's been actually recommended that kids have wellness visits annually for a very long time. I don't think the immunization platform created that, but it certainly created an expectation among providers, parents, patients as a touch point for not only immunizations, but other anticipatory guidance for all. Immunization platforms have been established for decades for infants and children, and they're well ingrained in pediatric practice, and no one really questions the need for the 2, 4, 6 month, et cetera, where actually more vaccines are administered at one time. And these immunization platforms haven't really had time to gel. So, immunization rates in adolescents are not the same yet as they are in children, but there are other issues at play for adolescents than there are for babies. I don't think there are any studies yet to determine the independent influence of platforms, but the VFC program that was established in 1994 obviously helped boost immunization rates. But I will say within just a few years of platform's creation in 1996, HEDIS measures, which tracked primarily insured persons at that time, tracked really significant increases in adolescent immunizations. And immunization rates are also subject to fewer healthcare provider visits in the older age group, while we put greater self-efficacy and input into the process from the adolescents themselves. But I do want to emphasize that we know adolescent platforms support immunizations. Studies have shown that in states with requirements for some routinely recommended vaccines, rates of other vaccines also rise, indicating that grouping vaccine recommendations really helps improve uptake. Fewer visits needed by adolescents for recommended vaccines improves completion of immunizations, and parents consistently report preferring fewer visits rather than more clinic visits. A recent survey conducted by the Unity Consortium showed that 3 out of 4 parents of teens and of teens themselves are comfortable receiving 2 or more vaccines at a given visit. Unity's parent advisors acknowledge the difficulty of getting adolescents to healthcare provider visits, especially as adolescents get older. So these platforms become really important touch points for families and providers. Given the totality of experience, I urge caution in deconstructing immunization platform infrastructure that has been developed using evidence when the risk is lower immunization rates among a traditionally vulnerable population. I actually love the idea of expanding, and I actually propose that we support primary preventive care at as many touch points as needed for our youth. Thank you for allowing me to comment.
Thank you, Dr. Middleman. Any final comments from the committee? I don't see any. Dr. Laird.
I guess I'd like to offer a different perspective. I don't see the immunization platform at 11 to 12 as particularly useful. And so as a practicing physician, I simply, and this is different than it was 20 years ago when there weren't regular well child checks, when I didn't have to do forms for kids needing to go to school every year, every 2 years. And so I think that there is a difference than it was 20 years ago. And so I would say that I can offer the vaccines at 9, I can offer the vaccines at 10 or 11 or 12. There are some state requirements that I'm running into. I don't see the adolescent platform as particularly useful for me as a practicing physician in a family practice. So that would be my perspective. Thank you.
Thank you. Would you like to move on to Dr. DeSisto?
Good afternoon. I will briefly review the next steps for both of our work groups' policy questions. Regarding the number of doses in the recommended HPV vaccination series, we have started the grade process and are planning for a full ETR framework. At the February ACIP meeting, we plan to share additional data from the trials and studies of interest, modeling data, and part of the ETR. Regarding the wording of the age for routine HPV vaccination, our work group has reviewed related literature, which you just heard summarized by Dr. Brewer. Because this is a minor wording change to the recommendation and not a change to the recommended age, we are not using grade and are planning for a modified ETR, which will only include selected domains. At the February ACIP meeting, we plan to share part of the ETR. We are planning to bring both of our policy questions for an ACIP vote at the same meeting, but not at the February meeting. Thank you for your time this afternoon. And at this time, we're happy to take questions if time allows.
We do have a few minutes if there's additional questions or comments from the committee. Dr. Laird.
So to answer your question on the screen, I would go back to people who should actually not receive 1 dose for whatever reason. Like Dr. Cambauge said, people who have immunosuppression, people who have been sexually abused. If there are certain categories that we should know about who should not be in this category of getting 1, I'd like to make sure that's very clearly delineated. Thank you.
Thank you.
I don't see any other hands up. So I think we will conclude the HPV session. Thank you very much to the team. And we will move on to our next topic, which is CMV vaccine. And I believe Dr. Jameson will be making that presentation on behalf of the CMV vaccine work group.
Great, thank you. I'm very excited to introduce our newly formed cytomegalovirus vaccines work group. Next slide. Cytomegalovirus, or CMV, is a ubiquitous beta herpes virus. CMV is the most common infectious cause of neurodevelopmental disabilities in children. Although not all congenitally infected children will be affected, it's estimated that annually about 4,000 children will have congenital CMV disease in the United States. In persons with immune suppression, such as solid organ and stem cell transplant recipients, and people with cancer or HIV, CMV causes substantial morbidity and mortality. In 1999, the Institute of Medicine, now the National Academy of Medicine, identified a CMV vaccine as the highest priority for development in the 21st century. This is because a vaccine has the potential to reduce the costs and human suffering caused by congenital CMV disease. However, to date, no CMV vaccine has been licensed. Next slide. So there have been several CMV vaccine candidates, and a few are highlighted here. CMV vaccine development started in the 1970s. Earlier vaccine candidates were studied in phase 1 and phase 2 trials among transplant recipients and among CMV-negative females. However, these vaccine candidates did not progress to phase 3 trials due to insufficient efficacy. Next slide. So more recently, 2 vaccine candidates progressed to phase 3. One trial was conducted among transplant recipients, but the vaccine did not achieve efficacy for the primary endpoints. Next slide. The other phase 3 trial is ongoing. It will assess the efficacy of an mRNA CMV vaccine candidate among females 16 to 40 years of age, and results are expected next year. Next slide. Next slide. All right. So in preparation for potential licensure of a CMV vaccine in the near future, ACIP is convening this CMV vaccines work group. So over the next 2 years, the work group will review the epidemiology of CMV and congenital CMV infection and disease and identify potential target populations for vaccination. The work group will also identify areas where additional data are needed to inform CMV vaccine policy recommendations, review safety, immunogenicity, and efficacy data for CMV vaccine candidates, and develop vaccine policy options that ACIP may consider for recommendation. Next slide. So I am delighted to be the work group chair and delighted to work with Dr. Tatiana Lanzieri and Dr. David Sugarman as the CDC co-leads for this work group. And we are finalizing the work group members, and we'll announce them shortly. Thank you very much. Oh, let me say one more thing, sorry. I forgot I had one more slide. We plan to hold our first work group meeting next month and tentatively plan to present to the full ACIP on the burden of CMV and congenital CMV disease infection during our next meeting, February 2025. I think that concludes my slides. Next slide. Yes, thank you.
Thank you, Dr. Jamieson. Are there any questions for Dr. Jamieson? Well, this is it's Dr. Shaw.
Yeah, this is great. It's a real cause. I hope it works out. I think one of the obstacles in the field, as I understand it, has been difficulties in coming up with immunologic correlates of protection, where I think our traditional use of neutralizing antibodies and other circumstances for CMV seems to be actually having a inverse correlation with the likelihood of maternal transmission and so forth. So other antibody functions or non-neutralizing antibody functions seem to be more important. So hopefully the work group will hold the trialists from manufacturers their feet to the fire for things like antibody-dependent cellular phagocytosis and other things that are relevant.
Thank you, Dr. Shaw. Dr. Asturias?
I think this is fantastic news for the pediatric community and certainly for pregnant women. And this is an issue that I think is that I'm grateful that ACIP is taking on as a future candidates are sort of moving forward, but also because there is an incredible amount of work that AAP has been doing in making people aware of CMV, which I think now we're having many patients that not only are struggling with what's the therapy available. This is an infection that produces tremendous disability in children. I think it's important for us to take on, so congratulations.
Dr. Chu?
So thank you, Dr. Jameson, for that introduction. I just wanted to emphasize how important CMV is in this very young population, and hope that, particularly with you as the work group lead, that we get some data in pregnant persons about potential use of this vaccine, because what I don't want to do is end up with another one of those, we have no data on safety in pregnancy, therefore wait until after pregnancy to get this vaccine. So thank you.
Okay, I think that's everyone. So thank you very much, Dr. Jameson. That's very exciting, and we're all looking forward to hearing about the work of the work group as it progresses. Our final presentation is on Mpox, and Dr. Rao.
Great, thank you so much. So there are two clades or types of monkeypox virus, or MPXV. Most people are familiar with the global clade 2 outbreak that began during 2022 and continues to cause roughly 56 cases per week in the United States. But similar to clade 2, there's clade 1, MPXV, and it's known for decades to be endemic in certain countries in Africa too. It's endemic in the Democratic Republic of the Congo, or DRC, the Central African Republic, Republic of Congo, Cameroon, and Gabon. The most number of human cases are reported each year from DRC, which is shown here in the largest country that is highlighted in green. MPXV transmission, regardless of clade, can be via exposure to infected wildlife. It's a zoonotic infection. Person-to-person spread, that includes skin-to-skin contact, including intimate or sexual contact. Direct contact with respiratory secretions, example via kissing. Oops. And direct contact with contaminated objects, example, shared towels and bedding. So none of this is new. This is the way that MPXV transmission has always occurred. But there's been a clade 1 outbreak in DRC. So even though cases there are, always occur and are commonly recognized, there's been an issue since 2023. There's been an outbreak, and this has been concerning because it's involving a higher number of suspected cases than previous years, and the laboratory-confirmed cases have been identified in provinces that previously had not reported cases. So these are very concerning issues. There's at least 2 concurrent outbreaks. There's clade 1A that is occurring primarily in the western part of the country, in the Equator province. And there's also clade 1B, which is occurring mostly in Sud Kivu, which is the eastern part of DRC. Clade 1A historically has a mortality rate that's reported somewhere between 1.4% and 11%, so quite a large range. However, there's been an NIH trial in DRC that it's involved a therapeutic that indicates that via routine supportive care, the mortality rate might actually have been just 1.7% in that study. Now, clade 1B seems to cause less severe disease than clade 1A, and in DRC, there's been a steady mortality rate of less than 1%. You can see here, though, that the more red the provinces are on this map, the more cases, suspect cases, that there have been in DRC. So the clade 1A cases are believed to be spreading by several ways. There's from animals to people. There's a high proportion of suspect cases occurring in children that are believed to be from animals to children. There's also human-to-human spread in crowded households. Both adults and children are impacted by those. And then sexual contact, regardless of people's sexual orientation and gender identity, and that's occurring in adults. And this is really important because unlike the global clade 2 outbreak that disproportionately impacted men who have sex with men, this outbreak seems to be involving people regardless of their sexual orientation and gender identity. And then clade 1B, which again is the eastern part of the country, lower mortality rate, seems to result in milder illness. Sexual contact comprises the largest proportion of those cases. Clade 1A has only been detected in endemic countries outside of DRC, and so that's Central African Republic and Republic of the Congo. Clade 1B, however, is the one that has been detected in other countries that are not endemic. There's been sustained spread in Burundi, Uganda, and Rwanda, and you can see from the image on the right that these are countries that are very close to DRC and very close to the eastern part of DRC, where a lot of clade 1B cases are occurring. And then there's also some travel-associated cases that do not involve sustained spread in Kenya, Thailand, Sweden, India, and as recently as yesterday, we heard about a case in Germany. To non-endemic countries, it's clade 1B, and so as I mentioned, these are often associated with sex. This can be sex, transactional sex, for example, with sex workers while travelers are visiting countries with sustained transmission, so not necessarily DRC, but other countries as well, the countries with sustained spread. And then secondary spread has been limited, if at all, in several non-endemic countries, such as Thailand, Sweden, and India, for example. And I can also say that in Germany, they just, I think overnight, published in their EpiMonitor. It's published in German, but we were able to understand it, and it appears that their case also seems to be an individual who recently traveled to one of these countries, to Rwanda, I think, and reported heterosexual sexual encounter while visiting that country, and that the country themselves in that report indicated that they don't expect secondary cases, but I guess we'll continue to monitor. But there are those countries, those non-endemic countries that don't have secondary spread, but there are other countries where there is secondary spread, such as Burundi, and those cases are believed to be associated with close household contact to an adult with Mpox. I just want to caution that these findings, all of these conclusions we're making, this is just based on what we know at this time. This is an evolving situation, and the information or the situation can change, but this is what we believe at this time. Now, this next slide illustrates the cases and deaths in countries with clade-specific testing. So in DRC here, you can see that the number of cases in 2024 was 6,962 cases, and this is laboratory confirmed cases. There's greater than 33,000 suspected cases reported in DRC this year, and many of the deaths have been reported among those individuals, and those are the individuals who are also often children. But as far as confirmed cases go, 6,962, and of those, 25 have been deaths. It's difficult to know what's happening among those cases that are not confirmed. What we can say is that many things can be confused with Mpox, and it's possible, particularly because we know that there have been concurrent outbreaks of measles and chickenpox in the same areas, that there's something else at play. We also know from our historical experience in DRC that patients can be co-infected with chickenpox and Mpox, for example, or measles and Mpox. And some of us have seen some of the rashes, some of the photographs of the rashes. It really is very challenging to definitively say what these infections are. Among laboratory confirmed cases, though, the 20 deaths that I reported, and then the Central African Republic and Republic of Congo is where there are additional clade 1A cases. Again, these are endemic countries. There was one death in the Central African Republic this year. And then the remaining countries are ones that, the non-endemic countries that it has clade 1b, so the less severe subclade seems to have spread to. You can see that Burundi has the greatest number of cases. And I also want to point out, though, that Burundi has a lot of cases in children, and despite that, there are no deaths reported from Burundi at this time. There is one death reported from Kenya. There is an investigation that's ongoing there, but what we understand is that this individual may have had multiple underlying health conditions, and that it's possible that those underlying health conditions is what led to the patient's death rather than Mpox. So moving on to what's happening in the US. So there are no clade 1 cases in the United States. We are monitoring this, and we have been performing active surveillance via clade-specific testing of a high proportion of MPXV positive specimens, including those tested in commercial laboratories. This has been going on since at least late 2023 that we've ramped up that process, but this EpiCurve just shows March or April starting from there, and we have not identified any cases at this time. What we believe is that the risk is considered low for U.S. travelers, and we issued a Health Alert Network advisory a few weeks ago to recommend that clinicians provide pre-travel counseling about risk reduction strategies to any patients who are traveling to the affected countries. And as a reminder, this is avoiding close contact with people sick with signs and symptoms of Mpox, including skin or genital lesions, avoiding contact with contaminated materials used by people who are sick, such as clothing or bedding, and then vaccination, irrespective of sexual orientation and gender identity, for certain travelers to those countries who anticipate any of the following. So sex with a new partner, sex at a commercial sex venue, such as a sex club or bathhouse, sex in exchange for money, goods, or other trade, sex in association with a large public event, such as a rave, party, or festival. It's only for these individuals that we are saying that if they anticipate these behaviors while they are traveling, that they can be vaccinated. There's also work that's being done at CDC to evaluate the risk to the general U.S. population, and at this time, that risk is considered low. There's modeling that's been done, and that has found that even in an extreme scenario where the household secondary attack risk of 30% is double, if it's an attack risk of 30%, which is double the previously considered worst case scenario, that most simulated outbreaks would be small. 66% had less than or equal to 5 cases, and 73% had less than or equal to 10 cases. Most simulated outbreaks also in these models had minimal spread between households. 72% affected less than or equal to 3 households. Modeling suggests that even with extremely high secondary attack risk, household clusters, including cases in children, would most likely involve 10 or fewer MPXV clade 1 cases with limited spread between households. So based on what we know today and the current characteristics of viral spread, we don't expect children to be heavily impacted if clade 1 is diagnosed domestically. But again, this is just based on the information that we have at this time, and we'll update accordingly. We're continuing to work on this. So what are CDC and other U.S. government partners doing? We've had an activation at CDC and also interagency activations across the U.S. government since the beginning of this calendar year. Internationally, U.S. government partners, including CDC, are providing technical assistance and funding to DRC's Ministry of Health. We're working with USAID, which is obviously part of the U.S. government, but USAID, WHO, International Organization for Migration, African Field Epidemiology Network, and other partner teams on the ground to help manage outbreaks. We're collaborating with public health officials in several countries bordering DRC to assess needs and provide support for outbreak preparedness, and donating 1 million doses of JYNNEOS vaccine and $500 million in support. And then domestically, we're increasing capacity to rapidly detect, contain, and manage clade 1 cases should they occur domestically, increasing capacity to detect cases of clade 1 and clade 2 Mpox through existing surveillance systems, including wastewater testing in communities across the United States and in select airports. We're coordinating with state, tribal, local, and territorial public health departments to provide clinical, diagnostic, and other guidance, and raising awareness as much as we can through COCA calls, through CDC IDSA calls, through HANS, Health Alert Network advisories, and other communications and updates. So in summary, there is a high number of suspected clade 1 Mpox cases in DRC. About 20% of those are laboratory confirmed. Travel-associated spread of clade 1b to some countries has been occurring, but those cases are milder than those associated with clade 1a and predominantly associated with sex, example transactional sex, with subsequent spread to others, example children, likely via household contact. The risk to U.S. travelers at this time, we believe is low, but counseling and vaccination should be provided to travelers. It is possible that we could have a case in the U.S. similar to other countries, but we believe that the impact to persons in the United States, including children, will be low. So moving on to ACIP, we had already planned to reform the ACIP work group, even regardless of whether this outbreak was going on. We are planning to do so as soon as next month, and Dr. Bonnie Maldonado is our work group chair. She's taken over for Dr. Pablo Sanchez. Dr. Faisal Minhaj is the work group lead, and I will be supporting him, so I've passed the reins on to Dr. Minhaj. The work group charge is to review several things. So it's sort of a continuation of all of the discussions and the votes that we've had over the last couple years. There is new data available from an NIH study about the use of Jynneos in persons 12 to 17 years of age that will be finalized come January. There is preliminary data that's been presented at conferences and that sort of thing, but the work group will begin discussing it. It'll be finalized in January, and we'll consider, based on what that data shows, bringing to ACIP a vote about the use of Jynneos in persons 12 to 17 years of age at risk for Mpox during Mpox outbreaks, and that includes the global clade 2b outbreak. And if that happens, we plan on presenting that during the February ACIP vote, so we present the terms of reference and any data that would be needed, and perhaps the vote could happen as soon as the February 2025 ACIP meeting. And then on a separate note, we did have votes about the use of Jynneos in adults, and all of that information has been updated on the CDC website. We know that the vaccine is commercially available right now, and that most insurance companies are covering it for individuals who are at risk for Mpox. We are planning the publication of the consolidated ACIP recommendations for adults and for persons 12 years of age to 12 to 17 years of age, depending on what is decided during the February meeting, into one consolidated MMWR, just to make things clearer, easier, everything in one place. But the information is available on our websites. And I think that is my last slide. I'm happy to take any questions.
Thank you, Dr. Rao. Dr. Maldonado.
Yeah, I want to thank Dr. Rao for her work on the Mpox working group before I came on board as chair, and look forward to working with her. And just wanted to mention that there was an update at ID Week last week from the Minister of Health, who was there, in the DR Congo Minister of Health, who was at the meeting, to just discuss the situation. And I think one of the issues, and I've been working with the International Pediatric Association as well, because at least the total, it appears, and again, as we know, a lot of the cases aren't confirmed, but it appears that up to 70% of the cases are occurring in children under 15. And so there's still a lot to be worked out in terms of what the transmission risks are and how to prevent disease locally. But the other issue and there's a couple of things I just want to mention to this group, and I know it's getting late, but one is that there are 2 tecovirimat trials going on right now, and the antiviral, and one of them is called STOMP, and that is really through NIAID, and that's ongoing. But another trial that was started and completed in DR Congo was the PALM-007 trial of tecovirimat, and it was stopped due to because there was no demonstrated efficacy of tecovirimat against the clade 1 strain. So that trial has been ended. And the other issue I wanted to bring up is that one of the things that has been happening with the providers in Central Africa right now, are they're trying to get more information out to local providers because lack of infrastructure in terms of just diagnosing kids and trying to provide infection control in their clinical settings, as well as trying to prevent disease, household transmission in homes. And one of the issues has been, in addition to what Dr. Rao brought up around the diagnosis of the lesions, is that the skin color, we need more pictures, so we're trying to get more pictures to get out into the local community clinical practices so they can understand what the disease looks like. But just to give you an idea, in the PALM-7 study, which was primarily done, well, in all age groups, but also in kids, the average number of lesions for the patients in the studies was about almost 500. So it's quite extensive disease. Doesn't, at least the ones that were enrolled did not look like your average chickenpox or measles cases, but there could be co-infections potentially. So lots going on there. But certainly the vaccine issues will be interesting. And the final thing that we heard is that so far they've gotten about 250,000 doses of the vaccine on board, but just the infrastructure to even administer has been quite difficult. So there's still a long way to go there.
Thank you. Dr. Jamieson?
Thanks for an excellent presentation, and thank you to the CDC team for all your work on this. Can we go back to slide 11? So in looking, as you're thinking about updating and consolidating the U.S. recommendations, it seems like the second bullet and then the second, third, and fourth sub-bullets are mostly covered with the first bullet, sex with a new partner, and I wondered whether it would be less stigmatizing not to have bullets 2, 3, and 4 in the same way that they're represented right now.
Yeah, no, thank you for that comment. We'll certainly take that back and discuss with our STD prevention colleagues. They're definitely engaged in this work. I'll also just clarify that our ACIP recommendations will not include this current outbreak recommendation. So this falls under the umbrella of the ACIP outbreak recommendation that was passed last year, which basically allows for CDC for every unique outbreak that comes up to develop specific guidance about who should be vaccinated. So we'd certainly update our CDC website, but it wouldn't be part of the published ACIP recommendations. But thanks for the comment. Absolutely, we'll take that back.
Other comments or questions for Dr. Rao?
Hi. Do you anticipate, along with the primary goal of responding to the outbreak, do you expect any information from that response to inform use of vaccine in children in the United States, or use of GNOs younger than age 12?
Yeah, I think we'll hear a little bit more about that during the February ACIP meeting. So there's perhaps preliminary data, and I know our NIH colleague might not be available, but there's data. Or I don't know if Bavarian Nordic actually wants to speak to this. They are doing a lot of studies in other countries involving the younger kids as young as 2 years of age. And I think that they also have seen the data that our NIH colleagues are from that study, and they have ideas about whether the data in 12 to 17-year-olds can be kind of what it says about the use of the vaccine in younger children. So it sounds like there's going to be more data. I'll also ask our branch chief to comment.
Hi, I'm Christy Hudson. I'm the chief of the Poxvirus and Rabies branch. I just wanted to add on to what Bonnie said, which is nice to meet you in person, Bonnie. So I think, we are still learning a lot about this virus with the current outbreak. It's one that the country, unfortunately, has been dealing with for a very long time. Through the PALM study, I think it was very evident when basic items were provided, even food and fluids, and making sure that they have antibiotics if needed to prevent secondary infections. It went a long way. And so that case fatality rate of 1.7% was much lower than what we've seen historically. And discussing with NIH colleagues, and I think that they're still working on getting all of this data analyzed, it's not clear how much they were able to test for underlying health conditions. They did point out that some people did have severe disease, and certainly number of lesion contributes to morbidity, but some individuals needed no additional sort of interactions or support. So it really was a wide range. So understanding how that would translate to the U.S., I think, is really important. And then as Uga mentioned, 1B is consistently less than 1%, both in DRC and Burundi, including in children. When you look at the confirmed cases, because as Uga pointed out, a lot of this is based on suspect, which you really have to take that with a very big grain of salt. Confirmed cases, the children are in that very young age group for the most part, where we know they're with a household member that's providing care to them. So we really think the household transmission is contributing to many of those childhood illnesses through this virus. So just to say we're learning a lot, but there's still a lot more to learn and a lot of new data still coming out. So thank you.
I see no more requests to make comments or ask questions. So with that, I believe the committee will have completed its business for the October meeting. On behalf of Dr. Talbot, whose voice is still not doing so well, I'd like to thank all of our speakers and all of the ACIP members and the ex officio members and liaison organization representatives for their work yesterday and today, so that the committee has been able to provide timely and transparent information to the public about vaccines, as well as the decision-making process. Absent any further business, Dr. Talbot, would you like to adjourn the meeting?
We are adjourned. Edwin and Bonnie. He's still talking. They got the shepherd too.